warm good morning to one and all. I'm Tinumol Chako.
And I'm Chinnu Thomas.
On behalf of Amida Eye Care and Ophthalmic Society of Pathanamthitta, we welcome you all to NETHRAM 2024, the third annual CME of Ophthalmic Society of Pathanamthitta. We have gathered here to learn from the leading experts in our field, share knowledge, and discuss advancements in comprehensive ophthalmology. The organizing team is thrilled to host NETHRAM 2024, especially as this year's event is unique with its exciting film festival, PG case presentation, and hands-on sessions in the phaco wet lamp. Today, we have an array of dynamic speakers who will delve into various topics in comprehensive ophthalmology. Without further ado, let's meet the experts who will enlighten us with their profound knowledge and insights. Our first section is Navigating Cataract Conundrum. We are lucky to have the renowned experts as chairpersons today for panel discussion. We request the panelists to come forward and be seated. The chairperson of this session, Dr. Bastin, Chairman, Scientific Committee, KSOS, Consultant at Nethra Eye Care, Irnyalakuda. Dr. Sabida S., Director of Sabida Eye Care, Pathanamthitta, KSOS representative from Pathanamthitta. And the moderator of the session, Dr. Asha Susan Kuruvalla, Assistant Professor, Kottayam Medical College. Over to you, Dr. Asha.
Good morning, everyone. Without further delay, let's move on to our scientific programs of the day. Our first speaker of the day is Dr. Minu Martin. There would only be seldom few here who wouldn't know Minu, sir. I remember listening to Sir's talks in awe as a resident 10 years back. His long list of awards, achievements, and accolades are so inspiring for the young minds here to look up to and try and emulate. Minu, sir, is currently consultant in cataract and refractive surgery at Chaitanya Eye Hospital, Trivandrum. Everyone, please join me in welcoming Dr. Minu Martin, sir, to the dais.
Okay, at the outset, let me thank Pathanamthitta Ophthalmic Association, Rachel Madam, Rani who is my actually classmate, and Priyanka. So I have been given this topic of SICS, optimizing outcomes and current indications. Sorry for my poor voice. I am recovering from sinusitis, but I don't know how it affects throat. Anyway, thanks to my teachers at Aravind for teaching me all that I know now. So SICS and phacoemulsification, they are two effective and elegant methods of performing cataract surgery. So the difference, according to me, is only cost, but mostly all the rest are same. And so no more discussion or comparison with phaco. So I would say, when I'm talking about SICS, talk only about SICS and do good SICS and get good outcomes. Don't compare. There's no point in comparing, telling that you're going close to phaco and all those things. No need. See, in India, this is the kind of population which we are dealing with, 144 crores. So a vast majority, they earn less than 400, 500 rupees a day. And so the cost factor is a major factor in India. So current indication is, one is this. But don't think it's a cheap surgery or the quality is not good. So we have to aim for best qualities. And there are two types of surgeons now. SICS surgeon, basically doing only SICS. Phaco surgeons, only phaco surgeons, only phaco. And the majority is SICS surgeons. And there are some who can do both. So basically, people who can do both can choose wisely. And the safest procedure for that particular cataract for best outcomes. But the others can do only, all cases they will do phaco, or all cases they will do SICS. So in SICS, how to optimize outcomes, because cataract surgery is becoming a more of a refractive surgery, we all know that. So Napoleon Bonaparte, he said one must change one's tactics every 10 years if you wish to maintain superiority. So we need to keep changing as and when technology develops and changing your technique to get best results. I have talked to a Chinese doctor who has converted from phaco to SICS and asking why. He says peer pressure. Surrounding Chinese doctors are doing SICS at low cost and people are not coming to me. I am doing phaco, my charges are more. So there are different indications for people to do SICS, but if you are doing SICS, we need to modify on most of these techniques which are already there to get the best outcomes. So there is nothing that you cannot do topical SICS. But the only thing is, don't make patients struggle and you should not struggle. It should be comfortable for both. So touching conjunctiva, I feel always there is some kind of a feeling patient will have. So it is better always to give at least a subconjunctival or a subtenons to make the patient comfortable. But if you give adequate anesthesia topically or put a pledget dipped in xylocaine there, it actually does well and the patient can move. And the only thing is, don't hesitate to give a block. If patient is very uncooperative or you think you will face problems during the case, complicated case, please do give block which you are comfortable with. Peribulbar is always fine because of the needle issue. Subtenons is the best now. So if you practice subtenons, it is so easy and clean. And there will be some bleeding, but then otherwise it is the best. So then comes the question of incision. So incision is the main comparison and main differentiating factor. Incision is big. So you get more astigmatism, you get infection, doesn't close, all the complications of a large incision. So I would stress 40% of your stress should go to creating a perfect SIC, sclerocorneal tunnel. So if we maintain the right depth, use sharp instruments, do not use blunt ones at all. They are cheap. They do not cost too much. And maintain the same level and depth. That is very, very crucial. And create a clear 1.5 to 1.75 at least clear corneal entry. And maintain that entry when you enter. And size it according to the size of the nucleus. In phaco, it's a fixed size. But here, the size should be according to the size of your nucleus because you want your endothelium to remain almost same number and the cornea to be clear post-op. You don't want to squeeze a large nucleus through a small tunnel and have a white cornea. So entering is also very important. So I'll measure and show you that this is 6 millimeters, this vertical one, the horizontal one, and a vertical back cut. We can make it a frown also, straight one, anything, whichever one. But then all this should be made in the same depth and the cut should be perfect so that it doesn't sag or it doesn't become irregular. And here also the third plane which you create should be maintained almost till the end of your tunnel, which should not touch on the clear cornea. Stop a little short. And I can measure and show you that it is 8 millimeters inside. For such a huge nucleus, you need that. But then later on I will show you that this will close perfectly without any problem and it will not induce. Remember, going temporarily will help you in reducing most of the against the rule astigmatism which many patients have now. And avoid all these. Try to avoid all these in your, be perfect with your sclerocorneal tunnel. That is one modification which you should make. And if you have very anterior ones, thin ones, short ones, and then small one for this huge nucleus, it will break. In the people call it technique and all those, but I consider this as a complication, as doing a small tunnel and trying to squeeze out large things. You can do a division or bisection and all those, but I don't suggest all those in the initial stages because it is very difficult to maintain corneal clarity if you do too much of manipulation there. See, paracentesis, we consider it as a very simple procedure, but then please don't use very blunt ones. If you use, this is what happens. The globe turns away from you and you won't get the right size. And the sizing is also important because if you make it too large, see the pressure from the side and the lifting up of the upper lip of the paracentesis, and it's too large and keeps leaking. And visco keeps going out and you lose your rhexis, especially if you're in an initial stage. And again, in intumescent cataracts and very shallow chambers, if you use blunt instruments and if the tip goes too much inside, you can cut the anterior capsule, and here you can see after staining, already the anterior capsule was cut. But then, because it was not very widely cut, I could manage to retrieve it please use sodium hyaluronate. It is cheaply available. Indian companies make it. So use that to flatten the lens surface and do a capsular rhexis. But then later sometimes it will tear off so much that you will lose a rhexis. Rhexis is very, very important to have the premium IOLs in the capsular bag and to have an effective lens position which is best for the eye. So please do stain the capsule if you have very dense cataracts, and sizing of the rhexis is for the size of the nucleus. Again, if you make a very small 4.5 millimeter rhexis, you can get away with it in phaco. But then here it has to be large enough, because when it goes more mature, the elasticity goes down, it becomes more brittle, and it can snap open when you try to deliver a huge nucleus through that. So there are different complications which you can face. Please use, my suggestion is to use dye whenever required. Use high molecular weight viscoelastic, flatten it, and then avoid the peripheral extension of the capsule, and have a rhexis as whenever possible. But then even if you lose a rhexis, like in this case, we have lost it at multiple areas. Still, in phaco it is very dangerous to proceed, but here there is no danger at all. Only thing is, don't pressurize that tear too much. Just gently rotate the nucleus out and you can complete the case very comfortably, even after a can opener or losing a capsular rhexis. So in nucleus management, as I said before, the hard nucleus has to come out, and if you are scared to do a full hydrodissection in a huge nucleus, you need not. Only see the nucleus rising up and then decompress it and lift it up with your Sinskey hook, which should go to the equator rather than scratching through the cortex, which is superficial. And at the equator, a good hold and push and a pull up. It comes out and rotate out. Use a lot of viscoelastic. See, Viscoat is not, or Oro Visc and other combinations are available, Indian ones, which are equally good. Use them once so that your cornea remains clear. And even delivery part, whichever you are comfortable with the adequate kind of your tunnel, with a lot of viscoelastic below and above the nucleus, irrigating vectis or sandwich or blue menthol or whichever. But do not touch the endothelium and bring it to the tunnel and then ease it out with the technique you are comfortable with. So in IOL implantation, cortex aspiration, the great advantage is that you can go through a paracentesis and aspirate subincisional. Because of large incision and it is posterior, it is difficult to go under the sclerocorneal tunnel. So use your side port to aspirate, and any premium lens can be implanted. See, I just use the folder to injector so that the IOL doesn't touch on the outer surface. You actually need not fold also, you can place it. But make sure you have gone into the bag. These kind of single pieces have to be in the bag, foldable ones. So retract and see, because of a large rhexis, you have to make sure that it's in the bag. So cosmesis and recovery, if I have to show you, at the end I told you that this kind of a tunnel, after hydrating, it will close completely. Make sure it doesn't leak on pressure from somewhere away other than the incision, and it should be tight. And then rolling this conjunctiva nicely flat and then laying on the tunnel, keep it there for 5-10 seconds. It will stick very well. And then use a little bit of cautery, because these are the things which will affect the patient's recovery, and they will be complaining of foreign body sensation and all those. So, and when cutting conjunctiva also, please do not let the bleed come so much into the conjunctiva and make it huge, and it will look red and people will say redness and all. So try to cauterize nicely and make it look clean and flatten it off. I take a long time now keeping the conjunctiva back. Previously we just used to just hold and leave. So don't char the conjunctiva and keep it very gently folded out so that it heals smoothly and the patient doesn't have this one. So the recovery, my post-op advice for phaco and SIC is the same. Medication is the same, head bath time is the same, activity part is all the same. If you have done perfectly the incision like this and closed it very well. I'll go to 3 difficult situations where we need to make adjustments. In small pupil, I would want to have a large pupil size so that I can do a large rhexis for the type of nucleus. So I would stretch and see if it stretches. In a rigid pupil it will stretch, but if in a flaccid one or IFIS it will not stretch. You will have to use dilating devices. I will show you. And if it is adequate to create a 6 mm or a 5.5 according to your nucleus, then well and good. Otherwise, I would definitely, this is a huge nucleus. This is a very hard, huge nucleus. So in this case, I would definitely use a iris hook. So first incision goes sub flap, under the flap, superficial flap of the main incision. So that will bring the iris away. Whatever instrumentation you are using through the tunnel, it will bring the iris off, and iris will be at a lower level. And it should be a stab, it should be at the limbus, not onto the clear cornea. So I can make a large rhexis now. Now I can prolapse out one pole easily. After I have taken out one hook so that the iris is free there and you have more maneuvering space. So see the internal lip and the opening which I have created. Make it adequate for the size of the nucleus which I want to insist again and again. And then make the nucleus free, prolapse it out, and after prolapsing partly, you can always remove the side hooks also. And then otherwise, sometimes if you are gone through the cornea, iris will be lifted up and you will have a crowded chamber. The nucleus, such a huge nucleus may not come. And ideally, you need not bring whole nucleus into the anterior chamber. If it rotates well and 180 degrees out, it will automatically come when you hold it with the vectus. And then it comes out, then I put back the iris hooks so that I can see again. After nucleus delivery, many times pupil constricts, and if your pupil constricts, you can use intracameral drugs which are available now. If not, put the hooks back on and see the rhexis margin and then implant the IOL. Don't blindly implant these kind of IOLs into the anterior chamber or in the posterior chamber, not knowing where it is going. So it has to be into the capsular bag. And see, the conjunctival closure has to be very important. Subluxation, I feel it's a very dicey question. If you are good at phaco, I would do phaco because retaining the bag steady and doing a phaco is easier. But still in SICS you can do. Only thing is I'll get the capsular tension ring in first. Everything is gentle, and then the hydro has to be done. You have to bring out the nucleus, so rhexis has to be large. But then still you have to have a rhexis good enough to place the lens in the bag. So iris hooks on the rhexis margin and the CTR also goes in. For lack of time I'll go through fast. And prolapse very gently, very gently. After hydrodissection, do a little more and more of hydrodissection. Take the nucleus out very gently. All movements have to be, don't hyperinflate the anterior chamber and all those things. And then the IOL can be placed inside the capsular bag. And last one is posterior polar. Again, I would personal preference will be phaco. But if you have to do an SICS, we can do by doing gentle hydrodelineation at different quadrants so that you get a cleavage plane. Hydrodelineation very carefully, because if you do a hydrodelineation very intensely, you will get an inadvertent hydrodissection wave also. And without rotating, this is the technique. Picking up, supporting with another instrument and just lifting and bringing it into the anterior chamber. So this will be the technique of not rotating, because if you rotate, it is going to shear open the weak posterior capsule where sometimes there may be a deficiency, sometimes it will be a weak area. And deliver it out without inflating. Deliver it out with visco or your sandwich technique. So be proud to be an SICS surgeon. I call it MSISCS because it is a manual, small incision, sutureless cataract surgery. It is small, it is not small. It is large when compared to phaco. But then it is smaller than an ECC. That's why we used to call it. So sutureless is the point. That is the catchword. And finally, patient wants clear vision. They will not ask you whether you use Centurion or whatever. Some people may. But then if they have clear vision, that's it. And so this is in April this year in ASARS, where I was training in the wet lab for SICS, for American surgeons. So don't consider yourself to be anything below phaco or anything doing SICS. Their wet lab runs full. And it is sold out very much early. So they want to learn scleral tunnel and how to convert into SICS. Thank you very much.
We'll have the discussions towards the end of the session. So may I call the next speaker?
Our next speaker for the day is Dr. Arup Chakravarti, a person who needs no introduction whatsoever. He's a senior consultant and director of Chakravarti Eye Care Center in Trivandrum. And as you can see, any attempt on trying to summarize the umpteen number of achievements and awards would be futile or rather foolish from my part. But please, there is enough and more on the screen to be inspired. I happened to come across that he wrote and edited international books on posterior capsular rent management. And I think it's a privilege to listen to him in person about the topic. Everyone, please join me in welcoming Dr. Arup sir to the stage.
Good morning, friends, and thanks to PATHANAMTHITTA Ophthalmic Association for giving me an opportunity to make this presentation on my work. See, it is a myth that a posterior capsular rent is a death sentence for the eye, or a posterior, or it is the end of the road for the patient. On if the surgeon does it very frequently, it is end of the road for the surgeon. So what I like to tell you is Posterior capsular rent is part and parcel of every cataract surgeon's career. It is just a question of, trying to reduce the incidence of posterior capsular rent in your routine in your surgeries, or if it is already there, reduce the damage control. Don't let the PC rent to enlarge. If vitreous hasn't been there, don't don't cause vitreous disturbance, so on and so forth. So nothing financial here in my presentation. So I'm going to show you. So basically, I'm going to show you a case of posterior polar cataract with a pre-existing posterior capsular rent and how that was managed. So basically, two different complex situations will be shown. This video is not edited intraoperatively. All the intraoperative manipulations are shown. So it runs for about 9.54 minutes. And if you want to have a comprehensive knowledge review on PCRN, I have done a review article in IG a couple of years back. So it's a very comprehensive article, and then a book on posterior capsular rent. So that will give you overall, every concept on posterior capsular rent. So here it is just a case-based presentation. So posterior polar cataract, and the posterior capsule is already open. How it was open, I'll show you towards the end of my presentation. So I usually take up these patients under topical anesthesia, under peribulbar. When the villi already had a complication. Make sure the rexis is about 4.5 to 5 millimeters in size, not too small, and should not be more than 5 millimeters, because if you have to use optic capture of if there's a PCRN, then the rexis size really matters. So once the rexis is done, then I do not use any hydro steps, just a hydro-free dissection, and I've been using this technique from the mid-90s, and it has worked wonderfully well in my hands. So take a cyclodialysis spatula, work from the two side ports and from the main incision, and separate the anterior capsule from the underlying structures. So now is you start phacoemulsification. So what I do is this patient is in his mid-60s. It is a choppable cataract. It's not a very neither here nor there kind of cataract. So I create a vertical wall. All right. So I sculpt as deep as possible in the central area. So my game plan is from the nasal side of the capsular bag, I would like to decompress the capsular bag, take out the nucleus and epinucleus and all that. So then you can't rotate the nucleus, so you have to use a chopping technique. And I've been more than 25 years I have used this technique, the what that I'm showing you. So here this is actually, it doesn't progress in a copybook fashion. Sometimes when you do the oblique chopping, you see the chop line develop from the periphery, comes to the center. It doesn't happen. So you might have to alter your phaco parameters. Sometimes the vacuum may have to become brought down, the phaco power may have to be brought down, so on and so forth. So it all depends upon the given case that you're doing. So then once the chopping did not happen, according to my plan, one particular zone, then I go to another area and then start chopping it, and then it is sort of it is successful. I don't really have to take out a full big quadrant all the time. So I just want to remove the lens matter from the distal area of the capsular bag, that is the nasal and supranasal and infranasal area. So now the nucleus has started rotating. See, this is what happens once the fluidics have been going on in the anterior chamber for quite some time. The fluid waves, it finds its way under the capsule, and it makes the nucleus ambulatory. It becomes mobile. So it is very different from performing a hydrodissection, where where there is definitely posterior fluid wave and the posterior pressure going up. So it is sort of a cheap and flip technique. You try to rotate the nucleus and take out the nuclear ball, try to aspirate it, and then ultimately when you're left with a small plate, then bring it into the anterior chamber. So here, it is actually a play of viscal OVDs. When I do the rexis, I always use the Indian version of the Hilon 5, that is 2.4%. So you would have seen that my rexis are going on very slowly because it's difficult to drag, very rapidly when you're using 2.4% Hilon 5. And again here, I will be totally dependent upon viscoat. Now, no financial interest, but there's no alternative to this. So there's a PC rent here, and before I remove my phaco handpiece, I injected viscoat from the side port. In many of these situations, in many of these cases, you may have to use a lot of vials of viscoat. So that is should not be a matter of concern. So OVD, further viscoat is injected. Then I'm trying to assess subincisionally. There are a lot of cortex, and it can be easily removed by manual irrigation aspiration. And peripherally, there's not much of cortex, so I'd like to visco displace the cortex, bring it into a more accessible area, so that I don't have to linger on, in the peripheral areas and more fluidics. And there's always a chance. This patient is in his mid-60s. Vitreous is not is expected to be, the fluidic, and AV antravitreous phase may rupture. So when I do a bimanual irrigation aspiration, and that is the way to go for compromised situations where you have a PC rent or a zonular dialysis. See, my irrigation port, it doesn't go beyond a certain level, certain extent, because we don't want the irrigation to be hitting the area of the PC rent. Engage the cortical material, drag it to the center. Don't try to aspirate it in the capsular fornix area itself, and then you aspirate it. So now again I have to switch my instruments. So before I remove my irrigating handpiece, again viscoat goes into the eye. At all stages, just ensure that anterior chamber is not made shallow. You do not want the posterior capsule to be trampolining forwards. So that is basically the secret. Just have a deep normally deep anterior chamber in all these cases. So again, I have switched the instruments, and irrigation is kept away from the area of the zone of the PC rent. Here is the PC rent. It is a spindle-shaped defect here, going from end to end, from limbus to limbus. So cortex is removed as much as possible. And here, when you come towards the end of cortex removal, bimanual irrigation aspiration will not work, because it has aspiration port is 0.3 millimeters in diameter. So it is very difficult to get an occlusion, and when you have just wisps of residual lens fibers, cortical fibers. So in that case, you have to go for a dry aspiration, and that's what I'm going to show you. So here, sometimes you have to change the cannula size. Normally, if we use the same 24 or 26 gauge cannula, it may not, the cortex, you may not be able to build up enough, force to build up to pull out the cortex. So sometimes, as you see here, it is a little, I think, a 20 gauge cannula. You have to be very careful. Make sure that adequate OVD has been injected, posterior capsule has been pushed behind. You are walking away at a much anterior plane than the posterior capsule, and then try to remove the residual cortex. And in these sort of cases where I have a PC end, vitreous, this is not yet disturbed, I will not be very finicky about removing the last chunks or last bits of peripheral cortex. Ideally, yes, your surgery should have should end up with total removal of the lens matter other than the capsule. But then sometimes too much of good may be actually worse. So you just leave it at that. And then all these manipulations have been happening, and clinically I know that I have not had any. I'm not experiencing any posterior capsular issue, any vitreous issue here. But before pushing the lens, I would definitely like to confirm the presence or absence of vitreous in the anterior chamber. So this is the margins of the rent. You see, it's a huge posterior capsular rent. So injected diluted triamcinolone acetonide suspension, 4%. So I usually dilute it, 1:10, and then then once you irrigate it, you realize that there is absolutely no vitreous. Was that a 9-minute bell? Yeah. Okay. So so you try to. There's no vitreous present. So it is just that it is the OVD plus the mixture of the triamcinolone acetonide. So I have changed my intraocular lens plan here. Instead of using a single-piece hydrophilic phobic acrylic lens, which could have been used definitely, but here I am planning to use a sensor lens. So it has to be kept in the sulcus. Sensor is a wonderful lens. It has large diameter, optic is 6 millimeter, opti-edge design. It doesn't have, it's a non-aspheric lens. So once the peripheral capsule has been compressed, the leading haptic, try to put it in front of the anterior capsule. Sometimes if you are not very sure whether you are going into the bag, you shouldn't go into the bag with the leading haptic. You can also deliver this leading haptic into the anterior chamber, and subsequently it can be tucked in the ciliary sulcus. So here I was sure that the leading haptic is going into the ciliary sulcus, and same thing. And once the optic has been placed inside the eye, the anterior chamber is further deepened, and this is my technique of tackling the trailing haptic. I don't dial the trailing haptic, because whenever you dial, you use a lot of forces, and some of these forces will have an effect after some time. And by that time, you have realized that the PC rent size has enlarged, and so on and so forth. If it's a zonular dialysis, the size is enlarged. So I just tuck the haptic under the iris, and then this is the optic capture. the optic is touched sequentially at multiple points, so the optic is pushed behind the anterior capsule. And though there was no posterior capsular rent, but whenever there is a PC rent, there was no vitreous disturbance. Whenever I encounter PC rent, I prefer not to do too much of stromal hydration. I just put a suture into the main incision. Sometimes where a lot of vitrectomy has been done and paracentesis also is leaky, I would not even hesitate to suture the paracentesis. So that is the end of the surgery. So this is how I started off, and this is day one. And patient has been followed up for a long period of time. Patient has done well. Now this is actually the fellow eye. Fellow eye came to me, referred to me. A patient just walked into my office, recentered intraocular lens. Okay, so I took up the patient. I might have shown the videos earlier. So lens has been recentered, and the eye that I operated actually was the posterior polar cataract. So it is important for you to realize that what is a posterior polar cataract. Sometimes we tend to overdiagnose it, and you unnecessarily extend the duration of the surgery, make the surgery messy. You shouldn't do that, and then take appropriate measures so that you end up with an outcome very similar to that of an uncomplicated case. Thank you very much for your kind attention.
Thank you, sir. That was a brilliant presentation. And we move on to the last talk of this session. Over to you.
I'm honored and overjoyed at the opportunity to introduce our next speaker, as I was privileged to have taken my phaco training under him. And rarely a day goes by where I don't remember him or his wise surgical tips, or other pearls which he effortlessly seemed to embed in his students. He's none other than our dear Verghese Joseph, sir. He could aptly be called a pan-ophthalmologist, if it really is a word. And if not, he would be the right person for which the term can be coined. As from lids to retina and everything in between, he's a master. Let it be squint, keratoplasty, the most complicated of cataract surgeries, to vitreoretinal surgery, Verghese sir is an expert. And it has been an honor to meet sir again and to moderate one of his sessions. Over to you, sir.
Good morning, everybody. I'll be briefly talking on toric IOLs. Postoperative residual astigmatism after IOL implantation can lead to glare, halos, and suboptimal visual outcome. Studies have shown that 30 to 39% of patients coming for cataract surgery has astigmatism more than one diopters, and 3 to 4% have even up to 3 diopters. That is, almost 1/3 of the patients have significant astigmatism, and this needs to be addressed effectively. There are many methods to correct astigmatism, but with newer designs and better materials, the toric IOLs give a more predictable outcome. Historical perspective, Shimizu from Japan in 1992 devised the first toric IOL made from PMMA and Prolene. First FDA approved toric IOL was from Star Surgicals. It was made from silicone material, and the problem with these were that they were prone to rotation. Alconi in 2006 introduced a single piece open loop hydrophilic IOL with good rotational stability. It had a square design also. It has 3 dots on the optic haptic junction to align the IOL to the correct axis, and it could correct astigmatism up to 6 diopters. The toricity of the any toric IOL is on the posterior surface. The axis along the line is the flatter axis of the toric. Senile cataract with regular astigmatism is the most common indication, but it's very, very effective in post PKP and in after radial keratotomy and in corneal scars. It should not be done in patients with irregular astigmatism and compromised back support. Poor dilatation is a relative contraindication. These are the lenses available: monofocal toric, EDOF toric, and multifocal toric. Toric IOL implantation requires meticulous preoperative planning. First, you calculate the spherical IOL power, then calculate the total astigmatism, add to it the surgically induced astigmatism. It is seen that for every 2.5 mm incision, it induces a 1 diopter astigmatism. And use the IOL calculator to get the model of the IOL. We use the Barrett toric formula. or a revised AGESIS or a revised technique formulas. These incorporate surgically induced astigmatism, posterior corneal curvature, and effective lens position. Use the Barrett suit formula and the IOL master. In our case, IOL master 700 gives most of the values. Topographers are used to cross-check the astigmatism. This is what you get. You get a printout of the calculations. It gives you the surgeon's name, patient's name. Then you get the which eye to be operated, the model of the IOL, the alignment, the power of the IOL, this is the alignment, and also the residual astigmatism. Accurate alignment of toric IOL is a prerequisite to get successful outcomes. For this, you have to mark the 3, 6, and 9 o'clock position on the cornea. This can be done either manually or digital markers. There are many methods of manual marking. There is the bubble marker, the pendulum marker, or you can mark on the slit lamp. For manual marking under topical anesthesia, we use the Nugent-Solomon bubble marker. Markings are enhanced with a 26 gauge needle and a marking pen. This is how you mark after that. And then you use a gauge degree and a meridian marker to align on the table. Many digital markers are available. Zeiss Callisto, Alcon Varion, and iTrace, and other intraoperative wavefront aberrometry methods are there. Image-guided systems captures a preoperative reference image followed by intraoperative image registration. So it uses the scleral blood vessels and limbus and iris details as landmarks. This is a Callisto system which we use. This is the reference image from the IOL Master 700, which is registered with the Callisto eye, and this is the data. The images are transferred via a DICOM, or you can use a pen drive also. Data is used to create overlays in the eyepiece, and it is efficient and reduce residual astigmatism. This is the first window. You select the eye, then you mark the main incision and the side ports. You will then project the size of the rexis you want, and after the rexis and surgery, you have to align the IOL. This is the blue line is the alignment mark, which is at this one is 17 degrees, and this yellow line is the reference mark at 0-180. Surgical tips other than good phaco, surgical tips include preferable use of cohesive viscoelastics which can be removed easily, and at the end of the surgery apply gentle pressure on the IOL so that IOL is seated in the posterior part of the bag. Then leave the eye soft at the end of the surgery. Do not hyperinflate the bag. Hyperinflation lead to IOL rotation. Post-op residual astigmatism can come from measurement errors, marking errors, or a posterior corneal astigmatism if the lens is malpositioned or it rotates. We did a retrospective analysis of from 2020 to 2024, 232 eyes of 179 patients, one eye operated in 126 and both eyes in 53, 72 male and 107 females. Post-operative pre-op cylinder, post-op uncorrected visual acuity and residual cylinder at 1 month post-op were calculated. Patients with retinal comorbidities and irregular astigmatism were excluded. Manual markings were done in 97 cases only, 97 cases, and digital marking in 135 eyes using the Callisto. So the chart shows the pre-op astigmatism. 188 eyes or 81% had cylinder 1 to 3 diopters, 8 had up to 6 diopters, and 3 eyes had more than 6. These were the IOLs we used during our surgery. This is the one surgery done yesterday. After initial markings, you dial the lens in position, clear the viscoelastic under the lens, and then position the under the blue line. This is another case where the IOL is the markings are done and a plate haptic IOL is toric IOL is implanted and rotated into position. Then this is a multifocal IOL. Positioned at 85 degrees. This is under manual markings. We do manual markings in all cases. This is positioned at 180 degrees. Again under Callisto. IOL positioned at 51 degrees. This is an EDOF IOL. You can see the markings, the BBT IOL. So, post-op, 136 eyes had 6x6 vision, and 200 out of the 205 eyes, 88% had vision 6/9 or better. 159 or 68% eyes did not have any cylindrical power. 88% had 0.5 or less residual astigmatism, and these people were spectacle independent. 7 eyes, high residual astigmatism was seen in patients with pre-op high cylinders. Mean astigmatism reduced from 2.2088 to 0.1157. 135 eyes were done under Callisto, and 97 eyes were done with manual markings, and the results were comparable between the manual marking and the digital marking. So we did 23 multifocals during this period. All were 6x6 N8 in unaided visual acuity. There were 100% spectacle independence. We have not studied the IOL rotation. We have not had any major surprises after toric surgery. We have not done any secondary IOL manipulation. So in conclusion, toric IOLs can effectively correct astigmatism and improve quality of vision and spectacle independence. Future technological advances may refine the outcomes of the toric IOLs further. Thank you.
Hello. Thank you, sir, for that explaining the tips and tricks about the toric IOLs. Now, we had 3 talks and the discussion is open now. So we start with Dr. Minu Mathan's topic regarding the SICS.
Dr. Minu, you routinely put the sutures with a large nucleus, whether it is needed in the SICS for the beginners to start with suture, whether I read some article, it reduced the astigmatism or the better for initially, for new beginners.
The point is, it is supposed to be a sutureless surgery. So it doesn't mean that you should not put sutures. So I will put sutures if it is not stopping, leak doesn't stop, that's all. So trying to correct astigmatism with suture won't work. I don't think it will work. But if it is leaking after hydrating, and if you make sure that the plane of the dissection is all flattened out, sometimes there will be some scleral flaps which may be lifting up, or some cortex epinucleus tissue sitting there. All that you clean out and then hydrate the other port and wait for some time also and see, and press on the nasal side and see. If it still leaks, I will definitely put 2 sutures.
Dr. Menu, in SICS,
Hello.
will you plan a toric IOL or you adjust with the incision or pre-planned LRI or anything like that?
I believe that if well constructed and consistently, if you do good temporal incisions, it doesn't induce more than 0.5 to 0.75. So titrate your K readings post-op and find out how much you're inducing, and then see if it is too much. Then go change your location, because I don't change location according to the astigmatism in SICS, because I am comfortable doing in one particular location. So if I continue doing that, and if my astigmatism is 0.75 to 0.5 only, then we can always plan toric IOLs with that, if you have consistent surgically induced astigmatism. But nowadays, surgically induced astigmatism is less in phaco, but then still in your SICS, we should see at least 30 to 40 cases and see the pre and post K and find out whether you are inducing too much, and then plan. Then you will get good outcomes.
Thank you, Minu. And another important thing we have to know is, like, as Dr. Minu has mentioned, choosing the right instrument is a very key part, even though we will miss sometimes. So you should select a sharp instrument while doing the incision and also the paracentesis. And equally important is you have to hold the eye properly to get the desired effect. Am I correct, Dr. Minu? So fixating the globe is a very key factor for getting the good incision. Thank you. And moving on to Arup sir's talk. Sir has clearly mentioned about the PC rent management and what you have to do when you get a PC rent. And the key point we have to notice is you have to break the irrigation and aspiration when you get a PC rent. Even if you do a coaxial aspiration, you move to the bimanual. And you can ask questions right now.
Arup sir, you had shown a video where you put the 3-piece IOL after the PC rent. So you mentioned something like that leading haptic, it can even go into the AC and then later tuck it in. Did I get you right?
Yeah, yeah.
So that is allowed?
Yeah.
Like we were initially, I think we were made to do it like it has to go into the sulcus directly, the leading haptic, and the trailing one we can tuck it.
Yeah.
Nothing
No,
like that?
I mean, see, you are right. But if you are sure that your leading haptic is going into the sulcus, there's absolutely no problem. But there will be certain situations where you have a large nasal PC rent. Okay, pupil has come down. So you create some space by injecting OVD between the iris and the anterior capsule, but still you are not sure whether the leading, you can't see it, there's no visibility, pupil is small. So how are you sure that you're going to, your leading haptic has really gone into the sulcus? The fellow eye operated elsewhere had the same problem, what you mentioned, the surgeon would have thought the leading haptic is going into the sulcus, but it went through the PC rent.
Right.
Okay. So there are few things I wanted to mention because of paucity of time I just couldn't mention. Like, see, incision is usually 2.4 millimeter for phaco. But once you use the sensor lens, it requires a 2.8 to 3 millimeter incision. So that has to be enlarged. Otherwise, what happens when you try to struggle to put the lens in, if incision is small size, then all the OVD comes out and AC becomes shallow. And if there's no vitreous disturbance, the vitreous face will break. Even if you've done vitrectomy, more vitreous will come out. So just to ease, the process of IOL insertion, the incision size may have to be extended to 2.8 to 3 millimeters, and I always put in a suture. So basically, it is what is wrong in putting the lens in the anterior chamber, inferior haptic, because you're not going to keep it permanently. It is just that we are going to do a stepwise insertion in the sulcus, and then exactly when you tuck the haptic, when you compress the haptic, bring it under the pupil, under the iris, and then you gently scrape the back surface of the iris and release the haptic. So you are 100% sure, 200% sure that haptic is going into the ciliary sulcus, and it is not going through the PC rent. But it is up to the surgeon. I'm not telling this is the only technique and all the other techniques are rubbish. No. So there are different ways of skinning the cat and different ways of managing a complication. Complication management is, there's nothing dogmatic about it. There are certain basic principles, yes. But if you follow those basic principles, and after that, it is all, you're on your own.
So might as well put it in the AC and then tuck it in. Isn't that, or is there a downside to that? Is it difficult, or like, why don't we do it routinely like that?
Routinely not necessary, isn't it? Routinely, I mean, see, if you are visible, if you are able to visualize the anterior capsule, and then the leading haptic is clearing the PC rent area. Okay, then you just release it. But why go for an additional maneuver?
Okay.
This is an additional maneuver. So there are certain things, like for example, I have used thousands of sensor lenses. So grabbing the haptic, the leading haptic or the trailing haptic with the Sinskey hook or the Kuglen hook, sometimes in the hands of the beginner can result in DM detachment in the periphery. All right, it can even result in iridodialysis. There may be hyphema. So there is a way of doing it. So I didn't go into all those details how to manipulate the haptic, the leading haptic or the trailing haptic. So it is a stepwise surgery to ensure that you end up with the desired post-operative outcome.
Thank you.
The basic thing you're talking about here is the skill set. Those are completely different. Like when you tuck the leading haptic in and you're either dialing or, gently tucking in using a McPherson or a lens holder, that skill set is entirely different from when you're placing it on the AC, like Sir said, and then, using a hook or a dialer to tuck it in, because it will slip unless you hold at the right position, like it will detach the membrane. So the skill sets are entirely different. So like he said, you should do what you're comfortable.
The skill set is something which is, Swapna, I do not know what you do. If you have 3 millimeter people, you have a large nasal rent, and a very small people, the very small people. How can you, you want to see and do what you're doing, right? You don't want to have, like for the previous patient, it is a very senior surgeon, another surgeon. I don't think that surgeon lacks in the skill set. It is just that, the surgeon wasn't aware that it was going the right thing. I have done both, and I've been doing for almost 35 years cataract surgery. So this is the best way to ensure that you do everything under direct vision. And then, of course, you do the tap test. Make sure that the haptic is, the lens is recoiling back. There's, it doesn't stay decentered when you do the Osher's tap test, all that. So you have to be familiar with everything.
Can I add one point? Last week, one of my trainees had a large PC rent, and rexus was also quite large, and the pupil had come down. So pupil, if it is small than your rexus, I will always put iris hooks and dilate the pupil, and then only implant an IOL. And then implanting into the anterior chamber, for me, I implanted the IOL, and the first haptic went into the sulcus over the rexus margin, but it was another Indian made 3-piece lens, which doesn't open that very controlled manner. Sometimes it suddenly opens up and my haptic and optic went into the vitreous through this one. So our trailing haptic was outside, so I could catch it and bring it up. So sometimes it may be, so it depends on the situation. If it is a too large a rexus and too large a piece and no piece is seen anywhere, and when the haptic and the optic opens up, sometimes the leading haptic which you have placed already in the sulcus may slip down into the vitreous also. So watch everything, keep looking at things, and keep dilated the areas where you want to see, and then proceed according to the particular thing. So placing into the anterior chamber in this one would have been maybe easier, but then again manipulating the haptic from the angle area, it is slightly dicey. Like what you said, you can touch on the root of the iris, the DM detachment, and all those things are there.
Yeah, I had another video where the leading haptic, I thought went into the sulcus, a similar situation. People are small, large PC rent. And then when I was pushing the trailing haptic, then I realized that the lens is going deeper and deeper. So then I brought the haptic out and kept it in front of the iris, and then did the needful. Patient has done extremely well.
Sir, one more question. In case of PCR, even with dry aspiration, if the rent is expanding and there is cortex inside, can we do anterior vitrectomy, place the IOL, and later after 2 weeks do a cortex wash? Is it advisable for the beginners?
No, if there's a vitreous in the anterior chamber, the first thing has to be anterior vitrectomy.
Yeah.
No manipulation should be done without removing the vitreous.
After anterior vitrectomy, can we go for IOL implantation without fully aspirating the cortex?
It depends upon how much cortex we are talking about. If it is just thin wisps in the peripheral areas, see, we don't want to leave behind too much of cortex. Two reasons. One is secondary glaucoma may happen. Second thing is uveitis may happen. All right, but if it is too little of cortex that is left behind, which would have normally removed in a routine case, but here you won't remove it because there's a PC rent. So there's no question of a patient developing a PCO. So you would only like to remove that much of cortex, which you feel would be safe without further endangering the residual posterior capsular defect.
So, what is your take on taking out the cortex with IA cut mode with the vitrector itself? Is that
I do that. That is my favorite technique. I did not do any vitrectomy. So basically, my phaco machine, when I have a PCRent, I switch over to the machine with a dual linear control. So I first is irrigation, and then when I go down is cutting, and then go to the right is aspiration. And if you reverse the foot pedal movement, you get irrigation, cutting, and then aspiration. So once the vitreous has been removed, then instead of again taking out the vitrector and replacing it with irrigation aspiration cannula, it takes some time. It doesn't take much time, but it is additional step. So I use the same vitrector, irrigation aspiration, and if it is too much of cortex that is coming up, a little bit of cutting and irrigation aspiration. So it makes it reach very fast.
the video you showed? I think it was.
There's no vitrectomy done. There's no need
no
to.
vitreous.
Yeah.
The vitreous wasn't disturbed.
Yeah,
I
yeah.
guess. So
That's what.
it was only the cortex.
Yes,
that you
yes.
took out.
It was just to make sure that there's no vitreous here.
Okay.
So whenever you have a PCRent or a suspicion of PCRent, triamcinolone acetylcholine is a must. Sometimes clinically you get a feel that your vitreous hasn't come, but many of these elderly patients may have fluid vitreous, and then some vitreous may come and you may not realize on the table, but you'll see on the day one, going up to the paracentesis or going up to the section. So in that case, no, you don't want to have a situation like that.
Okay, moving on to the last case about toric IOLs. Sir has clearly mentioned about the markings, the importance of markings before you put a toric IOL. So we have a system of making the patient to lie down flat after 1 hour after the surgery, because majority of the rotation after the toric implantation takes place in the first 1 hour. So will you do that, or what is your preferred practice?
No, we are doing mostly under topical, and even or we don't make them lie down. I have not encountered any serious problem after toric implantation.
So like any other monofocals, you send the patient during that time?
They go after 1 hour.
Okay.
I don't know about anybody has any other.
So any other difference in the opinion from the crowd? Is there any protocol for keeping the patient for 1 hour before you send him off after the cataract surgery, like toric IOLs?
There have been studies which have shown that maximum rotation happens within the first 1 hour.
Yes.
All right. So once I came across this study, I do the same thing for my patients. But then when I discuss this matter in the international fora, most of the surgeons disregard it. They just treat it like any other patient. But in my case, because there is a good study that has shown, I think it is from Korea or Japan, that most of the rotation happens within first 1 hour.
During the first hour.
Yeah.
So I just see the patient 2 hours later. So we make sure that we see the patient on the slit lamp and then make sure it is still on the same axis. So if the initial rotation happens in whatever reason, you would have left viscoelastic, it would be a large bag or whatever, then you can identify rotation on the before discharge itself. That is one thing. But lying down, this initially was being told, I also tried to do, but then actually it doesn't make a big difference at all.
But what sense does it make? Are you going to take the patient in again after 1 hour in case you feel that the thing is not, and then rotate, then again make him lie for 1 hour? Is that the protocol? Because
no, nothing like. We don't see the patient in the slit lamp, but we make sure that the patient with us at least for 1 hour after the surgery.
Okay, so and then you believe that it's stable.
Yes.
Okay. Yeah, because I think
that is not practical, no? Seeing the patient again after 1 hour. Maybe
he does.
You will see.
He
All
does.
the patients. So you keep the patient keeping dilated. After 2 hours, will it be dilated like that? Okay. Another thing is sometimes. So I am working with Callisto, so we have that markings. So what happens like towards the end of the surgery, sometimes one that marking on the lens will be within the 3 lines, and the other marking will be outside the 3 lines. Have you encountered such problems, and what will you do in such condition? Even though you keep the Purkinje images perfect, you will see that one marking is perfect and other marking is outside the reference mark. So which mark to consider?
So I have an incident in my mind when you say this. No? So I have seen a very, very prominent surgeon in this country do toric IOLs. So I went to observe him. That was long back. So he marks his cases on the, like they sit in the OT just before he goes in for surgery for the previous patient, marks them, and then he does the surgery, and then he takes the next patient inside and does it. So he has a Varion and he can align that way, or he, on the microscope that doesn't have a Varion, he just does it that way. So I have found that IOL rotation is very forgiving if it is to a very limited degree. Like he has excellent results, never less than 6 parts, because people tolerate a bit of astigmatism and they read well, or whatever the reason be. So like that little way of, I don't know whether it's going to result in a huge vision difference to the
what
patient.
I'm asking is on the table.
Yeah, so is that going to result in a huge vision difference to the patient?
No, nothing like that. One axis is enough. Yeah. Okay.
Dr. Arup Chakrabarti. Dr. Varghese Joseph. Dr. Bastin. Dr. Sabda S. And Dr. Asha Susan Kurula. Thank you for those insightful presentations and interesting discussion. Now, moving on to the next topic, eye-opening insights and innovations in ophthalmology. The panel for this session includes Dr. Rachel Jose, President of Ophthalmic Society of Pathanamthitta, Dr. Chaitanya R. Warrier, Pediatric Ophthalmologist at Chaitanya Eye Institute, and the moderator Dr. Jurmil, Secretary, Ophthalmic Society of Kottayam, and the Director at No Vision Eye Hospital, Mundakayam. Over to you, Dr. Jurmil.
Thank you for kind introduction. At the outset, I would like to congratulate the organizing team, Dr. Priyanka, Dr. Rani ma'am, and PATHANAMTHITTA Ophthalmic Society. It's my proud pleasure to be in my alma mater, our suite EMLC. So without wasting much time, we will quickly move to the our talks. So our first speaker of the day is Dr. Satish Thomas. Actually, sir does an introduction. He is a very renowned pediatric ophthalmologist. Yes, he has done his PG from the Sankar NETHRALAYA, Chennai, and then he has worked as a HOD at CMC, Ludhiana, and currently he is working as a head of the ophthalmology department at Believers Church Medical College. So he is going to give his pearls in squint management. So over to you, sir.
Good morning, everyone. So the topic allotted to me is pearls in squint, in a squint case. So rather than giving isolated pearls, I thought I'll fit it into approach to a squint case, how that helps us in making decisions in a squint case. So the main questions that we should keep in our mind when we see a squint case are these. Are we dealing with a pseudostrabismus or a true strabismus? Does the squint have any relation to vision? That is poor vision a cause of the squint or an effect of the squint? So we're dealing with whether we're dealing with a sensory strabismus or amblyopia in addition to squint. What is the level of binocular vision? Is it a comitant or an incomitant squint? What is the diagnosis? Often I find that we just leave it at a level of esotropia or exotropia. That's not enough if we want to manage it. And then what will be the management in the particular case? Is it optical, is it orthoptic, or is it surgical? So I'll be keeping it at a very basic level because I want to address the people who are not routinely doing strabismus in their practice. I know there are a few strabismologists in the audience and they'll find it very basic. So in evaluation, it is just like how we would evaluate any other case in ophthalmology, except that here the sensory state is an additional thing that we would want to pay attention to. And the important thing I want to highlight here is that we should evaluate the sensory state before assessing visual acuity. Because when visual acuity is being checked, then we would occlude one eye, and that would change the whole sensory status because it would cause disruption of fusion. In history, I won't go into the details of it, just to highlight that one thing I have put in red. Closure of one eye in bright sunlight is a symptom that can alert us to the possibility of intermittent divergent squint or intermittent exotropia. Because in a clinic, in a closed room, and if you're going to see the patient up close, you might miss intermittent exotropia. So you can remember that you should look for that. A FAT scan, just to introduce the term, is a play on CAT scan, family album tomography. So it's important sometimes that you will have to go back and look at the patient's family album at different cross sections of the patient's life to pick up something. And which eye deviates, again, important if you want. See, all these matters when you see very young children who cannot cooperate for visual acuity assessment objectively. And so if it is always one eye that deviates, then you can keep the suspicion of amblyopia there. And then when we come to examination, pseudostrabismus is something that in our outpatient clinic, we will have a lot of patients come to us with suspicion of strabismus, either from the parents or a lot of them get sent by the pediatricians. And again, one of the things that a lot of parents say is that in photographs, I think that, it is in photographs that I suspect that my child has a squint. So, see, like in this child, in the picture on your left, you would think that that child has an esotropia in the right eye. And similarly in the other one for the other eye. The problem here is that because of the broad nasal bridge and the epicanthic folds, you don't see the scleral show there when the face is slightly tilted. When it's absolutely straight, then you have a small scleral show there. But even then, you can still suspect that. So in photographs, the important thing is to not be deceived by the scleral show, but to look at the centration of the light reflex on the cornea. And so for that, on photographs, so I tell the parents, I routinely tell them, if you're looking at photograph, the important things in the photograph is that the face should be centered. Then don't look at the scleral show, but look at the cornea. And then when you look at the cornea, especially if you have a flash, look whether the light reflex is centered on the cornea. And as you can see here, it is absolutely centered on the cornea. But if Hirschberg is eccentric, it doesn't always mean that there is no squint. Or if Hirschberg is eccentric, it doesn't mean that it's always a true squint. You could have an angle kappa, and therefore it could still be a true squint. And so for that, we have to do a cover test, and I'll come to that later. It's important to always pay attention to the head posture because it can guide the presence of a squint. I'll not go into all these details here because the pearls I want to give are different. Sensory system evaluation becomes very important in a case of squint because, as I told you, the most important thing here is the binocular status rather than the cosmetic thing. So sensory system disruption is what we are most looking at in a case of squint. And these are the things that we would look at. What is the level of stereopsis? Is there diplopia? Is there suppression? Is there amblyopia? And what is the type of retinal correspondence? So various tests for stereopsis are there. And you can use any of that. The Lang has the advantage of the child not having to wear any spectacles. And so it's the cooperation is much better. So there are again various tests for binocular vision. I won't go into details of all this here. Visual acuity. So again want to drive home the point that sensory examination preferably should be done before visual acuity assessment. And then when we come to visual acuity assessment, in those who have nystagmus, the binocular vision will be a better judge of their actual vision than uniocular vision because of the manifest latent aspect of nystagmus. So it's good to measure visual acuity uniocularly and also binocularly there. Visual acuity in a case of strabismus or the pre-verbal children. For very small children, there are various methods of assessing their vision quantitatively, and preferential looking tests are very good for that. But again, and many of us don't have access to it. Even I don't have access to it in my present setup. This is something that I want to demonstrate here. The CSM method, the central, steady, and maintained method of fixation. This will help us pick up amblyopia in a pre-verbal child. Even if we do not know the quantitative or the objective amount of vision, we can still pick up whether there's a subjective reduced vision in one eye, which is amblyopia, by this method. This is what I'm doing there. Yeah.
Very good. Abhi ye. Very good. Ye. Very good. Ye. Very good. Ye. Very good. Ye.
Given a choice, this child always fixates with the left eye and not with the right eye. And the reason for that could be that the right eye has a lower vision. So esotropia here with right amblyopia would be my diagnosis there. So just this method of covering each eye and looking for the fixation in each eye can help you pick up amblyopia. Then we come to the motor evaluation. And Hirschberg corneal reflex is what most people, mostly do. But the problem with that is we would miss most of these squints. Because it measures only manifest squint, we would miss all the latent squints. Because it measures only in a non-accommodative state, we can miss accommodative esotropias. Because it doesn't evaluate for distance, you can miss an intermittent divergent squint, and it doesn't account for angle kappa. Therefore, cover test is something that we should be. So that's the best method of I'll just rush through. Here is another very important video showing the importance of cover tests. So this was a patient who had a closed head trauma following an RTA, and he was in coma initially in the neurosurgery ward. When he woke up, he complained of diplopia. And the residents who went and saw him in the ward saw that his extraocular movements are absolutely all right. Full extraocular movements. And the Hirschberg showed orthotropia. So even if you can see the cover test, it is showing orthophoria at the beginning. Now when you do it, the cover test at the different gazes, here you can see that there is an L over R. In the opposite gaze, you see there that it is an R over L. Right hyper, left hypo. In the down gaze, you can see that he has an esotropia. Up gaze, exotropia. So you can see that the cover test in each different gaze gives you a different result. In right head tilt, R over L. I hope you can appreciate that, R over L. And in the left gaze, it would be a L over R. So this is a classic case of bilateral superior oblique palsy. Unless you do a cover test, you will miss it. I think I will quickly finish with the last two slides. So when you are managing, try and have a clear diagnosis. As I told you, not just say esotropia or exotropia, but diagnose it whether it is accommodative esotropia or infantile esotropia. If not clear about the diagnosis, neuroimaging may be indicated. We must have a treatment goal. Why are we correcting the squint? Is it to restore binocular vision? Is it to take care of the diplopia? Is it to reduce the abnormal head posture? Or is it cosmetic or rehabilitative? And your management and the time of management, the mode of management would all vary depending upon your treatment goal. When to operate as early as possible if binocularity was there. And surgical plan, I'll finish with this slide. Sensory squints, just some pearls in the surgical plan. Sensory squints are better left in small esotropia, because if you try and make it orthophoric, then it will go off again into exo. Esotropia is better cosmetically than exotropia. Recess resect in one eye can induce incompetence and diplopia in extremes of gaze. Take into account ductions, versions, and incompetence when you're making a surgical plan. And if that is there, then you might undercorrect your, tone down your dosage. And R&R is preferred in an amblyopic or blind eye. And a resection will have a greater effect in an eye with recession than regular surgical dosage tables. So I think I'll stop here. Thank you all.
Unfortunately, you could not go into detail. I will do the discussion the last, after the two talks.
Thank you, sir, for your nice talk. Now, we'll quickly move to the next speaker. Next speaker is Dr. M.V. Francis, sir. Sir doesn't need any introduction. He is a very well-known faculty in neuro-ophthalmology. His area of interest in headache, and he has defined the migraine with and without aura. He has done a tremendous work in that field. He has so many international publications and award in his bucket. He is presently working as a consultant at Teresha Eye and Migraine Center, Cherthala. So we are sure that we are going to get new pearls in headache management. Over to you, sir.
Thank you. Thank you very much. Good morning, everyone. And thanks to Dr. Verghese, Dr. Amida, Dr. Priyanka, and PATHANAMTHITTA Ophthalmic Club for this invitation today. Now, headaches are very common in daily ophthalmic practice. As a symptom, anybody can treat headache. But when you try to diagnose them, they become very complex. They become mysterious. Why should they come to us? There are many reasons. But the most important reason is to rule out a refractive error, a spectacle problem. And how do we know that? we have this Bible of headache classification known as ICSD-3. And there is a diagnostic criteria there. 4 important statements. The first one, you have a headache patient sitting in front of you. You diagnose a refractive error, uncorrected or miscorrected. And the patient telling you, prolonged focusing aggravating my pain. And the third is, I discontinue focusing, my headache subsides. And you treat refractive error, no more headache. So this is an incomplete criteria. I have documented 5 additional features for these refractive origin headaches. One, you don't have to focus for a long time. Even brief focusing can aggravate or precipitate headache. It is not just aggravation as the ICSD-3 tells us. Second, discontinue focusing, it might not subside. In some patients, it can continue to progress and culminate in a migraine attack. And third, there is an incubation period. You focus for a long time, no headache at that time, headache can come sometime later. And the fifth is, even if there is no focusing correlation, any headache, any primary headache can subside if you give them a right refractive correction. Now, second is phoreatropia. Again, same recommendations. You have a headache patient with phoreatropia and prolonged focusing, aggravating pain. ICSD never tells, precipitating pain. And with 1 out of 3 symptoms, blurring of vision, diplopia, or difficulty focusing from near to far or vice versa. You close one eye, headache decreases. You correct phoreatropia, no more headache. Now there is this convergence insufficiency. This is, my own criteria, no criteria anywhere. You get convergence insufficiency when they focus near for a long time with 1 out of 5 symptoms. Blurring, diplopia, letters running together, difficulty focusing, and dizziness. I have documented all these. And you stop focusing, these symptoms subside. You treat convergence insufficiency, no more headache. Now comes convergent spasm, the spasm headache. Mostly psychogenic. 99% are psychogenic, just 1% only organic, like Chiari malformation, myasthenia gravis, brainstem lesions, metabolic encephalopathy. You may see once in a lifetime. And more of stress, anxiety, and malingering. And how do they present? They present with acute onset frontal headache, diplopia, and blurring. Diplopia secondary to esotropia, blurring secondary to accommodative spasm. And how do you diagnose? There are 4 important signs. And the most important is you patch one eye, esotropia subsides. Second, there is a mismatch between manifest refraction and cycloplegic refraction. Third, there is variable esotropia. And fourth is meiosis during esotropia. Now the simple summary of all this is that whenever you get focusing, precipitating or aggravating headache, short duration or long duration, far focusing or near focusing, rule out an ophthalmic cause. And convergence spasm, always look into the psychogenic origin of this headache. And they say there is nothing. All these are normal. Patient has no refractive error, no phoreatropia, no convergence insufficiency. So that time, remember 5 Ds. First D is dry eye syndrome, which can aggravate headache. Second D is digital eye strain, which can precipitate or aggravate headache. Third is, highly complex divergence excess. And fourth is a controversial term, divergence insufficiency, but they are there. They are true. You can get them. And the last D is DAM, depression, anxiety, and malingering. So now you know how difficult it is to diagnose headaches in ophthalmology. Now comes inflammatory origin headache. Any inflammation, a conjunctivitis, blepharitis, scleritis, all can precipitate headache, eye pain and headache. So how do you know that the headache is secondary to inflammatory process? So you can do 2 things. One, apply pressure over the globe, eye pain and headache increases. Second, you put xylocaine. Both decreases. So that is the way you correlate. Now the trochlear headache, I think not well known with the ophthalmologist. It is also known as movement headache. They get eye pain, supraorbital headache, but the classical symptom is supraduction, infraduction, exacerbates headache. You know, whenever you put trochlea into action, the pain gets exacerbated. And how do you confirm? You press at the trochlear region, supromedially, and that area becomes tender. If you get tenderness, then you can confirm that. And you inject xylocaine or steroid, and you get significant relief for a long time. Now, stabbing headache, they can also come to you, single stab or series of stabs, pricking, piercing, 1 second or 2 seconds. And usually in migraineurs, wherever they get migraine pain, they can get this stabbing pain. And when it is in the orbital region, it is known as ophthalmodynia periodica. And generally, this is more in migraineurs, and you can reassure them. Or if they are very much suffering from this pain, you can give them paracetamol or NSAID. Now comes the eye pressure headache. It is very easy for you to diagnose angle closure glaucoma. There is no problem. But subacute angle closure can be a problem. People with anatomically narrow angle can get angle closure when they are in the dark, they are in the moonlight. And traditionally, any headache early morning along with sunrise is known as Surya Kudinyi, sun migraine, and late in the evening, in the dark, when there is moon out in the sky, it is known as Chandra Kudinyi or moon migraine. So whenever they get this angle closure in the dark, they get headache with vomiting. So they, usually think that it is Chandra Kudinyi. And what do? They switch on the light, search for a balm, pain balm, or a pain tablet. They apply the balm, take the tablet, and sleep off. So the light or sleep both can induce meiosis, and this episode gets aborted. So when they come next day or day after with headache, there will not be nothing in the eye. So how do you suspect this as angle closure? So 5 important symptoms. One is a new onset headache, or if they get headache, it is a different type of headache. Second, more of orbital pain. Third, congestion, halos, blurring of vision. So if you get one of these symptoms, then it is mandatory you rule out angle closure glaucoma or subacute angle closure. Say now nothing in the eye. So that is the time, everything is normal. The way we say eyes are white and quiet. Patient is complaining of headache. That is the time, think of a primary headache disorder, more and more of migraine, less and less of tension. Why should these migraine patients come to us? Because of 3 reasons. One is the location of pain. If you go through the history, majority of them will get one episode in the orbitoperiorbital region. So one day they think, okay, I will get an eye checkup done. Maybe spectacle will be a problem. Second is the commonest aura. Migraine aura is visual aura. 90-95% are visual auras. And they have no other place to go. They have to come to you. Third is the autonomic symptoms. Congestion, lacrimation. So they also come to you. Migraine with autonomic symptoms and aura variants. Alice in the Wonderland syndrome, visual snow. They also will come because these are all problem with vision. So how do you diagnose? You look up to the Bible, again, ICSD-3. But you get disappointed. When you try to diagnose migraine and differentiate from tension, there are overlapping statements. 4 overlapping statements are there, so you find it very difficult. So I have modified this criteria. I have made it very simple. I have been presenting this in various national, state, international forums. It's very simple. A recurrent, that means multiple episodes. Activity affected. They take rest, lie down, sleep off, and they are absolutely normal after each episode. So 85% migraine you can diagnose like this. There are, 10-15% differentials. But if you get a migraine trigger, one of the non-migraine trigger, well-documented migraine trigger, then it becomes 99%. So when do you diagnose tension type headache? Episodic tension type headache when activity not affected. So activity is not affected, they are, continuing with their work, you can think of tension type headache. Now when we discuss autonomic symptoms in migraine, there is a specific entity known as trigeminal autonomic cephalalgia, where they present with profuse autonomic symptoms. There are 5 autonomic symptoms: congestion, lacrimation, meiosis, ptosis, periorbital edema. So if you get one autonomic symptom, then you think of TAC. And this is my mnemonic, Obama. You can easily remember this. You know, O means orbital, more of orbital pain, not, you know, other areas of the head. Second is B, brief episodes. They are, you know, seconds, minutes, excepting one, hemicrania continua, which is continuous pain. AM means autonomic manifestation, those 5 autonomic symptoms. And last A is, you know, agitated. They will be agitated, restless, and pacing the floor. They will not be lying down like a migrainer. In is indomethacin. 2 of these entities are absolutely responding to indomethacin. And for you to diagnose, oh, finished. 15 minutes? Over? Okay. Then I think. Okay. So you need a, you know, stopwatch to diagnose these conditions and differentiate one from the other. Cluster headache is 15 minutes to 180 minutes, but some episodes can be less than 15 minutes, very brief. Paroxysmal hemicrania, 2 minutes to 30 minutes. That is indomethacin responsive. Then there is the SUNHA, short-lasting unilateral neuralgiform headache with autonomic symptoms. When the autonomic symptoms are in the eye, it becomes SUNT. Otherwise, it is SUNA. And the last entity is hemicrania continua. They get continuous pain. That is also indomethacin responsive. But whether you diagnose migraine, TAC, tension, you have to keep in mind red flags. Red flags are very important. A migraine without aura can be a presentation of a brain tumor, or with aura can be a presentation of an aneurysm. So you have to be very well versed with these red flags. There are many mnemonics. Snoop is the most popular mnemonic, and Snoop verifications are there. Modifications, you can learn, you can by heart one of these mnemonic. And I have my own mnemonic, that is, I warn you please. I means incapacitating headache. W means worst headache of my life. A means abrupt onset. R means recent. N is with neurological symptoms or signs. U is unusual headache. And please means P symptoms. You know, there are many P symptoms. The most important are papilledema, pressure, blood pressure, eye pressure and CSF pressure, and progressive headache, and pattern change in pattern, and pituitary symptoms, which we never ask. I have seen many pituitaries being missed. So always see that, you know, pituitary symptoms, you ask them. Symptoms down the neck, gynecomastia, galactorrhea, infertility, amenorrhea, which you never ask and they never tell you. And before you wind up the assessment, look at the neighborhood. 3 immediate neighbors, sinuses, temporomandibular joint, maxillary teeth, and 1 distant neighbor, that is the occipital region. So palpate and press. See any tenderness there. Pain from these regions can radiate onto the orbital region, retrobulbar region. So to conclude, evaluate headaches carefully. Whenever you get focusing headaches, aggravating or precipitating, short duration, long duration, near or far, rule out an ophthalmic cause. And if nothing, you know, think of migraine or tension, more of migraine. If there is profuse autonomic symptom, trigeminal autonomic cephalalgia, and beware of red flags. Thank you.
Thank you, Dr. Francis, for highlighting the details of headache, different types of headache, and the solutions. Thank you very much. We'll keep the discussion at the end.
Thank you very much, sir. Now, our next speaker is Dr. Prithvi Chandrakant. He is one of the young, dynamic vitreoretina surgeon working at Chandrakant Nethralaya, Kozhikode. He is having, at this tender age, he is having many awards and presentation in his basket. So he will be enlightening us on the use of the smartphone in ophthalmology. Yeah. Over to you, Prithvi.
Good morning, everybody. First of all, I would like to thank NETHRAM and AMITA Eye Care for having me here. I'll be talking on smartphone ophthalmology. Basically, how to transform your smartphone into a ophthalmic imaging device, which will be useful for your daily practice. First of all, I'll go with anti-segment photography with intraocular lens. So as we know that slit lamp cameras are very expensive and it's very difficult to obtain one in a very low cost. So we all resort to a much easier version, that is a slit lamp freehand imaging. So this is very simple. This is Dr. John, my mentor, using a smartphone freehand imaging, where the only tip which we need to know is keep a small one finger distance between the eyepiece and the smartphone to get a proper round circle which makes your image very focused. So this is one basic tip which we need to use while taking freehand imaging. So what if we have another adapter? So there are a lot of adapters in the market which you can get actually for 500 rupees. So once you get a adapter, it becomes very easy for us to reduce the mobility, and we can actually stabilize the smartphone more easily on the slit lamp. So once you attach the smartphone onto the adapter, just fix it to the eyepiece. So eyepiece, again, we need to keep a one finger distance. So keep the smartphone camera exactly in the center of the eyepiece holding piece of the adapter. So once that is done, you place it on the eyepiece at least one finger distance. So once you do that, you will actually get a proper demarcation of the eyepiece. That's a circular demarcation which will help us take good focused images. So this becomes very easy, and you can even use it to take undilated fundus images also. So what if we don't have a slit lamp and we don't have any adapters? So that is where we come up with an ASPI device. This device is very easy to make, so I'll just show you the process. So take a chart paper, 10 centimeter to 1.5 centimeter, then cut it from the chart paper, and then what we have to do is put a double-sided tape. So divide into half, put a double-sided tape inside. This is the double-sided tape which is put inside. So once we have done that, we can use a paper puncher to make a hole, a small hole. So this is exactly the size of an intraocular lens, the IOL, which we are going to place inside the chart paper. So once you have done that, you can remove the other side, the double-sided tapes. Other side, you can remove the sticky surface, and you can just place a 15 diopter IOL. So 15 diopter IOL will get us the whole view of the cornea. If you want a much magnified image, we can even use 20 to 25 diopter IOLs. And once that is done, you can just fix this onto your smartphone. So any smartphone, we can fix this. And once we do that, it turns into a macro photography device. So once we on the video mode, on the flashlight on, and just take it towards the patient's eye. So you'll have to be a little close to the patient's eye. So go near to the patient's eye. So without a slit lamp itself, we can actually start taking images of the eye. So this is a small demo of the same. So here we have published an article where we have postgraduate residents have taken images of anterior segment findings and without a slit lamp. So this is how beautifully you can actually take images without a slit lamp. So what we thought is, what if we use it for gonioscopy? So we took 6 diopter, 8 diopter and 10 diopter IOLs. So you can see we used all 3 type of IOLs to with the gonio to take images of the angle. So these were the images which we obtained while doing this. So it becomes very easy that we are actually replacing a slit lamp in our OPD to take images. So what we thought is, why not take it to the next level? And we thought, let's put a cobalt blue filter to this same ASPI, and then we could start taking images of blue images also. So over here you can see a Seedles positive test taken using this device. This is called Scooby-Doo. So it becomes very simple if we don't have a imaging device in our OPD. Next, I'll be talking about IOL scope. So this is exactly like ASPI, but here we are using 4 different IOLs, 4 30 diopter IOLs. We're keeping one upon the other, just attaching it with the liquid adhesive like Fevicol. So this way we put 4 IOLs together. So this gives us a addition of 120 diopters. So you can see over here. So then attach this to the smartphone, and once you have a slide which is kept on a torch or any illuminating device, you can actually start taking images of microscope or microbes like fungus and other parasites, etc. This is how we take it. So you can see, keep the slide on the, and you can even keep it focused on sunlight or any other illumination source, and you can take images such as this. These are all the fungal hyphae which we were able to take. This is a KH mount. You can see the hyphae and spores. So this way, this is a parasite which was taken out of the eye. So this can be done in our OPD setup itself. So that becomes very simple. So over here, we took the same IOL scope into a OT, where we got a sample from the orbital mucormycosis, and we did it live inside the OT to see if the edges were affected with the mucormycosis, and you can see how easily the hyphae was seen over here. So we compared it with the original microscope also, and this is from IOL scope, and the other one was from the actual microscope. So it was comparable. So then we thought, why not use this in our OPD? So we attached this setup to the OPD slit lamp, and then we were able to take images of ulcers also. So corneal ulcers, scraping was done, and point of care diagnostics, we took the slide and started diagnosing if there was a hyphae specimen in the slide itself on the slit lamp. So next I'll be talking about the gimbal scope. So basically we thought, why not use a smartphone to see for retinoscopy reflex. So this is how we attached two adapters together, and we put it onto the retinoscope, and the smartphone was attached, and we could take images like this. So you can see the movement reflex. We could see against movement. We could see also, so this is the neutralization. So it becomes very easy for us to explain to our residents or optometrists on how the reflexes are seen. We have last one is a trash to treasure red cam. So here we are making a red cam using a hand sanitizer bottle. So this is a hand sanitizer bottle which has been cut in such a manner that we can use a 20D condensing lens to be fit inside. So it is very rigid and it doesn't fall off. So the adapter is used and the phone is fixed, and we on the video mode with the flashlight on, and you can see how beautiful retina images we can take from this device. So this is these are all do-it-yourself images, do-it-yourself instruments which can be used in our daily OPD, and we have also used the ASPE and the RedCam to see for ROP cases as well. And we have published this in the Indian Journal of Ophthalmology. So for those people who find difficult in making the devices, we have also 3D printed the same. So you can just use this. It is like a clip-on instrument which can be clipped onto the smartphone, and you can start taking images of the anti-segment. Exactly the same way, even the RedCam has been made into a 3D printed module, and it can be used for retina imaging. Thank you, and if you need any other queries, I'm here, and you can contact me also. Thank you.
Thank you, Dr. Prithvi, for the excellent presentation. Now we can go upon to the discussions.
We'll start with the discussion about Dr. Satish talk, squint, pearls in the squint management. Any doubts?
Sir, I have one basic doubt which we feel in our day-to-day practice. Usually we see most of the young newborns, like those who are below less than 3 or 4 months of age, the parents present with us complaining that my kid is squinting. So usually either they will have telecanthus, but if in case there is no telecanthus, then how we can make sure that the patient, means the baby, is having any amblyopia or any squint, or mainly means any pathology which can affect the visual development. You believe you focus on mainly on the CSM test in those cases?
Yeah, for alignment of eyes, always cover test is the gold standard. So for children, all you need to do is at that age, you just need to look at the give a near target and look at the cover test separately. And you can also use the Bruckner's reflex, where the deviated eye will have a brighter light reflex. You can dilate the pupils and look at the Bruckner's reflex, but cover test is the gold standard.
I always used to see the ocular movements also for the children to rule out the Duane's also. And nowadays more youngsters also coming with, as I'm having squint, they will show the selfie and say I'm having squint. Most of the time it will be pseudostrabismus and very difficult to convince them. Usually, previously I used to show the all photos like that of pseudostrabismus and used to explain. But this youngster is very difficult to convince. So nowadays what I am doing is, first I will take the video of the patient, cover, uncover and alternate cover test. Then I will show the video of squint patient. See, this is the eye is deviating. Then I will show the presenting patient's video and see, your eye is not deviating. So there is no squint. Don't misdiagnose with the photo. That way only I can convince the youngsters. This I will do for the young children also. If children up from 6 months, if the head control is there, child is not crying, we can do the cover uncover test. If there is any amblyopia, the child definitely will remove when we cover the non-amblyopic eye. That's also a very good test. Sir already covered everything. Very good presentation, sir.
Thank you, ma'am.
My question is to Dr. Prithvi. Nowadays, the smartphones are having more than 2 cameras. How do you focus it?
So nowadays all the smartphone comes with 2-3 cameras. So what I do is I take the camera, put it in 1x, and keep my finger and see which camera is focused. So once we know which camera is focused at 1x, we can use that particular camera for imaging.
I have one doubt to Dr. Prithvi. This printed version fundoscope you have shown, there also the 20D is attached, or we need to attach the 20D diopter lens?
No, we have to attach the 20D extra. Whatever we have, there is a small mechanism where we can actually remove it and you can put that one.
Okay.
And other adapters we can use for different lenses also.
The anterior segment adapter also we need to place the IOL, or is it?
No, that one the IOL comes prefixed.
We can use it.
Yeah,
say,
so
okay.
whatever IOL you want, you can actually put that and close it.
Thank you.
Any doubts about headache? Dr. Francis will be able to help them out.
Sir, cluster headache is also just like migraine, whether it will come for few episodes and then resolve, or it will come on and off like.
Every season or every year, and it can go into chronic cluster headache. They can get continuous cluster headaches. Yeah.
Any association of cluster headache with weightlifting or something like that, sir?
There are many triggers. Stress and strain, fever. Alcohol. So those triggers can precipitate both migraine and cluster. But then you have to look at the criteria and then see whether it fits into cluster or not. Yeah.
Sir, I had a doubt. Do you have any experience with using CGRP antagonist, the kid in the block treating migraine?
CGRP, only one in Indian market now. Arenuma. So that is very expensive. 20,000 per injection. Okay, yeah. And even if you spend 20,000, you can only promise 50% patients will get 50% improvement. So, so it is not a panacea or a magic remedy. So now, and recently now other drug also has come, migditan. That is the last migditan. That is 5-hydroxy 1F agonist. Yeah. So that is very cheap, 50 to 100 rupees, 50 milligram. No, that is the previous one, triptan. This is the ditan. So triptan and ditan, yeah. So all these, only 50-60% only get a response. 30-40% will not get a response. That is the problem with all these latest drugs, yeah. And some of them are very expensive, and other CGRPs have not come into India. There are 3 more CGRPs. Primanisumab, Galcanisumab, yeah. So they are very expensive in US. For injection, you have to give something like 40,000. Yeah,
I think it's taken once in 3 months also.
Once in 3 months also is there. Once a month also. Yeah.
Any other doubts? Otherwise, we'll wind up this session.
Thank you, speakers, and thank you, audience, for making it a wonderful experience. I would like to request all the speakers to please come on the dais for one group photograph.
Now, I would like to request Dr. Amita Varghese to hand over token of appreciation to Dr. Sadish Thomas. Dr. M.V. Francis. Dr. Prithvi Chandrakant. Dr. Drumil. Dr. Rachel Jose. And Dr. Chaitanya Arvariyar.
Now, we shall move on to the official inaugural session. We humbly invite the following dignitaries to the dais. Dr. Thomas Cherian, President, Kerala Society of Ophthalmic Surgeons. Dr. Rachel Jose, President, Ophthalmic Society of Pathanamthitta. Dr. Arup Chakrabarti, Past President, Kerala Society of Ophthalmic Surgeons. Dr. Gopalas Pillai, AOS representative from Kerala. Dr. Bastian V, Scientific Committee Chairman of KSOS. Dr. Amita Varghese, Director Amita Eye Care. Dr. Sabida, KSOS representative from Ophthalmic Society of Pathanamthitta.
Before the inauguration, our optometrists, Ria, Tinu, Subi and Honey will lead us with a prayer song. Shall we all rise up?
എന്നും ദയ ചൊരിയണമേ
humbly invite Dr. Rachel Jose, President, Ophthalmic Society of Pathanamthitta, for the welcome speech. Madam has been a dynamic president who revived the Ophthalmic Club, mobilized members to become more active, and converted the club into a registered society named as Ophthalmic Society of Pathanamthitta. And this year, we are conducting third NETHRAM with her as president. A warm welcome, dear ma'am.
Good morning and welcome to today's annual CME. Annual CME NETHRAM 24 is being organized by Amita Eye Hospital, Thiruvalla and Pathanamthitta Ophthalmic Society under the aegis of KSOS. The theme today is a deep dive into the comprehensive ophthalmology. The arrangement and preparatory work has been done in a wonderful manner by Amita Eye Hospital under the able guidance of Dr. Verghese Joseph, Dr. Amita Verghese, and the organizing committee team. I am extremely happy that the arrangement this time has been very, very good. They really should get a applause for the way the things have been arranged. Today, we will be honoring Dr. M.I. John, our senior most ophthalmology from Pathanamthitta district. He was my senior in Trivandrum Medical College. The sessions are scientific session, virtual reality phaco training, film festival, an interesting case presentation, and the last two by a competitive type of session. Presentation by PGs is also very important today. We are going to bring them chance to present interesting cases. The sessions are multiple today: cataract, IOL, squint, smartphone use, retinal diseases, including anti-VEGF treatment, dry eye disease, refractive surgery, orbital disease, thyroid eye disease, glaucoma, etc. I welcome all the dignitaries in the dais and in the hall. We are blessed with the presence of our dynamic Dr. Thomas Cherian, KSOS President. I personally know him for the last 20-25 years. He was working at that time, even now I think continuing in Angamali Little Flower Hospital. Which was one of the best training centers under the National Program for Control of Blindness in various subspecialties like SICS, phaco, retina training, pediatric ophthalmology training, etc. Now he is the HOD of the retina department. I welcome you, sir, today for this annual CME. Our scientific committee chairman, Dr. V. Bastin, is with us today. He is working as a senior eye surgeon in NETHRA Eye Care and Laser Hospital in Nyalakuda. He is also associated with a lot of KSOS and the District Ophthalmic Society activities. We welcome you, sir. I welcome Dr. Gopalas Pillai, past KSOS secretary and KSOS representative to AIOS now. He is the HOD of the eye department, Amrita Eye Hospital, Ernakulam, and a famous retina eye surgeon. I welcome you, sir. Dr. Arup Chakravarti, our past president, KSOS, and scientific committee chairman in the AIOS, and is a very dynamic retina IOL eye surgeon, and he has an eye center in Trivandrum. He is the owner, and his wife, Dr. Meena, we are missing her. She was also supposed to attend today. I welcome you, sir. Now, Dr. Amita Verghese, the owner of Amita Eye Hospital. The hospital is doing wonderful work in the field of eye work and also in the field of community eye care. The hospital is there for the last 30 years, and it's working as one of the best hospitals of Pathanamthitta district. I welcome you, Madam. Now, our Dr. Sabita, he's also from Pathanamthitta district. I know her for the last maybe more than 30 years. One of the best eye surgeons of Pathanamthitta. Now she's the KSOS representative. Pathanamthitta district representative to KSOS. I welcome you, Madam. Now I also welcome a lot of our senior ophthalmologists sitting in the hall. They have come from Trivandrum, Alleppey, Kottayam, and Kollam district. We really welcome you, all the sirs and madams. I don't want to be, due to shortage of time, I don't want to give the names. I also welcome all the dignitaries, speakers, chairman, co-chairman of all the session, moderators, and my special welcome to Dr. Verghese Joseph and Amita Verghese, and their meticulous coordination and excellent coordination by their eye care team. I also welcome our secretary, Dr. Leena, our treasurer, Dr. Sumi, and all the executive committee members who are a source of inspiration to me. I welcome all the eye surgeons from different districts. I also welcome all the pharma companies who are associated with us and helping us. Thank you very much. Welcome for all. Now Dr. Leena will be talking in detail about the Pathanamthitta Ophthalmic Society activities and the progress and the outcome today. Thank you.
Thank you, Rachel ma'am. Good morning all, respected dignitaries on and off the dais, dear seniors, fellow members and my dear students. I'll be just taking a few moments of yours just to tell you how much our society has grown so far. So at the outset, I'd like to thank the Amita Eye Care team for conducting such a wonderful conference for the society. And we are really proud of the work done by you, Amita ma'am and sir. So before going into our growth, I would like to bow down and pay our respects to our seniors, past presidents, secretaries and treasurers of the Pathanamthitta Ophthalmic Society. Even though the society was started in the early 2000s, it had many setbacks and problems that it had to face. I feel it was mainly because of the lesser manpower and members. The district being a large one, it was difficult to bring everyone together for meetings, especially during the evening. And also COVID that stopped all our meetings. But we did manage to have a few virtual meetings during the COVID times. These are our present office bearers. We work under the able leadership of our dynamic president, Dr. Rachel Jose, who makes sure that we put in our best effort for the development of our society. When me and Sumi took over, these are our executive committee members. When me and Sumi took over the society responsibility, we had many hurdles in front of us. One was starting an account, starting a PAN card, and most difficult was registration of our society. As you all know, it was not at all an easy task. We had to make multiple trips to the Pathanamthitta Registrar Office, change our society name to Ophthalmic Society of Pathanamthitta, and all throughout we had constant support from our seniors, Dr. Sabita ma'am, Dr. Shane, Dr. Rachel, Dr. Verghese, and Dr. Satish, Dr. Kashinath Chenoy sir. Now we have become a full-fledged society consisting of, so this is basically our society logo, our society being registered. Now we are a full-fledged society consisting of around 60 members and we have 12 postgraduates under us. We have made sure that we have regular activities, awareness talks and camps conducted in our hospitals. We have been having glaucoma week programs, eye donation fortnight, World Sight Day programs, Diabetes Day programs. And we make sure that we have short meetings every 2 to 3 months, giving more importance to PG teachings. These were the last 3 years meetings that we have had. And as you all know, we have our flagship CME known as NETHRAM, which we decided to conduct every year in the month of August. And we have had PG competitions in the form of quiz. And today, as you all know, we have video competitions and case presentations for PGs. So this was our annual CME NETHRAM we conducted in 2022. It was conducted by Believers Church Medical College Hospital. This was the next annual CME conducted by Pushpari Medical College. And now we are here, 2024, NETHRAM conducted by Amida Eye Care. So our growth so far is a testament to the collective efforts of not only to our leaders, but also to all its members. It's a huge teamwork. The wisdom and guidance given to us by our seniors play a major role in this growth. As we grow further, we must ensure that we can do the best we can for the people of Pathanamthitta who come to us with their eye problems. We should provide public awareness among them regarding the eye problems, empower the future generations, especially our PGs, we should not only teach them clinical as well as surgical skills, but also teach them how to see their patients with compassion and care. I would like to conclude by thanking God and each one of you sitting in front of me for helping me to make our society to what it is now. Thank you.
Now, we would like to invite Dr. Thomas Cherian to officially inaugurate the function by lighting the lamp. We request the dignitaries on the dais and also Dr. Rani Nair, Organizing Chairperson, Dr. Priyanka Tilak, Organizing Secretary, Dr. Leena Varghese, Secretary of Ophthalmic Society of Pathanamthitta, to join the inauguration ceremony.
Please let us all rise for a moment of silent prayer for those who lost their lives in Wayanad landslide.
Now, we invite our guest of honor, Dr. Thomas Cherian, for the presidential address.
Honorable President of the Ophthalmic Society of Pathanamthitta, Dr. Rachel Jose, Madam, seniors and my dear friends, on behalf of all the members of the Kerala Society of Ophthalmic Surgeons, I lay down my respects to the victims of the massive landslide tragedy in Wayanad district. As a fellow brethren, we are all shocked by the natural calamity. The entire state and the entire nation is on rehabilitative measures. And as KSOS, we are also thinking as to what we should be doing. It's very easy to donate some money, but what can we do beyond that? As a society, we are thinking about it. Next week in our executive committee meeting, we'll discuss suggestions and I request all of you to come out with ideas as to how we should help the victims and their families of the Wayanad tragedy. Coming down to the Ophthalmic Society of Pathanamthitta and this CME NETHRAM, the third edition. Just now I was told that this is NETHRAM 3. In Indian mythology, the third eye of Lord Shiva is very powerful. And so NETHRAM 3 is equally powerful. And I find that the Ophthalmic Society of Pathanamthitta is pooling its resources with the various institutions here. First time it was Believers, second time it was Pushpagiri, and now it is Amita Eye Care. That's a model to emulate for the various district ophthalmic clubs and societies to utilize the resources of our member institutions and come up with good CMEs where we have out-of-the-box thinking and talks. It was heartening to listen to seniors like Dr. Verghese Joseph and Arup Chakravarti, and at the same time have a vibrant youngsters like Prithvi around today. And I'm sure in the hours to come, we'll have much more of enlightening talks today. Once again, I congratulate OSP for this CME. We are in the run-up to Drishti 2025, and the two main offices which come under spotlight when we are approaching a Drishti are the offices of the Scientific Committee Chairman and the website. The Scientific Committee is coming out with a wonderful program. Dr. Baston should be able to release it in a couple of days. The program is being ironed out, and I'm sure Drishti 2025 is going to be a scientific feast. Our website has undergone a thorough revamp thanks to our website editor, Dr. Sujit Nayanar. All of you, please go to the website, visit the website. Our memberships have been streamlined, and our life membership certificates could be downloaded from the website today. We are honoring Dr. M.I. John as the senior ophthalmologist from this part of the state. Dr. M.I. John is a hidden gem. He has done a lot of remarkable service in Pathanamthitta district as an ophthalmic surgeon and also as the superintendent of the General Hospital at Pathanamthitta. It is an honor for the KSOS to acknowledge the services of Dr. M.I. John. Thank you, sir, for coming over and accepting this, and congratulate you for the wonderful services which you have done in your lifetime. It's good to note that the CME is well attended, and we'll have a wonderful CME today here at Thiruvalla. With these few words, I declare NETHRAM 2024 of Ophthalmic Society of Pathanamthitta open. Thank you.
Thank you, sir, for gracing this occasion with your inspiring words. Now, to felicitate the gathering, we welcome Dr. Arup Chakrabarti, past President, KSOS.
Dignitaries on the dais and off the dais, Dr. Rachel Jose, Madam, Dr. Leena, Dr. Sumi, Dr. Priyanka Tilak. This is actually the third annual meeting that I've been attending, and each and every meeting has been organized with so much of meticulous planning, so much of sincerity, and you know that they really are very committed to and dedicated to the program. I would also like to congratulate Dr. Amita ji and Verghese. I have known them since the time I was at Aravind, and that time itself I knew they were always at the cutting edge of technology. Their private practice in Kerala was they were basically the leaders, and they have kept it up with the joining of Dr. Shishir and the new generation. I think they're going to go to step to the next level. Shishir, congratulations to you because of all these awards, video awards and other prizes that have been winning for us. I wish you all the best. Dr. Thomas, our dynamic president of KSOS, we are all with you. He put up a message asking for support for his ventures in towards the relief of our brethren who suffered so much during the floods. So I think we are all with you. Whatever you want to be done, we will make sure that we allow you to, we enable you to meet your outcome. As regards the program, I was just going through the program. It is an ideal program. It has most of the basic topics. I fully agree with Minu that SICS is something that is not to be looked down upon. No, it is never compare it with any other surgical technique. This is a surgical technique, very good technique in itself. 2018 and 19, ESCRS wanted me to start off a FECO lab and a wet lab as well as a training program. So I had done it. Even all these training programs for the American Academy, ASCRS, they go houseful. People pay for it and still they don't have position. So please, the pearls for SICS that you have learned today. Whenever a meeting like that is organized, I always feel that from the perspective of the audience, when I'm the audience, it is not possible to cover the entire syllabus. So if the speaker basically wants to ignite your some passion, ignite some spark, so that when you go back, you know what exactly to, what are the current direction of the particular topic and this subject that is taking, and follow it up. And for the practitioners, you get alternative perspectives, what others are doing, does it fit into your way of practice. And a word about Prithvi. Prithvi, I have known him since he was a newborn, and I have been really impressed by your remarkable journey. And please keep it up. And whatever help you require, we from KSOS, at KSOS level as a personal level, we are going to provide you with. And finally, I would, from a personal level, I would like to thank KSOS for the wonderful support when I contested for the AS President elections. I lost by a narrow margin of 5%. Like out of 100 votes, 47.5 came to my direction, came my way. But the voting that the number of people that voted from KSOS was enormous. It has never happened before. And though I didn't win the election, but still, I want to thank you for the wonderful support that you have shown to me at a personal level. And I wish this program all the best. Thank you very much for this opportunity to talk.
Thank you, sir, for your kind words.
We invite Dr. Gopal S. Pillai, AIOS representative from Kerala, for felicitation.
Respected Dr. Thomas Chirian, President of the KSOS, Rachel Jose Madam, President of the PATHANAMTHITTA Ophthalmic Society, Arup sir, and other dignitaries on the dais and off the dais. When I have been fortunate to be part of the last few NETHRAMs as well, and I'm seeing the change from a medical college setting to a hotel setting. It is all in the end, this LED screen. Things are all improving. And I would say the change is the only constant thing in life. But with stalwarts like all of you leading the pack, it is not just change, it is growth, which is only the constant thing in here. I want to congratulate the all-women team of PATHANAMTHITTA Ophthalmic Society, who have actually made things in a very vibrant way over the last couple of years. The way Rachel Madam said, it is just like you're putting up a proposal or a project. What she was telling Dr. Leena, okay, so you will have this outcomes and documentations and this all ready next. So congratulations to that. And PATHANAMTHITTA definitely has a mix of senior as well as junior, doctors who are both experienced as well as anxious to perform. And that is definitely going to take PATHANAMTHITTA to the next level. Just one more thing that I want to add would be that, Kerala society is the best state society in India. And that is because each district ophthalmic clubs perform so well, and they document it and they send it up to the AIOS. Let Kerala continue to be the best state society in India. Thank you very much. Jai KSOS. Jai Hind.
Thank you, sir. Next, we invite Dr. Basting V, Chairman, Scientific Committee, KSOS, for felicitation.
respected KSOS President Dr. Thomas Cherian, President of PATHANAMTHITTA Ophthalmic Club Rachel Madam, Senior Ophthalmologist, and dear friends. As an organization, the first priority of KSOS is education. Today is the 27th CME being held under the aegis of KSOS in this year. I congratulate the team PATHANAMTHITTA and Amida Eye Hospital for organizing this wonderful CME with unique programs like case presentations, virtual reality programs, and video film festivals. Apart from the regular CMEs, the KSOS Scientific Committee is arranging a variety of programs, especially for the postgraduates and the young ophthalmologists. We have the physical PG update program, the highlights, in which a single topic will be covered in details, and the 2 modules are already over. The first one was held at Little Hospital Angamali, and the second one at Chaitanya Eye Hospital Trivandrum, and the third one will be held at Comptrust Eye Hospital Calicut on 18th of this month. We also do have the online PG classroom, in which a postgraduate will present a case in the presence of an expert panel, and also one external from outside the state. This is mainly to improve the skills of the postgraduates and also to prepare them for their final examination if such a case they come across during the examinations. We also do have the Young Ophthalmologist Forum, mainly to improve to update the postgraduates, not postgraduates, the young ophthalmologists who are in the beginning of their career, and also to discuss the various issues that they face during the initial phase of their career. The scientific preparations for the annual CME, Drishti 2024, is in full swing. This time we received a record number of 119 instruction courses, 195 free papers, 45 videos, and 175 posters. And the evaluation of all these are over, and the final result is already published in the website. I request all of you to go to the KSOS website and check it. And the final program will be ready in a couple of weeks. And unlike in the previous years, this time we will be having only the physical posters, no electronic posters. And the KSOS will sponsor the winners of the Teachers of Tomorrow this year to represent the Kerala team in the upcoming All India Conference at Delhi. And with these words, I conclude with 2 appeals. One, even though we have 2,492 ratified members of KSOS, our representation in the All India Ophthalmic Society is very less. So I request all the young ophthalmologists and the postgraduates to join the AIOS. Only then we will have our own voice in the national forums. And another thing is, all the postgraduates who are present here, please do join the physical PG update program that highlights the 3rd module with pediatric ophthalmology as a topic at Calicut Comptrust Eye Hospital, which will be held on 18th of this month, Sunday. So all those who want the accommodation, you can contact us. With these few words, I congratulate again the team PATHANAMTHITTA Ophthalmic Society and Amida Eye Hospital for this wonderful CME. Thank you.
Thank you, sir.
Now, we will be honoring the senior ophthalmologist as per the presidential initiative of KSOS. I request Dr. Sabida to introduce the senior most ophthalmologist in our district, Dr. M.I. John.
Good morning all. First of all, let me congratulate our dynamic KSOS President Thomas Cherian sir for taking an initiative to honor each and every senior members of our state. And I am happy to introduce our beloved and senior most member of our society, Dr. M.A. John, on behalf of our PATHANAMTHITTA Ophthalmic Society. Born on 11th April 1944 as the first child of Mr. Idikula and Mrs. Tangamma Idikula at Kottarakara, Sir did his schooling at Kottarakara and Sir joined the 13th batch of MBBS at Government Medical College Trivandrum in 1964. After completing MBBS, he joined Medical College Trivandrum as provisional tutor in anatomy, physiology, and later entered the Medical Education Service as lecturer in forensic medicine. In 1973, he left Medical College Service and joined Kerala Health Services. Sir took his post-graduation from Nehru Institute of Ophthalmology and Research Center, Sitapur, UP in 1977, after which he went abroad and served the people of Nigeria till 1986. Then he returned to India and rejoined the Health Service Department and worked at Kottarakara, Adur, Thiruvalla and various parts of Pathanamthitta district. He was in charge of the school health program of Pathanamthitta district, and also he was posted as district ophthalmic surgeon. And in 1997, Sir took charge as the superintendent of General Hospital, Pathanamthitta. And it was during his tenure as the superintendent, the Sabarimala Stampede, the Magaravalakku tragedy, which has occurred in 1999, where 53 pilgrims were succumbed to death, and most of them were from our neighboring states like Tamil Nadu, Karnataka, Andhra Pradesh. And Sir got appreciation from the government of Kerala for the flawless management of identifying each and every body and transporting them to their respective places without any issues. I also got opportunity to work with Sir during that period at General Hospital, Pathanamthitta. Sir got happily married to Mrs. Rajamma Matthew. She was professor and head of the Department of Catholic at College, Pathanamthitta, and they are blessed with 2 children and 5 grandchildren. His daughter is a dental surgeon working at Ernakulam, and son did PhD in biotechnology and settled in US. The introduction of John Sir won't be complete without mentioning his contribution in the formation of our Pathanamthitta Ophthalmic Society. Sir was the first president of our club. We started in 1990 with the initiative of late Dr. P.E. Soman, and John Sir continued to be the president of our club for many years till the year 2018. And it was during his presidency we could organize a grand CME at Pathanamthitta in 2017 under the aegis of KSOS. And Sir encouraged us in the smooth running of our club, and whenever we asked him to take responsibility, Sir was ready without any hesitation. And he retired from government service in 1999 and thereafter worked as consultant at People's Clinic, Pathanamthitta. He also held responsible positions in KGMOA as President and Secretary of Pathanamthitta branch, Lions Club President, IMA Vice President, and presently he is the Auditor of IMA Pathanamthitta branch. And with these few words, I welcome you, Sir, onto the dais. Thank you.
We request Dr. Thomas Cherian to honor Dr. M.I. John. Requesting Dr. M.I. John to share a few words of wisdom with us.
President of KSOS, Dr. Thomas Cherian, President of Pathanamthitta Ophthalmic Club, Dr. Rachel Thomas, other dignitaries on and off the dais, and all those who are assembled here, a warm welcome to all of you. Good morning to all of you. പത്തനംതിട്ട ഒപ്താൽമിക് ക്ലബിൻ്റെ ആഭിമുഖ്യത്തിലാണല്ലോ എന്നെ ആദരിക്കുന്നത്. ക്ലബിൻ്റെ കാര്യങ്ങളെക്കുറിച്ച് സവിത പറഞ്ഞു. എന്നാൽ 1990 തുടങ്ങിയത്. ഞങ്ങൾ KSOS മീറ്റിങ്ങിനൊക്കെ എപ്പോഴും പങ്കെടുക്കുമായിരുന്നു. അന്ന് ഞങ്ങൾ പത്തനംതിട്ട കുറച്ച് ആൾക്കാരേ ഉള്ളു. ഡോക്ടർ സോമന്, ഡോക്ടർ M.I. ജോൺ, ഞാൻ, ഡോക്ടർ വർഗീസ് M.A. വർഗീസ് ഹിയർ, ഡോക്ടർ സൂസൻ വർഗീസ്, അങ്ങനെ കുറച്ച് പേരേ ഉള്ളൂ. അപ്പോൾ ഇത്രയും പേര് വെച്ചാൽ എങ്ങനെയാണ് ഒരു ഒപ്താൽമിക് ക്ലബ് തുടങ്ങുന്നതെന്ന് ഞങ്ങൾ ഒരു 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 പ്രയാസം ഉണ്ടായിരുന്നു. സോമൻ പറഞ്ഞ് സാറ് പ്രസിഡൻ്റായിട്ടിരുന്നാൽ മതി, ഞാനെല്ലാം ഏറ്റു. സോമനെ കുറിച്ച് പറയാതെ നമുക്ക് ഒപ്താൽമിക് ക്ലബിൻ്റെ കാര്യങ്ങൾ പറയാനൊക്കത്തില്ല. പുള്ളി വളരെ ഓർഗനൈസാണ്, എന്ത് കാര്യം എപ്പോൾ പറഞ്ഞാലും ചെയ്യും. പുള്ളിക്ക് നാണുവെന്നും പറഞ്ഞൊരു അസിസ്റ്റൻ്റുണ്ട്, പുള്ളിയെല്ലാം എഴുതി കുത്തി എല്ലാവർക്കും അയക്കും. ഞങ്ങളൊരു ഇടയ്ക്കിടയ്ക്ക് മീറ്റിംഗ് കൂടും. അങ്ങനെ ഒരു 5-6 മീറ്റിംഗ് കഴിഞ്ഞപ്പോൾ ഒപ്താൽമിക്കിൽ അങ്ങ് നിന്നുപോയി. അന്ന് ഒപ്താൽമിക് ക്ലബ്ബെന്നാണ് പറയുന്നത്, അന്ന് സൊസൈറ്റി അല്ലായിരുന്നു കേട്ടോ. ഒരു 5-6 മീറ്റിംഗ് കഴിഞ്ഞിട്ട് അങ്ങ് നിന്ന് പോയിട്ട് പിന്നെ 1-2 വർഷം മീറ്റിംഗ് നടന്നില്ല. പിന്നെ തോമസ് ഫിലിപ്പ് എന്ന് പറഞ്ഞൊരു പാർട്ടി വന്നു. പുള്ളി ഒറിജിനലി ഒപ്താൽമോളജിസ്റ്റ്, ഇപ്പോൾ ഓർത്തോപെഡിക്സാണ് പ്രാക്ടീസ് ചെയ്യുന്നത്. സാറേ ഇങ്ങനെയൊക്കത്തില്ല, നമുക്ക് ഒപ്താൽമിക് ക്ലബ്ബ് കൊണ്ടുവന്ന് പറഞ്ഞു. പുള്ളി ഭയങ്കര നിർബന്ധം. പിന്നെയും ഞങ്ങൾ തുടങ്ങി. പിന്നെ അന്നോട്ട് ഇന്ന് വരെ നിന്നിട്ടില്ല, വളരെ വളരെ ഭംഗിയായിട്ട് നടക്കുകയാണ്. ഇപ്പോൾ തിരുവല്ലക്കാർ ഇപ്പോഴേ യങ്സ്റ്റേഴ്സിൻ്റെ കയ്യിൽ വളരെ ഭദ്രമായിട്ടിരിക്കുന്നത് അറിയുന്നത് വളരെ സന്തോഷമുണ്ട്. പിന്നെ ഒരു പ്രയാസം മാത്രമേ ഉള്ളൂ, ഞങ്ങളെല്ലാ മീറ്റിങ്ങിനും പോയിക്കൊണ്ട്, പ്രത്യേകിച്ച് MA വർഗീസ് എന്നെ കൂട്ടി എപ്പോഴും പോകും. ഞങ്ങൾക്കിപ്പോൾ ഞങ്ങൾ പത്തനംതിട്ട തിരുവല്ലയിൽ വൈകിട്ടൊക്കെ വരാനുള്ള ബുദ്ധിമുട്ട് കൊണ്ടാണ് ഞങ്ങൾ വരാത്തത്, അല്ലെങ്കിൽ ഒരു മീറ്റിംഗ് ഞങ്ങൾ വിടുന്നതല്ല. അപ്പോൾ ഈ സംഘാടകർ ഒരു റിക്വസ്റ്റ് ഉണ്ട്, എപ്പോഴേലും 1-2 മീറ്റിംഗ് പത്തനംതിട്ട വെച്ച് നടത്തിയാൽ ഞങ്ങൾക്ക് അതിൽ പങ്കെടുക്കാൻ സാധിക്കും. പിന്നെ കൂടുതലായിട്ട് പറയുകയാണെങ്കിൽ, ഈ അന്നത്തെ മലനാട് ഇവിടെ, ഇന്നത്തെ മലയാളം ഇവിടെ, കാലം മറിഞ്ഞതോടെ കോലം കീഴ്മേൽ മറിഞ്ഞു, നാട്ടാരെ നടപ്പ് മാറി ഉടുപ്പ് മാറി, അമ്പലത്തറയിലെ തുളസിത്തറയും പോയി എന്ന് പറഞ്ഞോളം ഒത്പാലിൽ വളരെയധികം ഞങ്ങൾക്ക് പ്രോഗ്രസ് ആയിപ്പോയി. ഞങ്ങളെപ്പോലെ പ്രായമുള്ളവർക്ക് ഇതുമായിട്ട് കോപ്പ് ചെയ്യാനൊക്കെ വലിയ ബുദ്ധിമുട്ടാണ്. ഞങ്ങൾ ആ കാലത്ത് കൗച്ചിങ്ങും എക്സ്ട്രാ വോക്കലും ഇൻട്രാ വോക്കൽസൊക്കെ പറഞ്ഞുകൊണ്ടിരുന്ന കാര്യങ്ങളെല്ലാം ഇപ്പോൾ പോയി മറിഞ്ഞു. പിന്നെ എന്നെ ആദരിക്കാനായിട്ട് SMS കാണിച്ച പ്രസിഡൻറ്റ് KSOS പ്രസിഡൻറ്റ് ഇനിഷ്യേറ്റീവ് ആണെന്ന് തോന്നുന്നു. കൂടാതെ സബിത, അമിത വർഗീസ്, അങ്ങനെ എല്ലാവരും ഇതിൻ്റെ പുറകിൽ പതിച്ച് നിങ്ങളെല്ലാവരും കാണുവാനും നിങ്ങളുടെ മുമ്പിൽ വെച്ച് ഇങ്ങനൊരു ആദരണം ഏറ്റുവാങ്ങാൻ എനിക്ക് ഇടയുണ്ട്. വളരെ സന്തോഷമുണ്ട്. പിന്നെ എനിക്ക് പ്രത്യേകിച്ച് യങ്സ്റ്റേഴ്സ് 1-2 കാര്യം പറയാനുള്ളത്, ഒരു കേസൊക്കെ റെഫർ ചെയ്ത് വന്നാൽ നമ്മൾ യാതൊരു കാരണവശാലും ഇച്ചിരി താമസിച്ചോ അല്ലെങ്കിൽ ഞങ്ങളെല്ലാം ശരിയാക്കണമെന്ന് പറയരുത്. അത് ഒപ്താൽമിക് അത്ര ബാധ്യതയല്ല, എന്നാൽ ഞങ്ങൾ സർവീസ് ചെയ്യിക്കുന്നവരെ അറിയാം. എന്തെങ്കിലും പറഞ്ഞു പോയാൽ ഉടനെ പോയി ആ ഡോക്ടറെ തല്ലും, പേഷ്യൻ്റായാലും ബസ് സ്റ്റാൻഡായാലും. പിന്നെ രണ്ടാമത് എന്തെങ്കിലും മരുന്ന് നമ്മൾ എഴുതിയത്, ആ മരുന്ന് കൊടുക്കട്ടായിരുന്നു, അത് ഇപ്പോൾ കുഴപ്പമുണ്ട്, അല്ലെങ്കിൽ ഈ ചൊറിച്ചിലുണ്ടായിരുന്നതൊക്കെ പറയും. അങ്ങനെ പറയരുത്. പിന്നെ നമ്മൾ ഒരു കാര്യം പ്രത്യേകമായിട്ട് ശ്രദ്ധിച്ചിരിക്കേണ്ടത്, പേഷ്യൻ്റ് നമ്മൾ അടുത്തിരിക്കുന്നതിലും ഒരു പേഷ്യൻ്റ് അല്ലാതെ അവനൊരു ഒരു ഒരു വ്യവകാരിയോടാണ് നമ്മൾ ഓർക്കണം. ഏത് നിമിഷം നമുക്ക് എങ്ങനെയായിട്ട് അവൻ തിരിയും. അങ്ങനെ 1-2 ഉദാഹരണം ഞങ്ങൾക്ക് സംഭവിച്ചിട്ടുണ്ട്. ഞങ്ങളുടെ അന്ന് ഒപ്താൽമോളജിസ്റ്റ് ഒരു പേഷ്യൻ്റ് കണ്ണിൽ ഇഞ്ചുറി വന്നിട്ട് ബ്ലൈൻഡായി. 1-2 അപ്പോൾ ഇടയ്ക്ക് അങ്ങനെ ബ്ലൈൻഡായി കഴിഞ്ഞ് വാട്ടറിങ് അങ്ങനത്തെ പ്രശ്നങ്ങളൊക്കെ ഉണ്ടാവില്ല. ഇങ്ങനെ 2-3 വർഷം ഇങ്ങനെ കണ്ടിന്യൂസ് ആയിട്ട് ഈ പുള്ളി ഡോക്ടറുമായിട്ട് ഇങ്ങനെ കോൺടാക്ട് ചികിത്സിച്ച് ഭയങ്കര ഇൻറ്റിമസി ആയി. അവസാനം ഈ പുള്ളി പറഞ്ഞു, എനിക്കൊരു സർട്ടിഫിക്കറ്റ് ഉണ്ട്, എൻ്റെ കണ്ണിന് കാഴ്ച എനിക്ക് ഗവൺമെൻറ്റിൽ നിന്ന് ആനുകൂല്യം വാങ്ങിക്കാനാണ്. പാവം ഡോക്ടർ സർട്ടിഫിക്കറ്റ് എഴുതി കൊടുത്തു. അത് അവിടുത്തെ ഈകളെ 3 വർഷം എന്നെ ചികിത്സിച്ച് എൻ്റെ കണ്ണിൻ്റെ കാഴ്ച നഷ്ടപ്പെടുത്തി, എനിക്ക് കോമ്പൻസേഷൻ തരണമെന്നും പറഞ്ഞ് കേസ് കൊടുത്തു. പിന്നെ വേറൊരു കേസിന് വേറെ ഡോക്ടർ പറ്റിയത്, IT മെക്കാനിക്കൽ പാസ്സായ ഒരു പയ്യനായിരുന്നു. അവന് ട്രെയിനിങ് വേണം മെക്കാനിക്കൽ. അപ്പോൾ ഒരു മെക്കാനിക്കൽ കടയിൽ ഈ ഡോക്ടറുടെ കെയർ ഓഫിൽ വലിയൊരു ഫാക്ടറിയിൽ ഒരു മെക്കാനിക്കൽ ഇതിൽ കൊടുത്തു. 3 വർഷം അവിടെ നിന്ന് പഠിച്ച എല്ലാ മെക്കാനിസവും പഠിച്ച്. അപ്പോൾ ആ ചേർന്നപ്പോൾ ഒരു കണ്ടീഷൻ എന്ന് പറഞ്ഞാൽ, ഈ പൈസ ഒന്നും തരത്തില്ല, ട്രെയിനിങ് പീരീഡ് എന്നായിരുന്നു. 3 വർഷം കഴിഞ്ഞപ്പോൾ ഇയാൾ എക്സ്പീരിയൻസ് സർട്ടിഫിക്കറ്റ് വാങ്ങിച്ചു. ഞാൻ 3 വർഷം ഇവിടെ വർക്ക് ചെയ്ത് എനിക്ക് ഒരൊറ്റ പൈസ പോലും തന്നിട്ടില്ല, ബാക്കി എല്ലാവർക്കും കൊടുത്തിട്ടുണ്ട്, എൻ്റെ അറ്റൻഡൻസ് റോൾ ഇതിനകത്തില്ല, എനിക്ക് എൻ്റെ പൈസ കിട്ടുമെന്ന് പറഞ്ഞു. അങ്ങനെ ചിലപ്പം എത്ര സ്നേഹിതരായാലും എത്ര നമുക്ക് അടുപ്പുള്ളവരായാലും ചിലപ്പോൾ എപ്പോഴായി തിരിയുന്ന അറിയത്തില്ല. അപ്പോൾ നമ്മളൊരു സൂക്ഷിച്ചൊക്കെ കൈകാര്യം ചെയ്യണം എല്ലാവർക്കും. പിന്നെ ഡോക്ടർ സബിത, ഡോക്ടർ പ്രിയങ്ക തിലക, ഡോക്ടർ അയ്യപ്പന്, സൈത എന്നിവരെല്ലാം എൻ്റെ വീട്ടിൽ ഞങ്ങളെ ക്ഷണിക്കുകയൊക്കെ ചെയ്തു. എൻ്റെ ഭാര്യ അവർ ക്ഷണിച്ചതാണ്. അവർക്ക് നിവൃത്തിയില്ല, ഭയങ്കര വേദനയായിട്ടൊക്കെ കിടപ്പാണ്, അല്ലെങ്കിൽ വന്നതിന് വളരെ പ്രയാസമാണ് വരാതിരുന്നതിൽ. ഇങ്ങനെ ഞങ്ങളെ ആദരിച്ചതിന് എൻ്റെയും വൈഫിൻ്റെയും എല്ലാവരുടെയും പേരിലുള്ള നന്ദി, സ്നേഹവും സന്തോഷവും അറിയിച്ചുകൊള്ളുന്നു. എല്ലാവർക്കും നന്ദി, നമസ്കാരം.
Thank you, sir. As we come to the end of this ceremony, the organizing secretary, Dr. Priyanka Tilak, will give the vote of thanks.
Very good morning to all of you. I am privileged to deliver the vote of thanks at NETHRAM 3 2024. On behalf of Amita Eye Care and Ophthalmic Society of Pathanamthitta, I extend my sincere appreciation to Dr. Thomas Cherian sir for generously accepting our invitation to be the chief guest of this occasion. I wish to extend our deepest appreciation to Dr. Bastin Sir, the Scientific Committee Chairman, KSOS, and Dr. Arup Chakravarti Sir, the esteemed past KSOS President, for generously sparing their valuable time to be with us. I extend my sincere thanks to Dr. Gopal Sir, our AIOS representative, for his consistent and valuable support. Despite Dr. Biju John Sir's absence, I am immensely grateful for his guidance from the initial stages of our preparation for this CME. I thank Sabita ma'am, our KSOS representative, for all the help rendered to us. I wish to thank all our esteemed speakers and panelists for their active participation and presence. The success of an event like this relies on meticulous planning and execution, which was possible by the unwavering support of Ophthalmic Society of Pathanamthitta under the dedicated leadership of Dr. Rachel ma'am, our President, Dr. Leena Verghese, our Secretary, Dr. Sumi Lucas, our Treasurer. I cannot overstate my gratitude to our organizing team consisting of Dr. Rani ma'am, Dr. Nita ma'am, Dr. Aditya Joshi, Dr. Agobisri Nair, and Dr. Ann Teresa for their exceptional dedication and willingness to go beyond their comfort zone in completing each task. I extend my appreciation to all the delegates for their kind presence in this significant gathering. I want to express my gratitude to Team Amita Eye Care for their active involvement in ensuring the success of this day. Additionally, I extend my sincere appreciation to the pharma companies for their valuable support. A special note of gratitude to the audiovisual team for their outstanding stage and presentation, and to KGI Elite Continental and its staff for arranging a remarkable event. My gratitude extends to our directors, Amita ma'am, Verghese sir, and our young and dynamic directors, Dr. Shishir and Dr. Priya, for their valuable suggestions and inputs. Once again, I thank each one of you present here. Thank you.
Thank you, ma'am. It is my distinct honor and privilege to introduce our esteemed keynote speaker, the renowned vitreoretinal surgeon and the most respected leader in Kerala ophthalmology, Dr. Thomas Terian. Sir has completed his MBBS from Trivandrum Medical College, completed MS from Calicut Medical College in 1994. Sir has specialized in vitreoretina from the prestigious L.V. Prasad Eye Institute, Hyderabad, and further training in ROP from Moorfields Eye Hospital, London. Sir has published numerous papers in peer-reviewed journals and has presented extensively at state, national, and international conferences and received numerous prestigious awards. At present, Sir is holding the position of President, Kerala Society of Ophthalmic Surgeon, Treasurer, Eye Bank Association of Kerala, Governing Council Member, Kerala Blind Society, Alva, and working as a senior consultant in Vitreoretina, Little Flower Hospital, Angamali, and Kochi Eye Care, Alva. So, we are honored to have you here and look forward to your insightful keynote address.
Good morning once again, and thank you very much for the opportunity for this keynote address. I'll go through diabetic retinopathy as an epidemic Indian scenario. In the next 15 minutes, I'll divide this talk into 4 portions. One is the prevalence of diabetes globally and in India, the prevalence of diabetic retinopathy, how do we manage diabetic retinopathy, what is the status as a clinician today, and the various projects and programs by the government and in association with the various government programs. So let's start off. We have a total of about 463 million diabetics in the world, of which 88 million are in Southeast Asia, and India has 77 million of these diabetics. This is the statistics from the International Diabetes Federation of 2020. The prevalence of diabetes in the population is about 9%. The number of people with diabetes in India has increased from 26 million in 1990 to 65 million in 2016. That is more than doubled. And if you look at this graph, India comes in this group where the prevalence of diabetes is between 5 and 8%. That's in the moderate number of diabetics. 8.8% of the adult population have diabetes, with men having a slightly higher rate than women. 463 million are diabetic and 374 million have impaired glucose tolerance test, which is a pre-diabetic condition. And by 2045, it's estimated to increase to 700 million people with diabetes and 548 million with an impaired glucose tolerance. That is a 51% increase compared to 2019, more than half. It's 150% of what we have today. By 2030, China will have 147 million diabetics and India will have 134 million diabetics. That means there's a high burden of diabetes in this part of the world. And out of every 7 diabetic adults worldwide resides in India, and 1 in every 3rd household in India has a diabetic patient. If we look at the prevalence of diabetes in India, these 2 states, Tamil Nadu and Kerala, have the highest prevalence of diabetes. In fact, Tamil Nadu has the highest prevalence, followed by Kerala, Delhi, Punjab, Goa, and Karnataka. 16.9% of diabetic population aged up to 50 years are affected with some sort of diabetic retinopathy. And there's not much of difference between the various age groups, the 60 to 69, 70 to 79, and above 80. In the Indian subcontinent, only limited data are available on the prevalence of diabetic retinopathy in the general population. And these 2 are landmark studies which showed the prevalence of diabetic retinopathy in India: the Chennai Urban Rural Epidemiological Study, or the KSOS study, and the Aravind Comprehensive Eye Study, which reported about 17% and 10% of diabetic retinopathy among diabetic population. 4% has sight-threatening diabetic retinopathy, according to the SN Dream study published by Shankar Nethralaya. The current global prevalence of diabetic retinopathy is about 103 million individuals, which is projected to rise further to 161 million individuals by 2045. And diabetic macular edema, which is a sight-threatening condition, the prevalence is estimated at 19 million and projected to increase to 29 million by 2045. The earliest studies regarding the prevalence of diabetic retinopathy were the Wisconsin Epidemiological Study of Diabetic Retinopathy, the DCCT, and the UKPDS. And now that is almost 3 decades back, and now the prevalence has increased much more. That is, diabetes has gone into an epidemic proportion. In 2 studies from South India, the prevalence rate of diabetic retinopathy in non-insulin dependent diabetic patients were 34 and 37%. And in the Andhra Pradesh eye disease study of self-reported diabetics, the prevalence of diabetes was 22.4%. Now, managing diabetic macular edema, which is a burning problem in India. Diabetes is a growing epidemic affecting the working age population, which is expected to double in India in 22 years. The diabetic retinopathy burden in India, 42% of diabetics have some sort of diabetic retinopathy, 19% has sight-threatening diabetic retinopathy, 9% has a DME, and 17% has a proliferative diabetic retinopathy. The risk of comorbidities is further increased in diabetic patients with DME. Almost 1/3 of the DME patients can lose vision if not treated, and all diabetics are at risk of developing a diabetic macular edema. Although diabetic macular edema is treatable and reversible in the early stages, a chronic disease may lead to irreversible changes. Hence, the long-term prognosis for DME is poor. Hence, we need to institute treatment as early as it is diagnosed. These are the clinical features of the diabetic macular edema. We have the cystoid macular edemas, the breakdown of blood retinal barriers, stout posterior hyaloids, hard intraretinal exudates, vitreomacular tractions, all this due to microvascular damage, leakage of fluid, and macular edema, finally leading to blurring of vision. Now, the management of DME, the DME treatment has evolved over the past few decades. Prior to 1980, there was not much of treatment. I remember in our postgraduate days, it was not pre-1980, but it was in the 1980s, where a diabetic patient was diagnosed as diabetic retinopathy, and the advice given to the patient was to control diabetes and nothing more than that. 1980s, we had laser photocoagulation coming in, which started to halt the progression of diabetic retinopathy. In 1990s, we started using intraocular steroids. 2012 onwards, anti-VEGF therapy was used in diabetic macular edema. Of course, anti-VEGF came at the break of this century, but in diabetic macular edema, we started using it extensively after 2012, and now the aim is to optimize a treatment with intravitreal anti-VEGF agents, steroids, and lasers. For treatment of diabetic macular edema, we need a multifactorial approach which requires systemic control as well as ocular treatment. We need blood glucose control along with the control of hypertension, dyslipidemia, nephropathy, and anemia, and ocular treatment which includes anti-VEGF, laser, and intraocular steroids. In the Indian protocol for DME management, we give repeated intravitreal injections for 4 to 6 months, look at the DME resolution, then we go either for a treat and extend or a PRN basis of treatment where we give again injections or lasers. And as far as the Indian clinicians are considered, we try to keep the injection levels to the lowest possible within the safety requirements of the patient, because most of our patients in India take treatment from their own pockets and very few are covered by insurance or government programs. Hence, in India, we try to bring down the number of injections as far as possible, though it is not purely scientific. When there is a persistent DME, we switch to a newer anti-VEGF agent or we switch to steroids. In between, we give lasers. And that is how we manage diabetic macular edema in India. Now let us look at the various programs and projects which we have under the government or in association with the various governments. This was one of the programs started by the Public Health Foundation of India in association with the Queen Elizabeth Diamond Jubilee Trust. This was started in 10 states over 10 districts. Kerala was one of those states, and Thrissur was a district which was selected for this program. This was a program with the Public Health Foundation of India, the government of Kerala, and being part of Little Flower Hospital as the mentor institute, I was also associated with this program. This was done in Thrissur district. We took up 5 major hospitals, the Thrissur General Hospital and the 4 Taluk headquarters hospitals of Chalakudi, Kundangulam, Chavakad, and Kodungalur. This was a joint venture it was a tripartite agreement with the Public Health Foundation of India, the government of Kerala, and Little Flower Hospital. And it was expected to decrease avoidable blindness in Thrissur district due to diabetic retinopathy through increasing awareness, upgradation of skills of the ophthalmic staff, equipping the Taluk hospitals, and by providing treatment. This was supposed to be a pilot project which could then be a model for the government to take up in the other districts of the state. This was a monitored program by the Public Health Foundation of India, and we had our interim reports. We had a lot of challenges while implementing this program. And in the interim reports, we gave a lot of recommendations regarding purchase of equipments, need for training the staff, posting of the trained staff in the appropriate institutions, have regular meetings, and all that. The project was started in 2016, September, when an MOU was signed with the government of Kerala. And fortunately, the the project was completed in 2019 before the pandemic set in, and the equipment was handed over to the government institutions in Thrissur district. We had a state task force committee. The project had funding where essential equipments were purchased. Optometrists and ophthalmologists were trained at the mental hospital, and we had a district level coordination committee. The patients were screened from the non-communicable disease clinics of the government hospitals, and we gave training to the ophthalmic assistants and optometrists for screening of diabetic retinopathy. Finally, there was a network of medical facilities, the primary health centers, the community health centers, taluk hospitals, district hospitals, the Medical College of Thrissur, and the Little Flower Hospital to provide primary screening, diagnosis, and treatment for retinopathy. And as this program went on, the government of Kerala also had a learning experience, and there was another project coming up in Trivandrum district later on with the on-aid study, which was taken up as the Nayanamrutham project of the government of Kerala, and it's still underway at Trivandrum. In this, the screening was carried out by optometrists using portable fundus camera. A unique ID was allotted to each patient. The images were uploaded in real time and reports were given at the site. Those patients who required referral were referred either to the Government Medical College at Thrissur or Little Flower Hospital, and laser or intravitreal injection was given at these places. Ophthalmologists in the health department were trained to treat diabetic retinopathy. There was a mass awareness program conducted. We printed booklets. The PHFI had its own material which was translated into Malayalam. In fact, all the 10 states translated it into their local languages. And this was the number of patients which we actually screened and picked up and treated. We mentored the partners, partnered with NCD clinics and medical college. We solicited the support of diabetologists, physicians, and nephrologists. There was a CCDR course which was run by the Public Health Foundation of India, and an endocrinologist as well as retina specialists were the trainers in this course, and we trained 6 physicians from Thrissur districts. More than diabetic retinopathy, it was the need of screening of diabetic retinopathy that was passed on to the physicians. We faced a lot of challenges because being a government setup, the NCD clinics were not equipped for diabetic retinopathy screening, but we could do it in Thrissur district and get the DR screening done from the NCD clinics. In between this project, we came across, in fact, we established one concept of training the patient or creating awareness with a 5-photograph concept of patient education. In fact, we had 5 photographs put up, of which 4 photographs are permanent. The first one is a normal fundus. We had it for the right eye as well as the left eye. The first photograph is a normal photograph, normal fundus. In the second slot, we used to insert the patient's photograph. The third one, we had a photograph of diabetic macular edema. Fourth one of a PDR, and fifth one of a vitreous hemorrhage. Same thing we had for a right eye and left eye, so that when the patient's photograph is inserted here, we could show them that this is how your eye should actually look like. This is how it looks like now. And if left untreated, it will go to this stage, or again this stage, or the last stage, which means blindness. So that was the right eye photographs and the left eye photographs. And the message conveyed was, act fast and save your sight. So that was the project which we had in Kerala. The various other projects which the various other governments implemented, which were equally effective in the respective states. The Ahmedabad Municipal Corporation came out with the Samvedana Eye Care project in collaboration with the World Diabetes Federation. The Shankar Nethralaya Diabetic Retinopathy program was initiated in Tamil Nadu by Shankar Nethralaya. The Mukhyamantri E-Eye Kendram of Andhra Pradesh is another project which has gone well in the state of Andhra Pradesh. The Aravind Eye Care System Diabetic Retinopathy project is running well in Tamil Nadu, and Nayanamrutam of the government of Kerala. Now, so far, about more than 5,000 patients have been screened, and 31% of patients needed a referral for treatment of sight-threatening diabetic retinopathy or because of ungradable images. The one positive fallout which I see from this program which we had in Kerala and passed on to the government is the government of Kerala has accepted a policy to screen all people with diabetes registered in the primary eye care clinics for diabetic retinopathy. Government has in principle accepted this, that a diabetic patient needs screening for diabetic retinopathy. Implementation is still a long way off. Miles to go before I sleep, and miles to go before I sleep. Thank you.
Thank you, sir, for that outstanding presentation.
We will move to the next session titled Revelation in Retinal Diseases. We have pioneers in the field of retina as chairpersons. Let us invite panelist Dr. Thomas Cherian, Senior Vitreoretinal Surgeon at Little Flower Hospital, Angamali. Dr. Manjit P.S., Vitreoretinal Surgeon, Associate Professor of Kota Medical College, to chair the session. And the moderator of the session, Dr. Rohan Nainan, Vitreoretinal Consultant at Chaitanya Eye Institute, Kottayam. Over to you, Dr. Rohan.
Good morning. So the first session is Approach to Central Serous Chorioretinopathy by Dr. George, sir. Dr. George Manayat is a senior consultant and professor at Aravind Eye Hospital, Coimbatore, with special interest in macular diseases. He is a prolific vitreoretinal surgeon and a surgical trainer for more than 150 VR fellows, including myself. And he has published more than 100 international publications, presented in numerous international and national forums, and he is a reviewer for multiple international journals also. And he has won awards for both his work in both AIOS and the VRSI Society. Over to you, Dr. George.
Good morning, everyone, and thank you, Dr. Varghese and Shishir. And it's a privilege for me to attend because we have Dr. Rohan and Dr. Shishir. Both of us them were with us in Coimbatore, Aravind. So I would be speaking to you on the approach to management of central serous chorioretinopathy. So we know that now there has been a paradigm shift from central serous retinopathy to central serous chorioretinopathy. Now we know it's a choroidal disease, and from capillary vasospasm it has moved to an RP disease, and now into pachychoroid spectrum, and recently into venous overload choroidopathy spectrum of diseases. So we used to look at this disease as a simple disease where generally self-limiting. You have a serous macular detachment on OCT and a point leak or focal leak on fluorescein angiography, and in a predominantly in young people with type A personality. Then we started seeing this more difficult variants of this disease, like for example the fibrinous variant of central serous chorioretinopathy, or a bullous exudative retinal detachment in central serous retinopathy, or even a leaking PED, even subfoveal leaking PED in central serous chorioretinopathy. And so when you look at these subset, and you have to understand that this is serous PED with subretinal fibrinous exudation, a variant of CSC, and fluorescein angiography. When this goes into a chronic stage, you see this multiple diffuse leaks all across the macula called as diffuse RPE epitheliopathy. Or you find these findings of intraretinal cystoid spaces, outer retinal photoreceptor elongation, and chronic PED signs, which point to a chronic disease where it is difficult to treat this disease. And the late sequelae is a cystoid macular degeneration, where there is no more subretinal fluid. Huge cysts are seen at the macula. These are not cystoid macular edema, but it's a late sequelae of CSC. Now with swept source OCT, we see that this disease is part of the pachychoroid features, more than 400 microns of choroidal thickness with dilated hallux vessels with overlying choriocapillary compression. And this disease originates in the choroid. It could be a diffuse choroidal thickening, or it could be a focal choroidal thickening, as we see in peripapillary pachychoroid syndrome, which is also a variant of CSC. Now we have the ICG angiography, which shows these early ICG findings of these dilated hallux vessels called Pachy vessels, or in the mid or late phase you see this choroidal vascular hyperpermeability. This is where to treat these patients, not at the RP leaks, which keeps recurring again and again. So this was what I was referring to us when there is a preferential nasal macular choroidal thickening with nasal macular fluid, intraretinal and subretinal fluid. This variant is seen in older individuals, and usually it's a bilateral disease where you see the peripapillary fluid on the papillomacular bundle and on the nasal side, and the peripapillary RP mottling, peripapillary Pachy vessels and choroidal vascular hyperpermeability and fluid on the peripapillary. This is a difficult variant of CSC to treat. So now moving to the treatment part of it, generally self-limiting. So we observe these patients for 3 to 4 months for spontaneous resolution. If it persists beyond 3 months, or if it recurs in the eyes with visual deficits, or other eye has a permanent visual deficit because of the CSC, then we need to intervene early. Or if you see the signs of chronicity developing in either of the eye, or patient has occupational or other needs like pilots or surgeons or some, we need to intervene early. So the simplest treatment is to treat that current episode with 2 to 3 faint grade 1-2 burns to the areas of early fluorescent point leaks, which are extrafoveal. That has been the time immemorial, that is a treatment for CSC. But it hastens recovery, but it doesn't prevent any recurrences or progress to the chronic stage of the disease. So now that is extrafoveal leak. What do you do if the leak is in subfoveal or juxtafoveal, wherein these conventional lasers, causes damage to the RP at this level, whereas when you have short pulses of laser, which doesn't cause the damage to RP, but it stimulates the RP and enhances the absorption of fluid. This is subthreshold micropulse laser, which has been promising in the treatment of CSC. So without this damage to the RP overlying retina, subthreshold micropulse laser. So it has been shown effective in studies. Problem currently is that there are no uniform parameter. Laser parameter use different studies use different parameters. So for the retinologist, there is no current uniform parameters. In this regard, we had done a trial in Arvind and came out with a titrated and sequential micropulse laser, wherein the least energy 5% duty cycle 200 milliseconds and 100 micron. This is kept standard. Anybody anywhere can reproduce it, and we find an extramacular threshold burn with the minimum energy and reduce it by 50% and treat it transfoveally. So this has been shown around 80% and reproducible, and if there is suboptimal response, anytime you can enhance the energy by 10% and treat it again at the fovea, across the fovea transfoveally. So this is a yellow micropulse laser which is fovea safe to treat transfoveally without damaging the fovea. So now moving to PDT or photodynamic therapy. This is the gold standard currently for the treatment of CSC, and 90% success, and it addresses the choroidal problem by long-term choroidal vascular remodeling, and no more recurrences and no more, it is effective, reduces the choroidal vascular permeability, which is the basic pathology of chronic CSC. So half-dose PDT or half-fluence PDT has been shown to be equally effective and around 90% success. Even in Indian eyes, we have published the Indian data of half-fluence PDT shows around 90% success in chronic CSR, which are persistent at least 6 months or more in 90% of these patients. So these are case examples where you have this subfoveal large PEDs and subretinal fluid, and there is a diffuse RP leakage or the leaking PED under the fovea. There is no way to treat these patients actually. So this is a half dose PDT, the subfoveal PEDs and fluid. Post-treatment, you can see the fovea is normalized, the PED is gone and fluid is gone. So this is one of the prototype case where it shows. And newer imaging modalities, now we have the ultra wide field ICG, which captures almost till the aura. So it is shown that in 80% of the CSC, you have this congested vortex vein ampullae corresponding to the quadrants of choroidal vascular hyperpermeability of CSC. So this suggests that there is a choroidal outflow congestion or obstruction in CSC. Something similar to the uveal effusion syndrome that we have seen. So in this regard, Spade and colleagues were the first to show that normal eyes where the vortex vein ampullae, this is ultra wide field ICG, the normal horizontal raphe is not obliterated by the vortex vein systems that we have in quadrants, where in patients with CSC, there is an intervortex anastomosis between the superior and inferior vortex vein ampullae happening at the macula. It's a compensatory mechanism to overcome the choroidal venous congestion by our body's own compensatory mechanism. These intervortex anastomosis happens, and this is what we call as Pachy vessels that we see on OCT or ICG angiography. For example, we had published, this is the first case in literature that we had published where the chronic CSC in this patient for 3 years we have been treating. This patient suddenly develops a bullous exudative RD. You can see this chronic CSC with bullous exudative RD with peripheral choroidal detachments, along with in CSC eyes with peripheral, something like a uveal effusion syndrome. You can see these CDs in the periphery, and this patient has a diffuse leakage in the setting of this peripheral CD. So, and you can OCT, you can see the fibrinous exudation at the macula, which is a classic feature of fibrinous CSC, and the ultrasound also shows the peripheral choroidal detachments. And after PDT, you can see the peripheral CDs have disappeared, only the fibrin band is remaining, and the exudative retinal detachment has subsided. This is yet another patient initially treated in the left eye. This is a good eye of the patient showing fluid and extremely thick choroid, pachychoroid with serous detachment, and it was misdiagnosed and treated as uveal effusion syndrome because the other eye has exudative RD with choroidal detachments. So this is a good eye of the patient. So after the vortex vein decompression surgery in this eye, left eye, and the steroids, the macula of RD happened. Because of the steroids usually is contraindicated in CSR. So we don't have any other way. We went ahead with vitrectomy for this CSR patient with endodrainage and silicone oil implantation to resettle the macula. This is under silicone oil that macula is resettled, and the fluorescein ICG angiography is done under silicone oil. So here you can see that the choroidal vascular there's no doubt about the diagnosis. The chronic CSC in the right eye or the good eye of this patient. And when you see the left eye, you see this fibrin band that is organized after the vitrectomy surgery. But there is a diffuse leakage extrafoveally which was treated in this patient under silicone oil, and then the disease settles down. This is under silicone oil, and retina is doing well, and then there is no further leaks on ICG. Good to go with silicone oil removal in this patient. So last, to touch upon another option that we have is eplerenone, which had a recent interest in treating CSC for 50 milligram Eptis for 3 to 6 months. But then we had done a study, even the randomized trial and the Indian study which LVP and Arvind that collaborated, we didn't see only 20% success. So not superior to placebo in the treatment of chronic CSC, but when there are no other treatment options, probably can try this. So lastly, to touch the predictors of poor visual recovery, when you see this kind of cystoid degeneration, that's a late sequelae with poor prognosis, or if you see these acquired vitelliform lesions or AVLs in the setting of PED CSR, this pre and post PDT, even the PDT has not worked in this case. So it's a poor prognostic indicator. Also to keep in mind some of the mimickers of chronic CSR, because here you see this fluid at the macula. The ICG shows a polypoidal lesions in the subfoveal. So it's a PCV mimicking as CSC. Another great mimicker is something called dome-shaped maculopathy with the subretinal fluid. But this is seen in high myopia, and at the edge of the staphyloma, the macula is bulged anteriorly and it can mimic CSR. If you see this kind of leak, think of chronic CSC, but ICG angiography shows these hypo spots here and no choroidal vascular hyperpermeability, differentiating from CSC. Again, one more mimicker of fibrin CSR. So these are referred as chorioretinitis actually. This is not chorioretinitis, this is a leaking PED with subretinal fibrin. Fibrin variant of CSR is a great mimicker. So to conclude, CSC, which was simple disease, is now part of pachychoroid disease and now moving to VOC spectrum of disease, a great mimicker. Focal laser is the simplest treatment reserved for patients who have persistence more than 3 months with extrafoveal leaks, and half fluence or half dose PDT is a gold standard for chronic CSR, which we are currently doing with limited availability of Visudyne in India. And subthreshold micropulse or epineuron is reserved as an alternate treatment option with a lower success rate, but then when you don't have other options, you can use that. And understanding the mimickers and OCT biomarkers are important in the visual outcome of this disease, which is sometimes complex to manage, at least in around 20% of the cases. So thank you for your kind attention.
Thank you, George sir, for the presentation. I'd like to remind everybody that discussions will be towards the end of the session. Moving on to the next topic is current approach to venous occlusions by Dr. Shane Matthew. He is working as a senior consultant at Chaitanya Eye Hospital, Trivandrum, and he has done his vitreoretinal fellowship from Shankar Nethralaya, along with degrees like FRCS Glasgow. Over to you, Dr. Shane.
A warm good morning to all of you. Thank you very much for inviting me, even though I'm part of the club, and an excellently organized meeting and excellent job by Amita Eye Care and team. George talked about choroidal congestion and venous stasis. I'm going to talk about retinal congestion, and I think it's all about congestion everywhere, tension and stress. I think that is the reason for all these diseases. It's impossible for me to really cover the entire topic in this stipulated time, but I thought, as Dr. Adoop said, I'll just throw a few sparks by which you can go home and expand on it. So why study RVO? It's second leading retinal vascular diseases after diabetic retinopathy, and it's a huge burden, especially in the elderly. And it has an unpredictable chronic course and needs individual clinical and emotional care in the practice. Risk factors, sometimes you see absolutely no risk factor in patient developing RVO. One of the most important factor is the age. Advancing age is one of the most important risk factor. So is other risk factors which we all know. And uncommon risk factors are not so uncommon. When you see a bilateral disease or when you see a young adult developing an RVO, you should think of uncommon factors such as polycythemia. I recently had a talk with a hematologist. He said in our part of the world, in PATHANAMTHITTA district, polycythemia is a very rampant thing, which he's actually doing a study on why it is happening so. And hyperhomocystinemia, so just a plasma homocysteine can give us value, can give us an idea about why this gentleman is receiving or having a retinal venous occlusion. Inflammatory disease such as Behçet's sarcoidosis, tuberculosis, and chronic renal failure, yet another common cause of retinal venous occlusion in our practice, has to be looked into. This is a standard, all standard textbooks give this, how to investigate a case of RVO. These are the routine investigation that you do for almost all cases. For young RVOs, you need some other investigations as well, which is there in, I'm going to go only into the most important things. So now young RVOs has to be differentiated from old RVOs or bilateral RVOs, because young has got a better prognosis, needs lesser treatment burden, and has got uncommon etiologies associated with them. So first you see an RVO, case of an RVO, visual acuity is extremely important. Check for RAPD and then you see the fundus. It's very easy to diagnose an RVO. Here you can have a central, so this is a central retinal vein occlusion, and that is a branch retinal vein occlusion, and this is again a hemicentral retinal vein. So it's very easy to diagnose an acute RVO. But what is not so easy is a peripheral RVO. Peripheral RVO, inferiorly you can see this gentleman is absolutely asymptomatic and has got an RVO in the periphery. Many scientists have actually described this entity for an impending RVO. We call it an evolving RVO or a venous stasis retinopathy. All you see is few dilated veins and you see multiple dot and blot hemorrhages, and this is an impending retinal venous occlusion which can lead to a non-ischemic variety where the visual acuity is 660 or better. Patient does not have an RAPD and the fundus examination shows something like this. An ischemic vein occlusion can be a little more dramatic. The patient visual acuity is in the range of counting fingers 1 meters, and there is a definite RAPD and ERG B wave abnormality. Studies have shown that B wave amplitude reduction by 60% is almost pathognomonic of ischemic retinal vein occlusion. So examining of the optic disc is extremely important. Examination of the optic disc is extremely important. This patient had glaucoma and stopped anti-glaucoma medication after cataract surgery. What happened? Superior branch retinal vein occlusion. All we had to do was to control the glaucoma and it subsided on its own. So have a look at the disc, which is extremely important in cases of retinal venous occlusions. Reparative process or self-healing is known to happen with RVOs, especially BRVOs. This is a branch retinal vein occlusion. Over the course of time, in 1.5 years, good collateral started forming. So it is important to look for the reparative process. One is collateral, and this is another central retinal vein occlusion with a good optociliary shunt or a disc collateral. Collaterals are reparative process by which the complications are avoided. This shows that the disease is coming to a halt very soon. And studies have also shown that if you see this in a case of RVO, central retinal vein occlusion, the chances of anterior segment neovascularization is very less. So it is important to look for that. Other reparative process includes retinal capillary macroaneurysms as well as intervenous anastomosis. This is a case of inferior branch retinal vein occlusion. The anastomotic channels is taking the blood through this way into the posterior circulation. Thereby the patient has got an excellent vision. Yet another interesting thing to notice, usually in a BRVO or a branch retinal vein occlusion, the occlusion is at the site of the AV crossing changes. So if you see that the branch retinal vein occlusion does not happen at the AV crossing changes here, okay, so this is the AV crossing changes here, but the occlusion is somewhere here. So if you see a location other than an AV crossing change, that is an indication to think that this patient may have an etiology other than hypertension or diabetes. So uncommon etiology. This is a medical professional who had tuberculosis which led to vasculitis and a branch retinal vein occlusion. So a lot of these clinical points help us in managing and prognosticating, even helping to follow up this patient in a much better way. So one word about reocclusions. You will have a vein occlusion and then it heals. After some time you get a reocclusion. So what does that mean? Now we know that reocclusion means there's systemic instability. So go back and check all his systemic parameters once again. And we also know that even if we inject or do treatment, we do not reach back to the pre-occlusion vision. So a guarded prognosis has to be instituted to the patient, and this carry a higher risk for neovascularization. So closely follow up this patient for neovascularization of the iris. Other sequelae include epiretinal membranes, macular holes, and chronic cystoid macular edema, and so on and so forth. So how do we look for the progression of the disease? Progression of the disease involves worsening of vision, fundus changes, increase in cotton wool spots or hemorrhages, presence of neovascularization. So in a non-ischemic RVO, there is a 15% conversion to ischemic variety in 4 months, whereas 50% of the ischemic CRVOs develop neovascularization of the iris in 4 months. That means an ischemic CRVO, we need to follow up very closely. Monthly follow-up is extremely important, at least in the first 6 months. And then on, probably depending upon the patient has developed NVI or not, we can reduce on the number of follow-ups. So imaging studies, routine imaging had its own flaws, and now we have multicolor imaging. It's extremely useful to detect subtle abnormalities. This is a near normal looking fundus, but when you look at the blue reflectance image, you can see that inferior sclerosed vessel. This is a case of inactive inferior old hemicentral retinal vein occlusion. So multicolor imaging is part and parcel of my follow-up with RVO cases. OCT in RVO, like any other OCTs, we look into macular edema. The impact of morphological changes on visual acuity in RVO seems to be unclear because of the fact that there may be ischemia associated with it. Outer plexiform hyperreflective foci has a negative correlation on visual acuity, and of course, central retinal thickness is the robust variable still available. OCT angiogram is a non-invasive way of finding out capillary non-perfusion. We can now find intraretinal neovascularization using OCT angiogram, which is a precursor of clinically visible neovascularization. So finding this helps to monitor the patient closely and treating as and when needed. So wide field fundus fluorescent angiography is yet another investigative modality which helps in denoting or diagnosing peripheral retinal ischemia and assessment of collaterals and differentiating that from neovascularization. The CVOS study, the time immemorial study which helped us in identifying ischemic CRVOs, had its own flaws. Basically, they used routine 8 standard field photography, which did not pick up the peripheral areas of capillary non-perfusion. So 20% of the neovascularization developed in the patients which had early treatment when compared to 35% in the no early treatment. That means they missed on peripheral ischemic areas, and that is what we are going to see with wide field fundus fluorescent imaging. So wide field fundus fluorescent imaging helps us finding out the peripheral capillary non-perfusion areas in a much better way, whereby we can predict which ischemic CRVO is going to develop neovascularization soon. In this respect, we now talk about an ischemic index, where we divide the number of ischemic areas by the area of perfused areas. So autofluorescence is yet another investigation which may come handy, especially in impending RVOs, where we see nothing but the patchy ischemic retinal whitening, which is a fern-like hypofluorescence along the venules. Intravitreal pharmacotherapy is the mainstay of macular edema. The first line would be anti-VEGF followed by steroids, and macular grid is now reserved for treating probably a leaking retinal capillary macroaneurysms or chronic cystoid macular edema, non-amenable to other forms of therapy. Laser photocoagulation is meant for anterior segment neovascularization, retinal neovascularization, and targeted laser photocoagulation can be instituted if you know about the ischemic index. Again, vitrectomy for vitreous hemorrhage and complications of ERM and macular hole. Radial optic neurotomy and schistotomy has been done in the past but not used anymore due to lack of evidence on its clear benefit. So a word about neovascular glaucoma, which is the main culprit in losing vision in these patients. And there is a concept of labile disc, where the disc is very labile to increase in IOP, especially in RVOs. So our previous tendency was to do laser, give injection, see IOP is controlled, getting controlled. If not, the last resort, go for a shunt procedure. I think we are slowly shifting from that. We immediately try to do a shunt, probably after injection, bring down the IOP so that we have enough time to do the laser and then salvage the eye. Well, monthly injections for 6 months and then on to continue with RVOs was the dictum ever since. But now with the huge treatment burden, there have been modified current treatment protocols. This is probably something which I follow in my practice now. I give 3 injections initially to these patients and divide them or stratify them according to good responders, moderate responders, and poor responders. For the good responders, probably I can call them for later follow-ups, but the poor responders, I call them for frequent follow-ups. So depending upon the visual acuity, we can approximately prognosticate these RVOs. A patient presenting with good visual acuity, there is a chance that it can remain good, and the patient with bad visual acuity in the form of corner finger 1 meters in ischemic CRVO, they may not improve at all. And the visual acuity from 2080 to 2200, the clinical course is really variable. Some may improve, some may not improve at all. So the take-home message is OCT angiogram and ultra-wide field angiograms are integral part of RVO management. The ischemic index is gaining interest to look into the natural course, prognosis and follow-up of this disease. And there is a definite role of peripheral razor photocoagulation, especially in recalcitrant macular edema or in susceptible eyes which can develop neovascularization, and stratification of patient who needs pharmacotherapy to reduce treatment and follow-up burden. Thank you.
Thank you, sir, for the presentation. Now we move on to the third session, which is newer anti-VEGFs in AMD by Dr. Gopal S. Pillai. Sir is currently the professor and the head of Department of Ophthalmology at Amrita Eye Institute, Kochi. He's been trained in both ophthalmology and vitreoretina from AIIMS, New Delhi. He has held numerous key positions in both state, national and international ophthalmic societies and has more than 40 publications in various journals, including international and national ones. He has also won many numerous awards, and he's a passionate teacher and researcher, and he's currently focusing on basic research and drug development along with clinical trials. I'll now hand over to Dr. Gopal S. Pillai.
Thank you very much for the kind introduction. So I will be talking about the new drugs in age-related macular degeneration. So when you say new drugs, what were the old ones? Bevacizumab, which is Avastin, ranibizumab, which is Lucentis, which became Accentrix, and then it's plethora of biosimilars. About 6 or 7 companies are making biosimilars of ranibizumab. And then came aflibercept, which is a little rung on top of that. And now we have the 2 new drugs. One is brolucizumab and the other one is faricimab. And I'll be speaking on these 2. So these are the things that I will go through: an overview, unmet needs in neovascular AMD, and what is the significance of fluid. Then we will go into brolucizumab and the Hawk and Harrier trials, some cases of that, Tenia and Lucerin trials of the faricimab, and some of the cases. So as you know, AMD is a leading cause for severe as well as irreversible vision loss all across the world. About 12 to 13% of patients, of adults over 65 years are affected. And India is no exception. The number of AMDs are keeping on increasing. Diabetic retinopathy was our significant numbers, but now AMD is also significantly increasing in numbers. So it's number 1 cause of blindness in the Western developed countries. And in India, it is still cataract. It is moving on to retinal diseases quite a lot. A significant unmet need exists for many patients. What are they? One is unresolved fluid, which means that even after 2 years of treatment, some of the patients continue to have fluid which requires injections. And that leads to a very high injection burden. And whenever a high injection burden occurs, there will be mental fatigue of the patient, financial depletion, and probably 60% of the patients probably stop treatment. Now, day before yesterday, I was having this meeting with one of the US group who said that their average number of injections is about 3 to 4 in a year, where you require about 7 or 8. In India, the number is about 2 to 3 in a year. So even in a very developed country, the number of patients who adhere to treatment outside of clinical trials in the real world is actually a little less. So that's a major problem. And so what is the relevance of fluid? See, we have the retinal pigment epithelium here, and below the retinal pigment epithelium is the fluid, sub-RPE fluid. Then we have the subretinal fluid itself, and here is the area where there would be intraretinal fluid. All 3 are significantly important, and in CAT trial, we found that 82% of patients had subretinal fluid, and 75% of patients had intraretinal fluid, and about 50% of patients had sub-RPE fluid. And in the real world, fluid is what drives the treatment, not even decrease of vision. If there is fluid, people inject. And if there is no fluid, people do not inject. So intraretinal fluid and subretinal fluid are two key indicators for continuing treatment. And if we have absence of fluid, you can see that the visual acuity of those patients are significantly better than in the presence of fluid. Now there is another problem. Whenever you have staggered injection, which is not very, very frequently, you will have a sawtooth visual acuity or fluid morphology, which means there will be fluid at some point of time, there will not be fluid at that point of time. So this fluctuation leads to more damage to the retina. Okay. Now under treatment, as I said, is a major problem. These are the real world statistics which tell that about 3 to 4 injections, 2 to 4 injections only. To maintain the visual acuity of a person with AMD, wet AMD, mostly you will require about 5 injections. And to improve the vision of those patients, you will require approximately 8 injections. So 5 injections to maintain, 8 injections to improve vision is what is usually required. But generally in India, we get about 2 to 3 injections on an average. So that is a basic problem. And many patients drop out by about 3 years. In the first year, probably everybody will be very nicely following up and the visual acuity will improve. By the second year, it may stabilize. By the third year, they will stop coming. And by the fourth year, they will lose vision. So, but having said all that, even with 2 or 3 or 4 injections, vision loss can be prevented. So even though we say that the visual gains, the maximum visual gains are not possible, but vision loss can be preventable even with those many patients. Now let us move to brolucizumab. Brolucizumab is a molecule, it's a very small molecule, which has, I will just go to the differentiation between aflibercept, ranibizumab and brolucizumab. Here you can see that the molar concentration is about 12 times higher than even aflibercept and about 24 times higher than ranibizumab and bevacizumab, which means the molar concentration, because of a small molecule, the molar concentration is very, very high. And this molar concentration, which is high, is what makes brolucizumab penetrate deeper into the retina and also have a long-term effect and efficacy. These are the Hawk and the Harrier studies in which 1, 2, 3, 4, 5 injections were given on 4 weeks, 8 weeks, 12 weeks, and 16 weeks. These were the initial brolucizumab injections. And it is compared to aflibercept standard dosing. After the loading doses, brolucizumab was given on a 3-monthly regimen, which means 12 weekly you injected, whereas aflibercept was given on an 8-weekly regimen, which was a standard of care, which was accepted. So 3-monthly brolucizumab versus 2-monthly aflibercept after the loading doses. You can see that both the worms are almost together. So which means that even if you move to 3-monthly injections, reducing the number of injections to 4 in a year, you could maintain equal visual acuity as that of 2-monthly aflibercept injections. So, but even despite that, you can see that it achieved more fluid reduction, more subretinal fluid reduction, and central macular thickness reduced, and more number of patients had IRF in aflibercept group than the brolucizumab group. So even with lesser number of injections, all these slides tell us that even with lesser number of injections, the fluid would be much more reduced in brolucizumab as compared to 2-monthly aflibercept, and the visual results are almost equal, which reduce the number of injections from 6 to 4 in a year. So that is what is happening. So in PCV also, you can see that about 70% of patients were maintaining on 3-monthly injections. All right. Now let us go to some clinical cases. This is one choroidal neovascular membrane with a bleed, and you can see that even though the bleed is large, visual acuity there was about 6/24, and there was a large pigment epithelial detachment here, large pigment epithelial detachment, and ICG showed some polyps there. And this is after treatment with brolucizumab. You can see that the bleed is reducing. The pigment epithelial detachment is persisting a little bit, but you can see that this large pigment epithelial detachment completely flattened down and the vision improved to about 6/9 after brolucizumab injection. This is November 2022, 6/6 parts. So considering that the large bleed is there with large pigment epithelial detachment, this is the result with 3 or 4 injections of brolucizumab. This is another case in which there is a large bleed, multiple bleed. Probably this is more older and this is more, recent. And this was a late leakage of indeterminate source, and there was ICG, there was a polyp. Here there is a polyp. And you can see the treatment results. You can see that slowly visual acuity is improving. And you can see the OCTs also, the pigment epithelial detachment and they are all reducing. And you can see that it is much better with a visual acuity of 6/9. Again, this is another case with large subretinal bleed. You can see the polyps right there. And this is the large pigment epithelial detachment with subretinal fluid, which is reducing with brolucizumab. And you can see the further improvement even to 6/9 vision. So another case, again, large pigment epithelial detachment with fluid, which reduced 6/12 and even 6/6. This is the improvement with brolucizumab, which is there. Another case, very tall pigment epithelial detachment, which significantly reduced. Now we'll come to the next drug. So you know that we have a drug which has a significant effect, which lasts longer, wow factor in terms of reduction of vision and durability. Now let's come to the next drug, which is faricimab, which is acting on another activity also, another receptor also. You know, there are VEGF, which we have been talking about for the last 15 to 20 years. Anti-VEGF is what we are using. Now there's something called angiopoietin 1 and 2, out of which angiopoietin 2 is an anti-inflammatory receptor. And when Ang2 gets connected to the Tie2 receptor, then it will upregulate VEGF. So what happens is when VEGF and Ang2 are upregulated with each other. So when VEGF increases, Ang2 increases, and when Ang2 increases, VEGF increases. So if you had something which blocked both VEGF and Ang2, would it not be better than just blocking VEGF alone? Was the question. So that is why we moved into this particular drug called faricimab. One small chain will block Ang2, and the other one will block the VEGF. So this is how this whole thing acts. So the single molecule has an Ang2 blocker on one side and VEGF blocker on the other side. Again, these are the TENAYA and the LUCERNE trials, which compared this particular drug either 3 monthly or 4 monthly with aflibercept 8 weekly. Just like in the other trial, aflibercept was given every 2 months. This is either 3 monthly or 4 monthly after the initial loading doses. And you can see that both the worms are almost together. And many patients could be shifted on to 4 monthly intervals. So I'll just go into that fast. Yeah, about in 48 weeks, about 45% could be moved to 4 monthly injections, which means 3 injections in a year. And about 80% of them could be moved into 3 monthly injections. So that is even better than the brolucizumab results, and these are the side effects. So some of the clinical cases of faricimab again, subretinal bleed. This was a subretinal bleed right in the center. It had a TPA and gas injection, and the visual acuity improved to 6/36. And now you had a drop in vision to 4/60 after some time because of further increase in the edema. And you can see that after 6 weeks, the visual acuity is back to 6/36. Another choroidal neovascular membrane, you can see the leakage here. BCVA was about 6/24. Large PED with fluid, and that getting reduced, and your vision acuity improving with Vabysmo. Again, another case, you can see the large PED again. This is the OCT angiography, which shows that, and you can see that that is reducing, significantly reducing, initially with ranibizumab. Then we move to Paganex. You can have the Paganex results. And then as Vabysmo came, we shifted over this patient to Vabysmo for further increase in the durability. And these are Paganex and post-Paganex. You can see each time post-Paganex, about 2 months, the PED increases significantly. And that is why we shifted the patient to Vabysmo and maintaining for a little longer period of time. So in summary, all fluid is pathological, be it sub-RPE, subretinal or intraretinal. If there is greater fluctuations in fluid, it finally leads to a poor outcome. In Hawk and Harrier, as well as in Lucera and TENAYA, you are seeing brolucizumab and faricimab to have very good, robust visual acuity gains and a reduction of fluid with lesser number of injections. Now we are moving into a treatment where with 3 monthly or 4 monthly injections, we will be able to maintain the stability of this patient, reducing the number of injections to 3 or 4 in a year. Thank you very much.
Thank you, sir, for that wonderful presentation. Because we are running a little short on time, we'll be having a short discussion. I'd like to ask the panelists.
Yeah, the first talk was by Dr. George Maneth. George is here. George, our age-old practice was when you have a CSR, you wait for a couple of months to see for a natural resolution and then go for an FFA. Now with all the variants of the CSR, would you like to go for an early FFA or would you still persist with 2 to 3 months?
For the first episode of CSR, I don't think we need to image with an invasive angiography of any sort if it's a first episode. And then I think we'll wait for the give the benefit of natural history and wait for at least 3 months before we do any sort of invasive imaging. And we have the, if you want to rule out in the setting of a pigment epithelial detachment, we could do an OPHTHA or CT angiography to rule out any, sometimes it will be like that. You see the serous PD and at the edge you get this small neovascularization. To rule out, we have OPHTHA now. So otherwise observe and then for persisting cases, we do the invasive angiography and treat accordingly depending on what type of leak, where is the location of the leak, all these things. So as I mentioned in the talk, it hastens recovery in few of the lasers and recurrence cannot be prevented. So if it is a persisting case, then we'll have to go treat it accordingly.
Do you consider CSR still as a disease of the type A personality and psychosomatic, or is it all gone? It's all the
No. It is still, there is actually there are different variants of the disease which we saw, but then those variants also depend on what type of thing. We see more of, for example, in a with no type A or any other personality, it may be steroid dependent. So it may be, we see in, so in those, the phenotype is different. See, sometimes multifocal leaks, multiple PPDs, fibrinous exudation. So these are all seen in different phenotypes in different setting of the disease. It need not be always, but then always the pre-existing condition is there. So why the question still unanswered is why this choroidal congestion, unlike in a you have a reason for the scleral pathology there or a vortex vein abnormality there actually. So here that is still unanswered, but then there are multiple cases which present with choroidal congestion and a secondary fluid actually.
Thank you.
For a juxtafoveal leak, would you consider TTT?
Yeah, actually we do TTT, no. We currently it depends on whether it's a focal leak or it's a diffuse leak actually. So we see, I showed cases of diffuse leak. So if it's a focal leak juxtafoveal, our preference in the first episode or second episode is to go for a yellow micropulse laser in a titrated and sequential micropulse laser. We are actually about to publish it. I think Rohan was also part of that study actually. So, which is reproducible. So that will be the first option currently, yellow micropulse laser in the first episode or second episode if it's juxtafoveal or subfoveal leak. And only in persistent cases, we go for photodynamic therapy. Subthreshold TTT, I call as poor man's PDT, where without injecting the expensive medicine, we go for a subthreshold TTT. TTT or a diode laser, it's a 810 diode laser which has a deeper penetration into the choroid. It doesn't treat the retina. So how do we do it is do an extramacular test burn to find the least energy which causes a retinal whitening, reduce it by 50% and transfoveally treat at the fovea. That is basically we have reserved it for cases with diffuse leaks, not a point leak actually.
Fibrin CSR in pregnancy second trimester.
Yeah. That is a big challenge actually. That's a big challenge. So I have treated with subthreshold TTT. And second trimester actually Visudine, there is no absolute contraindication, but then we wait as much as possible towards term before considering a PDT actually. Otherwise, my first option is to do subthreshold TTT, which is an invisible burn with 50% reduced energy, and I have done it even without a fluorescein angiography. Fluorescein is also first trimester. It's a gynecologist will not allow you to do a fluorescein angiography.
Thank you, George. Shane's talk on vein occlusion, one message which Dr. Shane conveyed was there is a reparative process for a branch retinal vein occlusion, and after that, there is hardly any chance of having an NVE and a vitreous hemorrhage. Yes, many of these cases have a reparative process, but I would like to convey one message here. However much the reparative process can happen, at some point of time the patient can come back at some point of time, not very common, with an NVE and a bleed. So never let the patient go saying you are cured. So always be on the lookout, but your follow-up frequency can come down. It can be maybe once a year or even beyond that after that reparative process has happened. But be on the lookout for an NVE.
Sir, how common is an elevated homocysteine in Indian population? Because many patients, most of the patients we work up for a thrombotic event, we see homocysteine more than 15. So is it very common?
Not so common, but it's a part of routine investigation that we follow. I more and more after doing this investigation, I feel raised hemoglobin seems to be a more difficult problem to manage actually. In this part of the world, I kept repeating that. Even I was talking to the hematologist the other day. That is something which is alarming. We don't know why that is happening. Initially, during COVID times, we thought it's because of the wearing of the mask and things like that, which was more, but actually it is true. So I started checking for hemoglobin for almost all cases of vein occlusions, and I'm surprising to see the results, and many a times the hemoglobin is on the higher side. Yes, homocystinemia is also yet another cause. COVID times we saw outbursts of venous occlusions as well. I didn't mention that in my talk. So that had a different pattern sort of. I'm sure all of you will agree with me.
Did you check for families for this polycythemia? Is it genetic factor?
Yeah, so familial polycythemia vera, polycythemia rubra vera, all those are familial polycythemias. But even otherwise also we are coming across polycythemia.
Hypoxia is a stimulant for polycythemia. And many of these patients, 60 plus, who are diabetics, hypertensives, may have OSA. And that may cause hypoxia and polycythemia. It is very easy to treat polycythemia because you have to bloodletting. I mean, he can donate his blood very frequently. That is all. It's very easy to treat.
And hematologists also told me that they check for a JAK kinase inhibitor. JAK kinase. Basically, that's a genetic predisposed for developing. So if that is positive, then they might give some drug. But otherwise, venesection is the treatment of choice. Yes, that's also important. Even if the patients recorded a normal BP, go for a 24-hour BP monitoring. I'm sure you'll pick it up.
At least in the Indian scenario currently, the age is not a bar. At least any vein occlusion earlier we used to classify as young and old, young less than 40 years. But then any person who has hypertension is undetected most of the time, and first episode will be a vein occlusion and homocysteine also in less than 60.
Thank you. And Gopal's talk, the one message which I got from Gopal's talk was repeated fluid appearance and disappearance is detrimental to the retina. So in India, most of us, after a loading dose of anti-VEGF, we go for a PRN regime. And PRN means after the fluid appears, we treat and the fluid goes down. Repeated injections and repeated coming and going of fluid is not good. So that takes us back to the treat and extend strategy rather than going for a PRN regime in neovascular AMD.
Yes, absolutely true. I try to impress upon the patient the need to follow a treat and extend regimen in which in 2 months if the fluid is not come, then we will try to increase the duration and see whether fluid is coming. And when fluid is coming, so that is the approximate time point where you will require the next injection. So in a strict treat and extend, even if there is no fluid, you may consider an injection and then further increase the duration. Initially, you can do that to know how exactly this patient is after 3 or 4 injections or 5 injections. You will know what would be the durability of that particular anti-VEGF in him. And then now we have more longer acting, so we will try to move out and see whether that durability can increase. And so the patient can, and many patients now don't require an injection for 6 months, etc., also, who were on regular injections before.
Have you seen vasculitis with brolucizumab?
I had 3 intraocular inflammation with brolucizumab. One was quite severe, but fortunately all 3 of them had recovered visual acuity with systemic steroids and topical steroids. So the VRSI study group has recently published 21 centers across India. I am part of that. Probably Thomas is also part of that. We had about 0.79% was the incidence of brolucizumab associated intraocular inflammation in India. The clinical trials showed about 4.6%, which is very high. And in India, the reported incidence currently is about 0.79%.
Was that after repeated injections or did that come after first injection?
Yes. All these conditions were after repeated injections. And that is why after 4 or 5 or 6 injections, I may shift out to, in those patients who would afford a brolucizumab, I would try to move to Vabysmo. So that is what was happening. And again, I want to tell you that the wow factor in terms of brolucizumab is not there with Vabysmo, because brolucizumab has a very, very significant drying effect, but the problem is that of an inflammation. So now I think I would reserve brolucizumab to an area where the activity is not getting reduced. I may give one, but not repeat.
But still loading dose you give monthly?
No, not monthly. With brolucizumab, when I start, I don't follow the loading dose, because some patients after 1 injection, after 3 or 4 months only the fluid will come back. So I don't follow loading dose.
Thank you very much. I think we are encroaching on the time for the next session, so we'll wind up. Thank you very much, all the speakers, George, Shane, and Gopal, and all my fellow panelists.
Now, I would like to request Dr. Varghese Joseph to hand over token of appreciation to Dr. George Maneth, Dr. Shane Matthew, Dr. Gopal S. Pillai, Dr. Thomas Cherian, Dr. Manjit P.S., and Dr. Rohan Nainan.
Our next topic is traversing the ocular surface. Let's invite the panel for discussion. Chairpersons, Dr. Kala B. Thotam, Senior Consultant, LASIK Surgeon at Chaitanya Eye Institute, Cochin. Moderator, Dr. Sumi Lucas, Assistant Professor at Believers Church Medical College, Thiruvalla.
Over to you, Dr. Sumi Lucas, for the session.
We'll move on to the next session, Traversing the Ocular Surface. I invite our first speaker, Dr. Anil Radhakrishnan. Sir needs no introduction. Sir is an eminent speaker in the field of cornea and refractive services. He is currently working as Associate Professor in the Department of Ophthalmology at Amrita Institute of Medical Sciences, Kochi. He has done his cornea specialty fellowship from L.V. Prasad Eye Hospital. He has many awards and accolades to his credit. And I hand over to you, sir.
Yeah, thank you, Sumi, for the kind words. And I would like to really extend my gratitude to Dr. Nitha, Varghese Joseph, sir, and his entire team at PATHANAMTHITTA Ophthalmic Society for giving me this opportunity to speak to you in this platform. I think after the interesting retina session, we'll move on to dry eye. I don't know what I can cover in the next 10 minutes, but I'll try my bit. So we are all aware of the lacrimal function unit. The cornea and the ocular surface is a very sensitive structure. And I think it is a more sensitive structure. It's almost 100 to 300 times than that of, more sensitive than the adjacent skin. So you have these impulses, sensory impulses going from the lids, from the upper mucosa, and from the ocular surface all the way right up to the trigeminal nerve. And the efferent impulses are coming out through the superior salivated nucleus, which reaches the ocular surface through the facial nerve. That is the parasympathetic output I am talking about, which is primarily responsible for the dry eye, for the tear secretion. You have the sympathetic impulses, then you have these neurotrophic factors, which are very, very important, of which the science has not really understood about. So this tear secretions that is made by your lacrimal glands, it's very rich in electrolytes, all the proteins, it has very good amount of mucin, and which makes it a really very important thing. And it coats the ocular surface, and none of the artificial tears come anywhere near this. So I'm not going to the definition of the dry eye, but we all know that it's a loss of homeostasis of the tear film, whether it's the quality or the quantity, and in which the tear film instability and hyperosmolality, along with a lot of factors like ocular surface inflammation, neurosensory abnormalities are all play important role. I think it's also important to realize that what is pain? Pain is the International Association for the Study of Pain defines pain as unpleasant sensory and emotional experience associated with or resembling that of actual or potential tissue damage. So again, the pain fibers, which is A delta, which is responsible for the fast amount of pain, and C fibers, which is predominantly for the slow component of the pain, that go into the trigeminal nerve. And at the level of trigeminal nerve itself, there are multiple factors which modulates the pain. So you have impulses coming from the cortex, you have coming from the emotional centers, the amygdala and all, periaqueductal gray matter. So at that level, at the trigeminal ganglion itself, it is so much modulated. So when we look at a patient with dry eye, we have to think of all these things. You know, when you have a patient sitting in front of you, it's important that you have a proper slit lamp examination. If you have these punctate erosions on the cornea, that tells you that the patient has got dry eye. So I'll just skim through the dry eye workup. Tear breakup time is the most important thing. When you put a drop of fluorescein, ask the patient to close the eyes and then open it and look for the first instance of tear breakup. So there are multiple tear breakup patterns. I think nowadays it's very important to locate the spot break. I think I'll come to that in the later slides. But I think it's very important that the most important thing that you see in a patient with dry eye is the tear film breakup. So the Asia Dry Eye Society has a slightly different view from the Western the counterparts, and I think the thing is, Asia Dry Eye Society, they have, I think in Japan and in China, diclofenac and ribapamine drops are also available, which are secretagogues, which are quite useful. Unfortunately, that is not available in our country. So I think it is not just about inflammation. I think it's very important that the breakup is something that is very, very important. I think one of the most important forms of dry eye that we see nowadays is this type of dry eye. That is the decreased wettability type of dry eye, in which there is reduced blink frequency and also there is reduced tear breakup time. So what happens is that when there is an incomplete blink and a partial or incomplete blink, and also when your blink rate is going down, what happens is over a period of time the mucin gets damaged, and this will spark off the pathways which are important in the inflammation and which will lead on to dry eye. So there are a lot of instruments that are available nowadays for the assessment of this dry eye. I think non-invasive tear breakup time is one of the very important things. And this is a Maya instrument in which you can calculate the tear breakup time. And if you see that the non-invasive tear breakup time is different from that of a fluorescent-induced tear breakup time. Nowadays, we have a lot of instrument which looks at the memeography also, and this is the classic LiPi view. in which you see that in these patients, you can see that the meibomian glands are very less. You don't need real instruments to really look into the meibomian gland architecture. It's just a picture taken from the autorefractometer. I think when we had the COVID pandemic running, we had an IIT guy to look into this, and it's very simple for them. They had developed a software with which you can very easily calculate the percentage of meibomian gland loss. So what we, in a very small study of 100 people, we found that about close to 30% had meibomian gland disease. And in a lot of people, in asymptomatic people, around 30 of them, we found that about 22% had meibomian gland disease. And I feel, and that were actually this asymptomatic population were all optometrists in the early 20s. And I think the only reason I can think of is the poor blinking and probably the contact lens wear in some people. The other parameter that we look into is the dry eye workup is the Schirmer's test. I think Schirmer's test is, if it is, I think depending on the type of criteria that you have different values. I think the Schirmer actually, when they devised the test, I think 15 was taken as normal. And in most of Sjogren found that it is less than 5 is important. And if you have less than 5, it is definitely dry eye. 5 to 10 should be considered as borderline. And in workup, other things are also important. Rosa-Bengal staining and nowadays lissamine green staining. You find this 3 and 9 o'clock staining, which is suggestive of dry eye. The other important parameter is the corneal fluorescence score. Now, how many fluorescent spots are there on the cornea? And based on which you can actually have a quantification of dry eye. But these things are seen in more severe forms of dry eye. The other important thing which has come up in the last maybe 10 years is the direct visualization of the lacrimal gland. If you see the thing on the right hand side, you can see that the normal lacrimal gland is slightly more bulky. And you can see when you put fluorescein on top of that, you can see the stream of fluid coming on from that. It will be reduced in Sjogren syndrome and it will be practically absent in Sjogren and SJS syndrome. The tear osmolality had its say, I think over a period of time, the importance of that is coming down because the results are not exactly reproducible and also there is so much of variation between the two. I'll just touch upon the management. I think the most important thing is the tear supplementation. Most of us do that. I think there is, whatever way you want to look at the literature, there are studies to support that. But I have taken these two basically to have a assessment of the tear film, the tear substitute, which is most important. So you have basically 3 types of artificial tear substitutes, in which one is the wetting agent or the demulcents. Second is the multiple action one, in which you have both the quantity and quality of the tear film. I'll come into that. So the CMC or polyethylene glycol, that is only if you have only that one that you can call it as a wetting agent. But if you have a combination of multiple things, you have something like sustain, no financial interest, but I think there are multiple agents in which you have this HP GOR which stick onto hydrophobic sites, onto which there is a cross-link of a borate as well as the sorbitol, which will keep it on the surface. And on that mesh, the polyethylene glycol and polypropylene glycol will be sitting. So that is supposed to be more useful for the treatment of dry eye as compared to just demulcents. So we have Lacryl hydrate, Lacryl ultra, Optimoist and all that. So if you look at the systematic review, I think we know that a combination of CMC plus hyaluronic acid is better than using one agent alone. And if you add Rehelose or coenzyme Q, it augments the action of hyaluronic acid. And if you look at molecule-wise, PEG or PPG is slightly better than CMC. And among the newer preparations of Sustain, it's supposed to be better than the older one, which has only sorbitol. I'll touch upon the other things also, the tear stimulation, which is done by, I think you have these agents are available, diclofosol, it's very good, but only thing is, it is not available in our country. I tried my best to get it from Japan, but it's not easy at all. We have autologous serum drops, which are, I think most of the time we use only 20% of serum. It is very helpful, but over a period of time, some people develop allergy to it. But it's very helpful for dry eye. And when you have neurotrophic keratitis, it's seen to be very useful. The other thing is anti-inflammatory therapy. I think we have cephalosporin, which is FDA approved. I think it's been there for more than 15 years now. I think there is very good evidence, level 1 evidence suggests that it is useful. I was fortunate to be part of a phase 4 trial in this, and found that almost about 65% of people benefit from cephalosporin. I think the recent one, which is 0.09% with Sequia, marketed by Sun, that is supposed to be slightly better than Restasis. My personal experience is also like that. Corticosteroids are useful, but actually only you can give only short-term pulse, you can't use it in the long term. But if you have very severe dry eye with corneal melt, you have to give systemic anti-inflammatory therapy, systemic steroids in the initial period, and quite often you have to put the patient on immunosuppressants, and quite often biologicals like rituximab also has to be used. The other thing what we quite often we don't use is the tear preservation. I think we have a variety of plugs now, the mushroom type plugs or the Herix plugs. Both are quite helpful. And the benefit is seen to be close to about 3/4 of patients are seen to be benefit from that. Among the newer ones, I think we have IPL, intense pulse laser therapy, and the LiPi-Flow. Both are helpful, definitely useful especially in Meibomian gland disease. I think people are pushing it for this Sjogren's dry eye also, but it's predominantly useful for MGD. And when you have very severe dry eye with bony dry eyes, I think you have no option but to go for a microvascular transfer of the submandibular gland. I think we had done a few cases with the plastic surgery and head and neck team, and it was seen to be helpful. So I would like to conclude saying that dry eye is an evolving field. I think it has been evolving for a long period of time, but we have miles to go. And with the increased use of tablets and this quadrangular devices which buzzes in your hands, we have this decreased wettability dry eye which has become very, very common. And over a period of time, we are getting more and more aware of renewability. Thank you so much.
Now we'll move on to the second talk of this session, patient selection for refractive surgery. I invite Dr. Swapna Nair for the talk. Madam has done her pediatric ophthalmology and cornea fellowships, and after her fellowship, she is working in Srinethra Eye Hospital, Trivandrum currently. She is a speaker at many national conferences, and she has many awards and achievements to her credit. Welcome, Madam.
Yeah. Thank you for my introduction. And I'd like to thank Dr. Shishir for having me here, Dr. Verghese and Amita Madam, and the entire PATHANAMTHITTA Ophthalmic Society for having me here. So good afternoon, ladies and gentlemen. Refractive surgery is one of my passions, and I'd like to enumerate what I have gathered over the period of time that I've been practicing this. I have no financial interest. And how you select a patient depends on multiple factors, some of which are patient-centric and some of which are eye-centric. Now, broadly, if you want to have an idea on how to divide patients, it would be according to age, as a patient comes to me, on what type of refractive surgery the patient might be eligible for. So here you can see that's broadly divided as under 40, between 40 to 60, and more than 60 years of age. The kind of surgery you do, whether it's a surface ablation or a LASIK, or whether you're doing an intraocular phakic IOL, or whether you're doing a refractive lens exchange, all this depends on age to a large extent. Now, under 40s are relatively easier to please because it's a rather simple, case of how you're going to treat their myopia or hypermetropia. You don't have to think of many complications in an absolutely normal eye. So here we're not talking about formifrostic keratoconus or any such kind, or dry eyes or anything. Between 40 and 60 years is the really toughest part, because especially the near presbyopes, let's say the age starts from 37 and it goes on, till about 55 or so. After that, they become better. So here they haven't fully realized that their retina are no longer the 20-year-old retina. They don't fully realize that they have lost the power of accommodation, and LASIK or trans-PRK is not going to give that back to them. So if you correct their myopia completely, they'll be extremely dissatisfied by the lack of near vision. So they won't be appreciative of the gain in distance vision. I mean, that is a reality that you often face. More than 60 years of age, again, it used to be easy once upon a time because the lens is cataractous. You can always advise lens exchange. But now it's getting tougher and tougher because you have so many lenses and everyone wants to see very well. Not only that, everyone's using the laptops and pods and pads, and they are all on Instagram and YouTube. So the demands have become so much that you have to satisfy, you're pushed to satisfying each aspect of vision requirement that they may have. Now, age is also important regarding the status of the eye. So whether it be a young myope with, let's say, macular degeneration or peripapillary atrophy or something in the periphery that needs to be controlled, these have to be vetted out very carefully, and it may be better not to do anything for a person with gross macular degeneration or gross amblyopia. In an older patient, of course, other factors like macular degeneration due to age, or any other systemic conditions like diabetic retinopathy or any problems with the disc, the vascular supply, all these need to be ruled out before proceeding with a refractive surgery. Now, accommodation is another factor that has to be taken into control because it varies according to age. Now, you have to make sure that your myopic patient at an older age is willing to wear glasses for near. So that has to be drilled into their mind because there are a lot of people who don't wear glasses for near work, and that is where the problem lies. They are so used to seeing near clearly. So one of my patients, she complains, no, I cannot see anything. She was 37, she can read N6 at 1 foot, and she can also see distance 6 clearly. But she tells me she cannot see anything. So I said, why? No, because I keep my phone like this and I'm not able to see anything. So I told her, this is not how you're supposed to keep your phone. The ideal distance is 1 foot. No, but I have been keeping this all my life. So those are things that, that is what is natural for the patient. And they expect to get that kind of, vision back from here to all the way to the distance. So those are things that they need counseling on, basically. So it's not that don't do them. They need to be counseled regarding that. Then, of course, the future prospects. So the younger the patient, the lesser invasive you'd be. You try to do, moreover, an extraocular surgery for someone less than 40 years of age, unless the patient is eligible only for a phakic intraocular lens. You can go on for an intraocular procedure at an older age. And you can do extraocular as a part of bioptics. So you have done a refractive lens exchange, and then you still have a residual part due to some sort of unexpected refractive surprise. You can always top it up with, LASIK or trans-PRK. Now, occupation, another important factor. For uniform jobs, you might need to achieve good vision, and there are jobs which allow you to do refractive correction. So that's, simple. But there are jobs which don't allow you to do refractive correction. The best thing is to avoid such patients and tell them that your job clearly mentions that. Because even if you do a good trans-PRK where you don't have a LASIK margin, initially you would have some healing pattern like this during the first 1 week. And later on, you'll have a clear cornea where you will not be able to detect unless you do a topography whether the person has undergone any form of refractive surgery. But occasionally you can get a subepithelial fibrosis like you see over here. This was along the axis of astigmatism. So he had a similar pattern on the other side also. So that is a possibility, especially in people who are predisposed to keloid formation. Sports, again, how you choose. A lot of youngsters come to me, they're playing basketball, they're playing football, and they don't want to put their glasses on because that's very incapacitating. So it would be better to do a flapless procedure. An extraocular flapless procedure like trans-PRK to avoid any sort of disasters because of flap displacement or trauma. Now, expectations of the patient, that is what is controlled by counseling. So, now if anyone's asking you for perfect vision okay, you have to say, sorry, my machine is out of order. I won't be able to do for the next 1 month. Maybe your friend who is sitting next door might be able to help you. So that stops there. Now, if they want to get through a job test, or I'm thinking about glass-free vision for most of the things, please go ahead. No problem with that. We have to be especially careful, like I mentioned earlier, about myopes who are very dissatisfied with loss of near vision. And then when you're doing any form of presbyopic LASIK, where you're creating a multifocal cornea or you're doing slight monovision, you have to counsel the person regarding some sort of blurring of distance vision, especially if that person had been an e-metro. I had this lady who was a hyperopic presbyope. So she had +2 for distance. She wouldn't wear the glasses, so she sees only 624. And she has +2 for near. So she doesn't see near also. And so I was very happy because she's the ideal Presbymax candidate. Once I do, whatever I do, she's going to see distance and near. So once the initial period was over, she comes to me after 2 months and I say, okay, so now are you happy? So she's going back to her husband who is abroad. No, I cannot see anything. So I said, okay. And I look at her chart, and in the right eye, it's 6, 9 and 6 uncorrected. The left eye, it's 6, 6 and 6 uncorrected. So then I said, yeah, it seems to be good. Can you read my chart? Yeah, it is blurred, but I can read. Yeah, and she reads the 6 by 6 line. So I said, yeah, so what? No, when I stand on my balcony and my neighbor is on the other balcony, so I said, you are not able to see his face. No, I cannot see his eyes, the cornea, unless I see that, how do I know what he's thinking about me? So I said, okay, so these are the expectations that I failed to address in that patient. So that is important. It's not magic. So that is what needs to be impressed on the patient. Then refraction, there are a lot of ways to go about it. Like we do routinely, the least minus in myopia, the most plus in hypermetropia. Try to fully correct astigmatism. And if you want to conserve pachymetry a bit, it may be better to reduce the astigmatic correction a bit arbitrarily rather than reduce the spherical correction without disturbing vision too much and conserving tissue at the same time. And in Presbymax, always treat the non-dominant eye for near. Always give contact lens trials to simulate the kind of vision you're trying to produce. Like whether it be, monovision, a micro monovision, or whether it be a multifocality of the cornea, you have to use corresponding contact lenses, give them for 5 days or so, make them used to it so that they know what they're going to end up with. Then maps. Topographies are the most important, both the surface aspects, the posterior floats, the pachymetry, and then all the indices that indicate of the anterior and the posterior float, and where the highest points are on the cornea. Epithelial mapping is a good tool, especially in transpiaca. We have to determine what amount of epithelium to shave off. Endothelium will help you in the future. ASOCT may or may not be done. Then comorbidities. Of course, if it's a cataract patient, you have, or anything with lens opacity, you have to go for a lens exchange. If there is any form of formae frustae keratoconus, avoid any form of refractive correction unless it's a part of C3R associated, regularization of the cornea using topography. Corneal dystrophies, again, in low ECDs, also you have to, endothelial cell counts, you have to avoid LASIK. And in scars, you have to be a bit cautious. You can use PRK to treat some form of scars. Glaucoma, don't touch, because LASIK will always give you a false IOP later on. And these people are usually steroid responders, especially people with large discs, ocular hypertension. They respond more to steroids, and they are more predisposed to glaucoma anyway. And also, there is always an angle closure component with phakic intraocular lenses. So this is one patient that I wanted to show. Here you can see that he is a high compound myopic astigmat, -6.25, -3 in one eye, -7.75, -3 in the other eye, with a very good pachymetry, 596 and 593. Okay, so, and he has a very good AC depth also, 3.49. So, any idea what you would like to do for this patient? Are there any postgraduates here, fellows? Anyone who would like to answer? Okay. I don't know who all are the fellows or postgraduates. I would have picked you out. Anyway, so yeah, so LASIK may be an easy solution here. Now, what is the criteria that would prevent you from doing LASIK? So here, if you look at the cornea, the corneal values are 41.71 and 44.3, I think, over there. So an average of 43 diopters. And if you're going to correct this much of sphere, like 7.75 over there, then the cornea is going to go way near 34 or 33 diopters finally, which is a very flat cornea. It's a hyper-oblate cornea, which we don't want. The patient won't be able to stand the aberrations. Though the pachymetry is very good. It's good enough to do the entire spherical and astigmatic correction. But this is one point where you have to watch out. Then the other option is a phakic intraocular lens. He has a good anterior chamber depth, which is 3.49 from the endothelium to the lens, and a good white to white also, which is 12.8. So that may be a wiser option here. So this is just an example to demonstrate that in spite of having a good pachymetry, how you need to discriminate sometimes. I have multiple such cases, but due to paucity of time, I think I'll stop here. Thank you very much.
Good afternoon. That was a good talk. First, I think Dr. Anil, dry eye is a complex problem, and managing dry eye is an art. I think he has covered it very well. I just wanted to ask him, when do you start cyclosporin in patients with dry eye, and how long you give?
I think it is important that we avoid patients who are having end-stage disease. In the sense, you have having a lot of punctate erosions, and if you see that the gland is almost permanently damaged, there is no much of a benefit in giving cyclosporin. But in moderate cases, definitely helpful.
And usually you give it for 3 to 6 months.
I think we have to give it for minimum 3 months, 6 months. Mostly it is lifelong only.
In refractive cases or like normal cases?
Normal cases I was talking about. When you incidentally detect a patient with a dryness, either before refractive surgery or cataract surgery, you can start. Maybe within 1 month we can plan surgical procedure.
What about the new drug Lifitegrast?
I don't have experience with that. I don't have, because I don't think...
I think they have launched.
Yeah.
Okay. Launched, but it's too costly. And
It's very, very costly. I think 25,000 for 1 month.
12,000, I think.
Yeah.
12,000 for the 30 unims.
For 30 unims. And I think they call it SECA, something like that. Yeah. And they are not launching it freely into the market. So through the company directly can you procure it. But studies has shown very good results is what they say, you know. I mean, when I think recently I read about something with 331 patients or so. So that shows
they are claiming it is very good compared to
improvement in the symptoms of the patient.
None of you have tried it.
Yeah, we're trying to get hold of the person who to catch, to get the drug. So only the senior managers.
I think NETHRAM is doing a good job on that. Okay, thank you. Not with the new type. Not with the new drops. There won't be much irritation.
Yeah. No, I think we have to give a minimum 3 to 6 months. 6 months is bare minimum. Yeah, and I think generally objective parameters, there will be some increase. I think around modest increase of around 30% or so. But subjective parameters definitely improve significantly, very significantly. And I think it's just your call. I think you can, after 6 months, you can just stop it and see. So I tell them, you stop and we'll see, and some people will require it. Then if they are having recurrence of symptoms, obviously, they'll be restarting it. But I think the literature is very much in favor of diclofosol. I think, unfortunately, it's not available in our country. I think that is, very good evidence to suggest that diclofosol is very useful in dry eye. I think it works on multiple pathways. No, it increases the production, it improves the mucin, it reduces the inflammation. Multiple things are happening there.
Any other?
Regarding the meibomian gland dysfunction, the light therapy, how long it will be effective or how many sittings we need?
Okay. IPL, I think even if you look at randomized studies, I think there are reasonably good number of studies to support the use of IPL, intense pulse lace. So I think 3 sittings, some companies say 4 sittings. I think the eye test, that company says 5 sittings. So, but quite often we have to repeat it. After 6 months or so, we have to repeat it. But even with LipiFlow, they said it is one-time treatment, but quite often we see that patients do come back after 6 months or 1 year. So I don't think it's a permanent solution. But difference is, it is way different in the costing. You know, LipiFlow, most people charge around 25 to 30,000 for one sitting. And IPL is around 2,500 to 5,000 rupees.
Any other questions to Dr. Anil? Dr. Priya, I'm sorry, I'm really sorry. Yeah, sorry about it. How do you counsel the patient around 40? If do you go for monovision or convince the patient for near vision glasses?
Yeah, so again, it depends on what kind of motivation the patient has. I used to do monovision more before, but now I either ask them to choose a distance correction and wear glasses for near, if that's what they want. I mean, depending on the nature of work and everything. That is one option I give them. If I'm doing monovision, where you correct, let's say the myopia entirely in one eye and then only partially in the other, to provide that kind of monovision, then I always give a contact lens simulation. So I ask them to put a corresponding contact lens for about 5 days or so and do all their work using that, so that they know what kind of vision to expect. Then the third option they have, provided this is more for hypermetropic presbyopes. I would prefer to do a Presby Max also, where I can correct both the distance and near. It's a micro mono vision kind of treatment. But again, counseling is very important. Then refractive lens exchange, which is the last option, I usually practice in patients older than 45 years of age. So less than 45, it's very, very rare that I do.
What about hyperopic ICLs, phakic IOL?
Yeah, phakic IOL, hyperopic ones I have done, but it's not common at all. Because up to a particular range, the common ones that we see, amounts of hyperopia, we can treat with LASIK, let's say up to +3 or so. So I'd prefer to go for that. Or I'd prefer a refractive lens exchange earlier in a patient with hyperopia because of the lesser amount of retinal risk and all that compared to a myopic patient. So that corrects them both for distance and near.
Okay. So LASIK, the main thing is give a realistic expectation, and it should be more transparent to the patient. We should know what we are planning for and what we are going to treat, and they should have a clear idea of what vision they'll get after the procedure. Not, as she said, no magic in LASIK or refractive surgery. It's a normal vision, and they'll be having unaided vision. That is the main thing we have to explain to the patient. I think with this, we'll wind up this session. Thank you very much. Thank you, Dr. Anil and Dr. Sapna.
Now, I request the speakers and panelists to come forward for the photo session.
Now, I would like to request Dr. Rani Nair to hand over token of appreciation to Dr. Anil Radhakrishnan. Dr. Anil Radhakrishnan. Dr. Swapna Nair, Dr. Kala B. Thotam, and Dr. Sumi Lukos.
Our next topic is Odysseys of Orbit. Let's invite chairpersons Dr. Jisha K, Additional Professor, Government Medical College, Kottayam; Dr. Leena Maria Varghese, Assistant Professor at Believers Church Medical College; the moderator of the session, Dr. Shebin Salim, Oculoplasty Consultant at Girdhar Eye Institute, Cochin. Over to you, Dr. Shebin.
Thank you. First, I thank Pathanamthitta Ophthalmic Society and the team Amita Eye Care for this kind invitation. So, from the ocular surface, now we are going deep into the orbit. We have two eminent speakers in the field of oculoplasty here, Dr. Marian Poli and Dr. Fairoz, PM. Unfortunately, Dr. Fairoz couldn't be here in person, but we have a recorded presentation. So, I will introduce Dr. Marian Poli first. She is currently working at Girdhar Eye Institute as the HOD, head of the Department of Oculoplasty. So she did her DO and MS from Kerala University and DNB from NB. And then she completed her 2-year clinical fellowship in orbit oculoplasty, trauma and reconstructive aesthetic surgery from Shankara Nethralaya. Also, she did ICO short-term fellowship in ocular oncology from Wills Eye Institute, USA. She is the recipient of many awards, including the Best Outgoing Subspecialty Fellow from Shankara Nethralaya in the year 2011, and Dr. Gangadhara Sundar Award for Young Oculoplastic Surgeon from the Oculoplastic Association of India, and Dr. Shivareddy Award for Best Paper from Kerala Society of Ophthalmic Surgeons. She is also life member of Oculoplastic Association of India. She has organized several CME programs and participated in and presented papers at many conferences. Her topic is on updates in thyroid eye disease. Over to you, ma'am.
Good afternoon, everybody. At the outset, let me thank Pathanamthitta Ophthalmic Society as well as the team from Amita Eye Care for giving me this opportunity. And also, always the THIRUVALLA and POS, Pathanamthitta Ophthalmic Society, is always close to my heart. So, in this 10 minutes, it's a huge topic. I'll just try to touch up on the few updates in what is happening in thyroid eye disease now. So why we have to update thyroid eye disease? So you can see this patient. She is with the total lag of ophthalmos with a hypopen fungal corneal ulcer, and she is developing this after 12 pulses of IVMB with the euthyroid status. So this kind of challenging cases we will come across, and we should be able to manage and to give back her good vision after the treatment. So coming to the updates in the diagnosis. So this is my first patient. She is 50 years, presenting with chronic ocular surface irritation, redness, irritation, edema more in the morning. So she has already undergone multiple investigations for thinking it as autoimmune episcleritis and scleritis. So when she presented to us, you can see there is a little puffiness of both the eyelids. There is a minimal congestion near the carangle, and there is a mild proptosis. We did a thyroid function test. It was normal. Then we always ask for TSS receptor antibody, which was very high. So I did a CT scan also to confirm it as thyroid eye disease. So we can see an increase in fat, but muscles are relatively spared. I sent the patient, since the eye disease was due to thyroid eye disease, I sent the patient for endocrine consultation. They did a thyroid scan, found out a cold nodule, and she was advised thyroidectomy. And from our side, since the disease is only minimally active, I just gave her lubricants, and she underwent thyroidectomy and she became all right. So here comes the importance of evaluation of TSH receptor antibody levels. We do this antibody test in all the patients. We know anti-TPO and TGAB, that is thyroglobulin antibody, but TSH receptor antibody has got a prognostic value in eye disease. And second, it helps in deciding the thyroid gland treatment options and also to monitor immunosuppression. Even though this is very costly, but when you consider the benefit that is going to give to the patient, it is very useful. So we did a study in our institute with 100 patients, and we can see superior SR-LPS complex enlargement was high. The antibodies were more common in SR-LPS complex enlargement patients. That is, they are more prone for apical crowding and all the complications. That is compressive optic neuropathy. Coming to the second case, she is a 70-year-old female presented with blurring of vision since 2 months. She had some protrusion of eyes, which she was not very concerned. She is a non-diabetic hypertension, post-thyroidectomy, etc. 1 year back. And she is a known case of old subarachnoid hemorrhage also. So this was her clinical picture. You can see proptosis, retraction, but the eye is relatively quiet. This picture has taken after dilatation, but not much congestion. Vision is CF 3 meters and 36, both eyes. Color vision is defective, IOP is normal. Fundus, right eye minimal dyspallor, rest is within normal limits. She had already seen by others and neurologist also, because she's a known case of subarachnoid hemorrhage, thinking it as ischemic neuropathy. Even the MRI has reported it as likely thyroid-associated orbitopathy. We did a CT scan, so we can see the apical crowding in this case with the all the muscles are enlarged. So she was diagnosed to have compressive optic neuropathy. She underwent medial prednisolone pulse, then decompression, immunosuppressants, and she did well after all the treatment, even though the field effects are remaining. So this here I would like to press on the different phenotypes in thyroid eye disease. So always the classical thyroid eye disease presents with chemosis, congestion, movement limitation, all the classical features, but there are 6 or 7 phenotypes. So our patient is in this 10 minutes time very difficult to explain all the features, but at least we should be familiar that it can present even without any inflammatory features. That is basically at the apical crowding, and they respond very well to decompression. So for this also we did a small pilot study of 20 patients, and to our surprise, like almost 35% of patients presented without any signs of inflammation, only with the blurred vision, movement restriction, disc edema or disc optic atrophy. So this is very, very important, and the clinical activity score also might not pick up this sometimes. Coming to updates in imaging. So we know CT scan is the preferred mode of treatment to document and diagnose thyroid eye disease. It is indicated in vision-threatening disease, moderate to severe disease, and to rule out orbital space-occupying lesions, and to confirm euthyroid ophthalmopathy, especially fat predominating, and as an investigation before orbital decompression. So CT scan, the classical findings, muscle enlargement with the sparing of tendons. Look for dilated superior ophthalmic vein also. This can be associated with cavernous sinus abnormalities. So now there are 2 patients in this picture, both having right eye proptosis. One is relatively young, one is relatively old. We had done TFT in both eyes, both are euthyroid. So what is the role of imaging? I just wanted to show. So in the first patient, there is proptosis. We can see mainly in the right eye, but he has got left eye medial rectus enlargement. So we can detect the disease in the other eye. So look at the second patient. This is there is a huge schwannoma sitting in the intracorneal space. So when you see a normal patient with a euthyroid patient with a mild proptosis, don't stop at it. Always go for imaging. It can be there can be a mass lesion also. So when will you do MRI? So there was a very good article by Dr. Surya in 2022 IJO. Here, when the patient comes to you after steroids, or like what else can we do? So when you are in a dilemma, you can actually do MRI to differentiate active from inactive disease, because signal intensity ratio is the ratio between the signals between extraocular muscles as well as the temporalis muscle. So now you know sometimes the disease is half treated and only the inflammation is persisting only in the levator muscle, especially the lid retraction. In that case, you have to specifically tell the radiologist that I would like to know, is there any active disease in any of the muscles, and accordingly you can treat that muscle. For example, you can give intralevator triamcinolone in patients with lid retraction. Similarly, if the inferior rectus alone is inflamed, we can give steroids to the muscle. The thing is, like in our part of the country, since steroid response is very high, we usually don't give that, but it is practiced in all the other parts of the world. So this is another patient which I would like to show. When will you do MRI? So she is a 17-year, presented with lid retraction. Now look at her gaze pictures. Her elevation is restricted. That is, both eyes symmetrically restricted, and down gaze also restricted. This is not a you obviously know she's euthyroid and not a classical case of thyroid eye disease. So we did MRI brain, which showed a midbrain glioma. So MRI also sometimes it has to be used very judiciously. Coming to updates in the treatment, so mild disease we always treat with lubricants, head elevation, sunglasses, endocrine consultation, stop smoking, etc. The 2 points which I would like to highlight is, one is always rule out obstructive sleep apnea. Today we heard from other speakers about regarding the ischemic part, but here what happens is in obstructive sleep apnea, it is associated with lots of inflammation, which is again implicated in the pathogenesis of thyroid eye disease also. So what happens is, if there is obstructive sleep apnea, it can prolong the Rundle's curve. Second, suboptimal response to treatment. So in that case, rule out OSA by ask the history. And if there is a history of OSA, always get an opinion from sleep specialist. And treating OSA will help in the management of TRO, thyroid eye disease also. So second thing is selenium supplementation. This is little controversial, but from practical experience, it works well in the management of thyroid eye disease, especially in mild to moderate disease. As we know, there is an element of oxidative stress in thyroid, which can be managed with selenium. The recommended dose is 200 microgram per day, which can be given for three months at least. So now coming to the management of severe disease. So severe disease is always a great challenge. So this patient presented to us in November 2021, that is almost 2.5 years back. 64 years, both eyes, active disease. She has got lots of risk factors. She's hypertensive, she's hyperthyroid, antibodies are highly positive, already treated with the steroids. She developed fracture following steroid intake. So this was her lag ophthalmos. Again, she had bilateral cornea affected. Fundus showed features of disc edema, MRI confirmed. So these are the concerns: active disease, compression, corneal ulcer, then glaucoma, diabetes, hypertension. We sought a cornea opinion, scraping was done, diagnosed as fungal ulcer. So our primary aim is to close the eye, because cornea will give a very fast rather than optic nerve. So we did a total tassorrhaphy with the total blepharotomy with the lateral tassorrhaphy. The thing is, if you do tassorrhaphy alone, it will give way. So you have to do a complete blepharotomy so that we can close it. Then lid cornea became better, underwent decompression. Again, vision has improved, then worsened. She was treated with radiation. Then after radiation and steroid treatment, she developed cataract. She underwent cataract surgery, both eyes. Then once the vision became normal, she developed diplopia due to her squint, and she underwent squint surgery also. So this is her final picture in February 2024 after squint correction, and she is doing extremely well. Feels little bit field effects is there, but still she is doing well. Even though throughout all these years, her TSH were always suppressed and became hypo also, but her eye disease remained quiet. Pulse therapy is the current standard of treatment, first line. Steroid sparing drugs, mycophenolate mofetil has been largely used. Previously it was azathioprine. Then come orbital radiation. The good thing about radiation is it is a local treatment and side effects are less. We have got patients with long-term follow-up. He is doing very well with pulse methylprednisolone, radiation and MMF at 7 years follow-up. Biologics being used now with specific indications. So he is a diabetic steroid responder, so you cannot give more steroids. Treated with rituximab, doing well. Then role of statins. This we have to actually educate the endocrinologist, because it has already come up in the medical management of Graves' ophthalmopathy. Actually, statin has got an anti-inflammatory effect, so it has got a good effect on thyroid eye disease. This also we have improved in our institute by a paper. Lid retraction, fillers, Botox and triamcinolone. These are all being practiced nowadays. If not responding to any of the medical management, we can do levator recession once the disease is inactive. Finally, decompression. Ballast decompression is the choice. This is the patient pre and post-op. Then finally identify the red flags. Thyroid eye disease can be associated with lymphomas and IgG4 related disease. So muscle biopsy have a role in selected cases if it is not responding to the regular line of treatment. So to summarize, it's a highly stigmatizing disease. Control the inflammation, case-based approach, new therapies are emerging, multidisciplinary approach. I always acknowledge my endocrine, rheumatology, radiation oncology, and all my fellow colleagues in ophthalmology for managing all these very complicated cases. Thank you so much.
Thank you, Dr. Marian. We know that to cover this topic in a very short span of time is very difficult, but still you have gone through the whole. Because the next speaker is not available right now, I think we can take up the questions right now and clear. I think smoking also is considered as a very important risk factor.
Yeah, that is already been known, so that is why I didn't stress on it.
Yeah.
First thing you have to ask, are you a smoker? Then stop.
Yeah.
Even active and passive both.
Yeah, passive, even for females also, I
Yes.
think we should ask. And do you think the thyroidectomy, by what time is it the surgeon's decision only, or based on like our ophthalmological?
It's a combined decision between the ophthalmology as well as the endocrine surgeon. Patient will also ask, is it a cure for eye disease? Always no. You cannot predict the course of the disease. It can aggravate, it can become normal after thyroidectomy, but thyroidectomy is indicated from your side. You can go ahead with thyroidectomy. Eye disease we will manage. Yes. Yeah. So statins is a recent trend. So statin has got an anti-inflammatory effect. It's already used in cardiology. And whenever you see a patient with thyroid eye disease, always check the lipid profile also. And don't start the statin by yourself. Then tell the endocrinologist, this patient is already have an eye disease or mild eye disease. Is it possible to start statin from your side, especially if the antibodies are high? If the antibodies are normal, no need to do anything. TSH receptor antibody. TPO, TGAP is non-specific for eye disease, but TSH receptor antibody is little more specific for eye disease. 20 milligram atorvastatin. It's already proved in STAGO trial. Phase 3 is yet to complete, but all the literature and even from our experience, we have done a study using radiological findings and statin users. And those who are using statins, the amount of muscle involved is less compared to non-statin users. So that means they have got a relatively good effect. And second, the incidence of squint is also less if you are on statin. Yeah, yes. So that, we have to study. So what actually now we are looking into all our orbital inflammation cases. Many of them are statin users. So these are all contradictory things.
Statement. Yeah. So probably it is because of the muscle atrophy that we are actually seeing a reduction in the propers. It could be. I'm not sure though.
It is thyroid eye disease is like a big Pandora's box now.
I have another question. Do you give IVMP pulse therapy alone or mycophenolate also alone?
Yeah. So decision on methylprednisolone depends on, patients will be divided into two categories. One with compressive optic neuropathy, no corneal involvement. So in that case, I start with pulse 1 gram IV OD for 3 days, followed by 500 for 6 doses. Then after 4th pulse, if the patient is willing for radiation, always send the patient to radiation oncologist, and oral immunosuppressant will be added. So that I'm 100% sure this patient will never land up in any of the complications of thyroid eye disease. Second group is, there is no compressive optic neuropathy, but the disease is active. That means patient has got diplopia, then occasional blurring of vision, but fields, color vision, everything is normal. So in that case, I will skip that pulse, that 3 pulse I will miss. I will not give. I directly start with 500 milligram weekly pulse. Then after 500 pulse, add mycophenolate. And if the patient is little less affording, I will always go for azathioprine. But always you have to monitor blood, liver function, renal function, total count, etc. And endocrine, obviously, thyroid has to be controlled, endocrine has to be in your loop. Yeah. Yes, sir. Yeah. Yeah. Original pulse therapy was devised by Kahaili, and he has put 12 pulses. So the thing is, patient coming from very far off, 12 weeks coming to the hospital, most of the time it's literally very difficult and they will skip. So what I do is 6, I will always insist you have to come. After 6, I convert to oral. That is 0.5 milligram per kilogram body weight per month. Taper every month. That is almost a period of, over a period of 3 months. So total around 6 months, 5 to 6 months steroids.
I had a patient who came 2 days back with unilateral proptosis. He has evaluated with MRI 2 years in 2021, and now I repeat thyroid. Only free T3 is 6 and AGESIS is 1.06 or like that. Can we call it
what is the MRI? What are the
MRI has shown nothing conclusive of thyroid or any orbital mass.
But there is a proptosis, no?
That muscle thickening, that is especially the superior rectus one. Inferior rectus is normal.
So that is actually because of the paucity of the time. So the one patient which I showed 7 years follow-up, actually he presented to me in 2014 with the right superior rectus myositis kind of picture. So at that time I treated it as myositis because everything was normal, including antibodies were normal. And after 3 years, he coming with the active disease in the left eye. So your patient could be thyroid eye disease, just get the TSH receptor antibody done. Right. So that is a new entity in evolution now. See, as for the classic teaching, inferior rectus is the predominant muscle involved, all the textbooks. But what we have seen now is all those patients who are antibody positive, they are all SRLPS complex, that is superior muscle complex is enlarged, and they sometimes they will become hyperthyroid and they can get an active disease later on.
Thank you. Ma'am, like you said, what happens is when we see this mild lid retraction, mild eye disease, we send the patient to a physician. They check the normal thyroid function test. Patient comes back to us saying that thyroid is normal.
No problem.
So like you said, TSH receptor antibody is very important.
Yeah. So from endocrine point of view, without a thyroid derangement, they cannot treat the patient. So let them come back to us. We will start the patient on like euthyroid and get the antibodies done. If the patient is like chronic mild surface inflammation, you can start some lubricants and add selenium. Selenium works very well. See, I have a couple of battalion of patients. They will do very well with selenium.
For how long, ma'am?
I give 3 months. Then if the patient is showing good response, then I'll continue for 6 months. So the symptoms will disappear and they will become asymptomatic, which is the most important for both of us.
Do you have a selenium alone combination, or you always combine it with vitamins, multivitamins?
No, it is, there is, I don't have any financial interest. Abbott has got THIRUVALLA Plus. It contains 200 microgram selenium.
Okay.
All our iVital, etc., it has got only 50 mcg. Yeah, exactly. So 50 mcg is actually insufficient. So I started giving THIRUVALLA Plus. It's by Abbott.
Thank you, ma'am. Thank you for that excellent presentation. Almost all the points are covered and a very good discussion. We'll go to the next presentation. Next is talk on approach to orbital swelling by Dr. Fairuz PM. We will play the video. She completed her MBBS from Government Medical College, Thrissur, and MS from Mysore Medical College, and fellowship in oculoplasty from LV Prasad Eye Institute, Hyderabad, followed by Wills Eye Hospital, Philadelphia. She also did an observership from Shiley Eye Institute, San Diego, USA. Currently, she's a founder and director of Horus Specialty Eye Care, Bangalore, and also HOD Oculoplasty and Ocular Oncology, Prabha Eye Hospital, Bangalore. She is also a visiting consultant at Amardeep Eye Care and adjunct faculty in ocular oncology services at Malabar Cancer Center. She heads many important positions. She's a vice president of Asia Pacific Ocular Oncology and Pathology, also member of Scientific Committee AIOS and section editor of IJO, and she's also an alumnus of APAO Leadership Development Program. She has many awards to her credit. Okay. Yeah, we will start the video.
Hi, everyone.
Thank you, Dr. Amita, for having me here and inviting me into this platform of NETHRAM 2024. I'm sure, congratulations, it's going to be a super successful conference. I wish and hope that I could have made it in person, because always it's good to interact when it's in person. Maybe next time. Thank you so much, Dr. Priyanka, for coordinating everything, and thank you for being patient with me. When Priyanka called me, she wanted me to talk on orbital inflammation. And I said, well, it's a good idea because, orbit being a Pandora's box, it can come out with various surprises, be it a general ophthalmologist and even for us as orbital specialists. And it's important to know and differentiate various disorders that happens in the orbit. These are my affiliation. I'm associated with Amardeep Eye Care in Kollam and Trivandrum and Malabar Cancer Center in Telcheri in Kerala. Orbital swelling can involve the periorbita, the preseptal space, or the postseptal space, and it can be infective, inflammatory, or neoplastic. Now, depending upon evaluating, a meticulous clinical evaluation, looking into the symptoms, the duration of the symptoms, and getting the signs right, most of the time, we don't go wrong with orbital diseases. This is a patient, a 38-year-old gentleman who presented with acute rapid onset of swelling. He said, like, I could feel the swelling coming, within minutes. And this is how he suddenly ran and came into the clinic. And on, it's a very compressive, swelling, not painful at all. There is absolutely no hyperemia here. And on elevating the eyelid, there's no chemosis or proptosis or ocular motility restriction. Now, what would you do next? Now, the question is, do I do an imaging? I decided no, okay? Because this is a very typical presentation, painless, acute onset of an allergic angioedema. It could be a food allergy, it could be a chemical allergy. The only thing that I did was to give him injection dexamethasone stat, and he did perfectly fine. Orbital emergencies patient can present with emergencies, including infection, inflammation, trauma, or vascular disease. And it's very important to identify this because it can be vision threatening. Now, there are certain P's of the orbital disease. We have all learned it, in our post-graduation and even in our specialization. Basically, depending upon these different P's, we can have a provisional diagnosis initially. Like if it's acute, we all know it could be infection, inflammation, and it will be associated with pain. If it's long-standing, it's usually neoplasm or granulomas. Proptosis, depending upon, dystopia and location of the globe and pushing of the globe, we can actually locate where the lesion is clinically. Progression, yes. Slow, benign. It's slow, it's benign neoplasm. If it's rapid, again, it could be an infection or an inflammation. And you palpate to see whether there is any mass which is palpable, whether there is resistance on retropulsion. And the periorbital symptoms and signs, including rubor, calor, and dolor, gives us a clue whether it's an inflammation or a neoplasm. Now, clinical evaluation of a case of an orbit is a serious thing. Vision, color vision, and pupillary reaction is the most important thing. And fundus evaluation is very, very important because, you can have optic neuritis associated, you can have compressive optic neuropathy, etc. Now, regarding the ocular motility, it gives you a clue whether the muscles are involved. Anterior segment evaluation is also very, very important because there are certain situations which can be associated with anterior segment involvement. This is a student who presented with acute onset of swelling, progressing proptosis, too much of a discomfort in an eye and associated with pain and blurring of vision. Now, do I do an imaging in this situation? Yes, I do, definitely, because it is an, progressive disease, painful disease. And in the imaging, what we found was this very well loculated lesion sitting in the superior orbit, involvement of the sinus. In a pediatric age group, when the patient presents with sinus involvement and an orbital lesion, the first thing, such a lesion is what we suspect is a subperiosteal abscess. And what did I do? He was put on systemic steroids, intravenous. A surgical drainage of the abscess was done and he did perfectly well. So it was a case of a subperiosteal abscess, which is infective. 27-year-old male baby presenting with progressive swelling. We did an imaging even in this tiny one. And again, you can see multiloculated lesions sitting in the medial orbit. The only thing that we did was to go in and do an drainage through the medial caruncle, and this also came out to be an abscess. So whenever it's an infective orbital cellulitis with abscess, this is how the microbiology workup is done, including fungal and bacterial culture. And in this baby, it came out to be a gram-positive cocci. He was also put on intravenous dexamethasone along with steroids. Now, depending upon the classification of orbital cellulitis, the management is, we approach the management. If it's a preseptal cellulitis, it's just oral antibiotics, but depending upon the severity, we, adopt intravenous antibiotics and even intravenous steroids. And well, in cavernous sinus thrombosis, even anticoagulants is considered. This was a 10-year-old child who presented with on and off swelling, in the periorbital area, initially thought to be a chalazion by a general ophthalmologist and treated. And this has been going on for 4 to 5 months. So imaging was done, and this is what we found with erosion of the bone in the roof of the orbit, with this lesion sitting in the superior orbit. Well, something that we think of in children presenting like this is eosinophilic granuloma. So curettage was done. And this is the dura which is intact. Intralesional steroids was given intraoperatively. A systemic evaluation for Langerhans histiocytosis, which was proven again by histopathologically, was done. Bone scan was done to look for other lesions in the body, and systemic evaluation to rule out even hematological malignancies in these cases. So she did perfectly fine, fantastic with intralesional steroid in this case, and even there is a bone healing that has happened over here. Similarly, a child, not a child, she's a 20-year-old student who presented with this bilateral swelling with severe swelling of the left eye. You can see an enlarged lacrimal gland in the right eye over here. And this is what the imaging looked like. A large, lacrimal gland with involvement of the orbital soft tissue, causing lobe indentation and a reduction in the vision 6/60. She was given intravenous methylprednisolone to, tackle the situation. But, then this is May 2018 after completion of the treatment, but then again, she recurred. So at the time of recurrence, we went ahead for, imaging again. And at this point of time, she had this bony erosion. So whenever there is a bony erosion in the orbit, there are a few things that you keep in mind. You saw one, which is eosinophilic granuloma. Second is tuberculosis. It could be fungal granuloma, or even it can be a neoplasm or a malignancy. So we went ahead doing a biopsy, and it came out to be a sclerosing variant of IOID with vasculitis. And we also did other systemic immunological profiling for her, and she came out to be tuberculosis quantiferon gold test positive, although the mantle was negative. But with discussion with an immunologist, because of the bony involvement and severe pain in the bone, we started her on ATT, and she did perfectly fine without any recurrence. So dacryoadenitis, 50% of these cases can have associated systemic disease, and it's always good to do, biopsy if they recur. Now, orbital inflammatory disease, we have a broader classification of specific and non-specific. Non-specific is when we rule out all the specifics in the orbit. So biopsy plays a major role. Now, classification, you can have localized or diffuse. You can have anterior, posterior, dacryoadenitis, myositis, apical, and perineuritis. This is a case where this child presented with this bilateral swelling. She has photophobia, and this is a case of anterior IOID with associated tenonitis and anterior uveitis. She was on oral steroids. She had a recurrence post-IVMP. She did perfectly fine. IOID, she doesn't have a proptosis but presented with vision loss. It is a case of anterior and posterior IOID with perineuritis in this particular case, where she also presented with RAPD. Myositis, it could be muscle involvement associated with motility restriction, pain and diplopia, as in this case. I went ahead doing a medial rectus muscle biopsy in her, proven it is an idiopathic orbital inflammatory disease. She did well with IVMP6 cycles. Now, this patient was referred as a case of idiopathic orbital inflammatory disease with a reduction in the vision. Although I was not convinced with the diagnosis, I went ahead because it was progressing despite IVMP, and I went ahead doing a rebiopsy, and it came out to be an IgG4 disease. In fact, he progressed even during the course of, after we stopped IVMP with an orbital apex syndrome where he had complete third nerve palsy. Then we started him on immunosuppressants, oral mycophenolate mofetil, and rituximab for recovery. And currently he's doing fantastic and well without recurrence past 1 year. So IgG4 related disease is something which is very specific that we should be knowing, and it has to be ruled out. There is a particular criteria, including serum elevation of serum IgG4. So this is a chart which shows how we deal with in orbital inflammatory disease. What I want to highlight here is if it's not responding to steroids, be it intravenous or oral steroids, immunosuppressants should be considered, other immunosuppressants. And if there is recurrence and inadequate response, biopsy is 100% mandatory. This was a patient who was referred to me during COVID, as a case of orbital mucormycosis, where he had a third nerve palsy and severe pain because of uncontrolled diabetes mellitus. Probably the referral doctor thought it could be mucormycosis, but I was not too convinced about it. Did an imaging, there's this lesion sitting over here, went ahead doing a biopsy, and it came out to be a very lethal high-grade malignancy lymphoma, which is natural killer T-cell lymphoma. He succumbed to the disease. So the management pearls in orbital disease is that it's very important and crucial to differentiate between infection, inflammation, and neoplasm. And these are the normal mimics of inflammation in the orbit. It could be thyroid eye disease. I'm sure Dr. Marin is going to speak about it, and neoplasm like lymphoma. So 30 to 40% of biopsied inflammation has a specific disorder. So there is a very important role for biopsy in orbit if it's not responding to normal treatment. I would like to end this talk with a strong take-home message that timely referral for orbital disease is very, very important. And in order, there are situations where it's vision threatening and sometimes life threatening. Thank you so very much for your patient listening. I can take questions. Thank you.
Thank you, Dr. Fairuz. In spite of your
inconvenience,
in spite of all the inconveniences for arranging this recorded presentation, and it was very good. And you highlighted the point that by the right diagnosis, you are not only saving the vision of the patient, but you are saving the life of the patient also. Thank you very much.
Thank you. Thank you so much. Do I have any questions?
I have a question. Do you have any, what's your opinion about CT guided FNAC or CT guided or a true cut biopsy in the case of orbital mass lesion, where you can avoid, you think you can avoid an orbitotomy approach? Do you practice true cut biopsy in orbital lesion where diagnosis is not certain by the initial evaluation?
Ma'am, yeah, great question actually. So there are practitioners who go in and do an FNAC or an FNAB or a true cut biopsy, but in our practice, the way we are trained, we want maximum yield and the right yield of the biopsy, not going wrong with any histopathological evaluation. So I never go ahead doing an FNAB or FNAC or a true cut biopsy in the orbit. It's always, orbitotomy is not too difficult. Taking an incision biopsy is pretty easy, actually, if you locate the lesion right. Excision biopsy is obviously, it's a bigger surgery, but going in and directly going into the location of the tumor and taking an incision biopsy is not too difficult, but it gives the best yield of pathology because there are certain situations where you might have to do an immunohistochemistry, and pathology has evolved again. We don't stop at basic pathology now. Immunohistochemistry, there are genetic markers that we do in certain situations. So we need enough yield of tissue. So I personally never go for FNAB, FNAC or true cut biopsy. It's always incision biopsy.
Okay. Thank you.
Any other questions from the audience? Okay. Thank you, ma'am.
Can I have one more question, please? When exactly will you make?
Please, I'm here. Yes.
When exactly will you make a diagnosis of idiopathic orbital inflammatory disease? After what all investigations exactly? Will you do IgG4 in all cases before making a diagnosis, or can you enumerate all the investigations that have been done as a routine practice?
Yeah. So it is basically the immunological profile that we do, so which will include ANA, RA factor, C ANCA, P ANCA, SS row, all those immunological profile. And then IgG4, I do in all case as a protocol. So along with the immunological profile, IgG4 is also included in that. Because there was a time, IgG4 is something which has been, in vogue recently, not too recently, but, it has just been like 5 to 6 years where, we always underdiagnosed IgG4 earlier, thinking that it could be a sclerosing IOID or something. Immunological profile that I listed, IgG4 is definitely included. So I do include it, yeah.
Okay, thank you.
Yeah.
Thank you, ma'am. Thank you so much. Okay, so with that, we will conclude the session.
Now, I would like to request Dr. Nitha S. to hand over token of appreciation. Dr. Marian Polly. Dr. Jisha K. Dr. Leena Mariam Varghese. And Dr. Shebin Salim.
This session will explore the challenges and solutions in the diagnosis and management of glaucoma. So let's invite the chairperson of the session, Dr. Kashinatha Shenoy, Professor and HOD, Pushpagiri Medical College, Thiruvalla, and Dr. Jacob Koshi, Professor and Dean of Believers Church Medical College, Thiruvalla, and moderator of the session, Dr. Rani Nair, Senior Consultant at Amida Eye Care.
So our first speaker for the session is Dr. Kiran Gopalakrishnan. After his graduation from Trivandrum Medical College, he did his MD from RP Center, AIMS, and where he was awarded the Best Resident Award. He has completed his fellowship in glaucoma from AIMS. Currently, he is a senior consultant, glaucoma and anterior segment services at Precise Eye Care since 2013. He is a regular faculty at international instructional courses in KSOS and AIOS. Over to you, Dr. Kiran.
Thank you to the Ophthalmic Society of Pathanamthitta for the invite to speak here. So in the next 10 minutes, I'm going to speak about optimizing the medical management in primary open-angle glaucoma. This is a very vast topic, and therefore I have taken the liberty of selecting certain specific things to speak about. So we will be discussing on selecting the primary drug, then the adjuvant drug. We will look at neuroprotection. We will look at ocular blood flow. Should we use preservative-free medications, and a few words on drugs in pregnancy. So selecting the primary drug. We have a vast collection of drugs to choose from, most of which acts either on the uveoscleral outflow or the aqueous humor inflow. But with ROCK inhibitors, we also have drugs that now act on the trabecular outflow. So when you want to select the primary drug, it should be the most powerful IOP lowering agent with convenient dosing and negligible systemic adverse effects, which should be reasonably affordable as well. So all these criteria are satisfied by PG analogs. So that should be your primary drug in glaucoma. Now, if you look at the list of the drugs with the most powerful IOP lowering efficacy, all the first 3 positions are occupied by the prostaglandins. And if you look at the comparison between the three available prostaglandins, what you find is that in meta-analytical studies, more or less all the three drugs are the same, but in terms of strictly IOP lowering efficacy, bimetoprost seems to have an edge over the other two drugs. But at the same time, eyelash growth and other orbitopathies are also more common with bimetoprost. Hyperemia, which is a common side effect reported with prostaglandin, is the least with latanoprost. Now, if your primary drug has not achieved the target intraocular pressure that you have set, should you add a drug or should you substitute it with another drug? So generally, we look at if your primary drug has achieved at least 20% IOP reduction. If so, that means your drug is currently working. That means you can add an extra adjuvant drug. But if it has not reduced your IOP by at least 20%, it is very likely that the drug is not working, and then you can consider substituting. Now, why this 20% IOP reduction? We have to keep in mind that placebo effect of anti-glaucoma drugs, placebo effect of drugs in general are very significant. And in the study from the European Glaucoma Prevention Study, which is a lesser known cousin of the ocular hypertension treatment study, placebo was able to reduce IOP to a staggering 18.7%. So if your drug is not reducing your IOP by at least 20%, the drug may not be working. Now, once you have selected the primary drug from the rest, you have to select the adjunct or adjuvant drug. So an ideal adjunct drug should tick 3 boxes. It should be efficacious, it should have again convenient dosing, and it should have good safety and tolerability. And you will find that none of the drugs will tick all the 3 boxes. But let's start with the well-known, well-tested beta blockers, timolol. Now with efficacy, this is a very good drug in terms of efficacy. If you look back at the previous chart, you find that after the 3 prostaglandins, timolol occupies the next position. So it's a very efficacious drug, but its efficacy is marred by 2 points. One is beta blockers have minimal effect on the intraocular pressure during sleep. So if you notice, during sleep hours, the effect of timolol wanes to the effect of a control. On the other hand, if you notice there, the square blocks, that is latanoprost, is still continuing to be active. So at nocturnal hours, timolol tends to have very little effect. And the other problem is that the effect of timolol tends to lose its effect over a period of time. So this is first described in the 1984 paper, which I have shown here, which talked about short-term escape and long-term drift, which basically means that the effect of timolol, due to upregulation or downregulation of adrenergic receptors, the effect tends to wane over a period of time. But another huge advantage of timolol as an adjunct drug is that it has got convenient dosing, because a once daily formulation is available, and in generally studies have shown it to be equally as effective as the twice daily solution. Another huge advantage that timolol has and none of the other adjunct drugs have is a fixed dose combination of prostaglandin and timolol is available. So that is an extra advantage. Safety and tolerability, we are always concerned about the 2 classical side effects of timolol, the cardiovascular system and the respiratory system. This is something we all know. But what you need to keep in mind is that timolol is not blanketly contraindicated in all cardiac issues. They are only contraindicated in heart rate abnormalities like bradycardias or other arrhythmias. But a person who has undergone an angioplasty or a CABG, they are not contraindicated from using timolol because they are anyway using oral beta blockers. In fact, in a large EPIC Norfolk cohort study, this was a study conducted over 17 years, it was found that topical beta blockers were not associated with any increased CVS mortality. So you should not blindly contraindicate timolol in all cardiac patients. Now, brimonidine, again, as an adjunct drug, its efficacy is quite good, as evidenced by, if you look at all these studies, they are all very positive about brimonidine as a drug with good IOP lowering efficacy. So that checkbox is ticked. Convenient dosing, no, because you need at least 2 to 3 times daily dosing, and a fixed dose combination is not available. So this is not a drug that has convenient dosing. And the other question is, does brimonidine have a neuroprotective effect? Of course, this is the famous LOC study, the low pressure glaucoma treatment study, published more than a decade back, which showed that at the end of 4 years, brimonidine patients had lower rates of visual field progression compared to timolol, in spite of the fact that they had the same intraocular pressure levels. It was postulated that this was because of a neuroprotective effect. But one of the important points from the study is also that 36% of the patients who were using brimonidine dropped out of the study mainly due to allergy. So that is the biggest downside of brimonidine, because it can cause a lot of allergies locally, and apart from it, it has its own systemic side effects as well. So for all practical purposes, IOP reduction still remains the best neuroprotection in glaucoma. Therefore, the best neuroprotector currently still continue to be prostaglandins. Now, coming on to carbonic anhydrase inhibitors. Again, if you look at the studies where it is tested for efficacy, it's an excellent drug. It works very well when added to prostaglandins. Convenient dosing, again, this is where it falls short, because again 2 to 3 times daily, and the fixed dose combination is not available. Do carbonic anhydrase inhibitors increase ocular blood flow? This is a question that needs to be looked at. And if you look at the meta-analysis, you find that in most of the studies, there is an increase in ocular blood flow with dorzolamide, especially so, in most of the vessels that supply the optic nerve head. So we know for a fact that there is an increase in ocular blood flow with carbonic anhydrase inhibitors. But what is to be kept in mind that there is no evidence at this point to suggest that this increased ocular blood flow has any genuine beneficial effect in glaucoma. So you cannot simply prescribe this drug just because it increases ocular blood flow. If you look at the safety and tolerability aspect, dorzolamide tends to sting in the eye, and that is something that you warn the patients about because of its acidic pH. Brinzolamide, on the other hand, will not sting, but it will cause a little blurred vision in the eye when you put it in the eye, because it's a suspension formulation, and these things have to be warned. ROCK kinase inhibitors, they have been around for some time. Efficacy-wise, it is inferior to prostaglandin analogs, and therefore it is not a first-line drug and should not be considered so. Moreover, it produces at least 2 to 3 times the rates of hyperemia as prostaglandins, which itself produces a fair bit of hyperemia. So either in terms of its tolerability or in terms of its efficacy, it's not a first-line drug. Now, one genuine advantage with ROCK kinase inhibitors is that in patients who are already on multiple drugs, let's say somebody is on 3 or 4 drugs, addition of ROCK kinase inhibitors like repasudil or netarsudil tends to have a good effect. In about 60% of patients, at least 10% IOP reduction is possible. In other words, it could be effective when all the other drugs are not. And this is because of its mechanism of action. This acts on the tightly compacted actin filaments which are present in the trabecular mesh. You can see when the drug acts on it, it becomes loosely compacted, and therefore the permeability of the trabecular meshwork is increased. So essentially it acts on the trabecular outflow, and none of the drugs, other drugs which I discussed, acts on the trabecular outflow. This is why it could be effective when all the other drugs are not. As far as convenient dosing is concerned, yes, netarsudil is once daily dosage, and the fixed dose combination of prostaglandin and ROCK inhibitors is not available in India, though it has been approved in both the US and the European Union since 2019 and 21 respectively. It's not available in India yet. Pilocarpine. Well, pilocarpine is also a drug that actually acts on the trabecular outflow, but indirectly by contracting the ciliary muscle. It does not directly increase the permeability of the trabecular outflow. Because of its various limitations, currently we use it basically for 2 things, for Plato iris and prior to performing an LPI. Some people, including myself, use it for a short period of time after performing an angle-based mixed procedure to prevent the iris from going and blocking the trabecular meshwork, but otherwise its use is very limited because of various reasons. One, it's not a very convenient drug in terms of dosing, and in younger patients especially, it can produce a lot of headache and transient myopia. Very importantly, it interferes strongly with performing visual fields, which is a very important part of our glaucoma investigation, and also causes increased risk of retinal detachment, which was not a particularly important concern earlier, but now 1.25% pilocarpine is increasingly being used in US, mainly for presbyopia. So now there is an increased risk of RD. In the next 2 minutes, I'll finish. Should you use fixed dose combinations? Yes, in general, because of lesser preservative exposure and better adherence. And generally, if you shift from an unfixed combination to a fixed combination, you can expect about 20% increase in adherence. Should you switch to preservative-free medications? Well, a meta-analysis in 2019 which looked at 16 RCTs on preservative-free medications found that as far as IOP lowering is concerned, it was as effective as the preserved formulation, but it could not produce any statistically significant decrease in hyperemia or an improvement in tear breakup time. So really, the evidence is not very strong currently for using preservative-free medications in all cases. And finally, a quick word on medical management in pregnancy. brimonidine is the only drug categorized as B. All the other drugs are categorized as C, which means there is no drug which is ultra safe like category A, nor are any of the drugs very dangerous like category X. And why is brimonidine the only drug that is categorized as B? Because in animal studies at supra-threshold doses, 190 times also, there were no fetal abnormalities, which is not the case with all the other drugs tested. For example, in timolol and at supra-threshold doses, adverse effects have been found in the fetus. But brimonidine can produce CNS depression and apnea in infants and small children, therefore needs to be discontinued during lactation. In pregnancy, irrespective of the drug used, insist on punctal occlusion. And to conclude, your goal of glaucoma treatment should not be completely confined to reducing the IOP and stabilizing the visual fields, but to maintain a quality of life at a sustainable cost. And that concludes my presentation. Thank you very much.
Thank you, Dr. Kiran, for that excellent presentation. Questions?
Since I will be leaving because of the train issue, if there are some questions, I shall take it right now.
Yes, Dr. Kiran, I have one question. What is your stand on now? Travoprost intracameral is on the market in about...
You are talking about intracameral.
Yeah.
It is not available in India.
It is available in India.
Travoprost, it's
Bimatoprost.
Bimatoprost implant is marketed as Durista. So Durista implant has been approved by the US FDA, I think in 2021. So the effect of Durista is pretty good, and it is found that one important thing to consider is that it has been approved by the FDA for only a single injection.
Yeah, but
so it's not been approved for multiple injections.
Because you can
No, once you inject it, its effect generally lasts for about 3 months. And what do you do after that? And moreover, going intracamerally for something that you can give topically is a little too aggressive in my opinion, especially since the reason why it has been approved for only one injection is that there are some concerns with repeated injections that the corneal endothelial count tends to come down in the various trials that they have looked at. That is why, though the trials looked at multiple injections, the approval currently is only for a single injection. But if you are, even if it is available in the market, if I am going to give somebody a single injection, what will I do after 3 months? If the approval comes for multiple injections, then I think it certainly can be considered in cases where you are looking at poor ocular surface and other issues which are generally associated with the use of prostaglandins. Then you can consider giving it. One thing that was noticeable in the trials is that as you increase the number of injections, the dose response also increases in terms of duration. So while the first injection will give you an effect only for 2 to 3 months, you give the second dose, let's say at 3 months, the effect tends to last for about 5 or 6 months extra. And the third injection, the effect may last for about 1 year or so. So in that way, once that approval comes, we might think about it in very specific situations where, let's say, there is a lot of ocular surface abnormalities.
Do you come across NETHRAM with the honeycomb appearance of the cornea routinely?
No.
How it is common? Because
So see, NETHRAM basically pumps the fluid from the corneal endothelium to it basically absorbs the fluid. So it pumps the fluid from the deeper endothelial layers to the superficial layers. So what they have found is initially when they started using it for corneal conditions, for example, somebody has Fuchs dystrophy and some degree of corneal edema, they found that if you use netarsutil or ripasudil, either of these two drugs, you could find the subepithelial vesicles that was referred to as the honeycombing, corneal honeycombing. And initially it was found only in patients with already existing corneal edema, that is deep corneal edema. But subsequent literature also found that in patients who do not have clinical corneal edema currently, but some susceptible corneas. For example, a Fuchs patient might not have an increased corneal thickness currently, but if you use it, you can still develop some degree of honeycombing. The thing about honeycombing is that if you stop the drug, the honeycombing will disappear. And the other thing is, there is a difference in the way in which honeycombing appears with netarsutil and ripasudil. Netarsutil honeycombing appears actually much earlier, whereas the ripasudil honeycombing appears later. But the downside is when you stop netarsutil, the honeycombing disappears faster. With ripasudil, the honeycombing disappears much slower. So this is a pattern again which has been published by Shankar Nethralaya, but that's it about honeycombing.
Dr. Kiran, brilliant presentation as always, so lucid and so clear. Just one quick question. You did mention that bimatoprost dose for dose has a better lowering
Yes.
effect.
That is a trend that you find in meta-analytical studies, because one of the biggest issues with comparing prostaglandins in individual studies is that almost all the studies are funded by the industry. So we know for a fact that with industry-funded studies, some bias does creep in. But if you look at least 2 meta-analytical studies, we've looked at the prostaglandins, all you find is a trend for slight benefit of
Yeah, so there are so many studies that show that in India, many patients miss dosages. And there are other brands that say that they have a better missed dosage lowering than. Would you ever consider that in your choice for a primary drug, or would you just look at only IOP lowering efficacy?
In fact, I don't practically use bimetoprost as the first-line drug, in spite of its efficacy as the, probably the top IOP lowering agent. That has nothing to do with the IOP lowering per se, or the ability of possibly some other drug like travoprost to have a longer duration of action. And that is also really not proven. Initial studies had actually shown that travoprost might have a slightly longer duration of action, but again, all of them were funded studies, and when subsequent studies came up, this was not really proven. The reason why I don't prefer it as a primary drug is simply because of the orbitopathies it causes. It causes a complete absorption of the subcutaneous fat. The lids become very tight, and because I am a surgeon, I don't want to operate patients who are on bimetoprost for a long period of time. I have had trouble with even putting a speculum in one of my patients. So that is one of the reasons why I don't use it as a primary drug of choice, because of the orbitopathies, not because of its IOP lowering efficacies. Tight lids, very difficult to open. So that is the reason.
When we start monotherapy prostaglandins, after 6 weeks or 4 weeks, patient is responding to, for example, we started latanoprost, patient is not when you want to change in the same group of drugs, or you will change?
Look, the general principle is when you want to switch to
a
different class of drugs.
What is the criteria?
What is, in generally, because if one drug, say if dorzolamide is not effective, there is pretty much no use in shifting that patient to brinzolamide, because they are essentially acting on the same mechanism. There is a slight exception. I had put that slide because of the time issue. If you want to switch, suppose your latanoprost or travoprost is not responding, you can consider giving a trial of shifting to bimetoprost. And there are 2 reasons. Bimetoprost is not chemically exactly similar to latanoprost or travoprost. Bimetoprost is not really a prostaglandin analog, it's a prostamide. So chemically different. And the second thing is, bimetoprost is it's not a pro-drug, it's an active drug. Whereas the other 2 are pro-drugs that gets hydrolyzed by the corneal esterases and then it converts to the active form. So chemically and mechanism of action, there are slight differences with this. So this has been studied. There have been at least 3 studies published on patients who have been shifted to bimetoprost after they are non-responders to latanoprost. The first study came way back in 2006-07, Dr. Gandolfi's study, which looked at 15 patients who were non-responders to latanoprost. And when they shifted to bimetoprost, 13 out of the 15 patients responded. But again, the issue is that Dr. Gandolf is a paid consultant to Allergan, so you take that study with a pinch of salt. So subsequently, 2 more studies were published. Another study also showed the same mechanism, but the 3rd study published in 2019 said there is no difference if you shift to another prostamide like bimetoprost. It really doesn't matter. What effect you are suddenly seeing in all the other studies is simply what we call as regression to the mean. If you give this drug for some time, maybe you shift to the other drug. Even if you had continued the same drug for another month or 2, maybe the patient would have had a IOP reduction. So, but I have tried in a few patients and seems to work in some patients. So I will still, before shifting out of prostaglandins, as I said, I will usually start with latanoprost or travoprost. If the patient is not responding, I will definitely give a trial of bimetoprost. Thank you.
Quick last question. I know you're trained.
No, now I have no problem.
For all the general ophthalmologists here, quick opinion on generics versus substitutes in this day and age.
Okay. Generic versus substitutes is a very big discussion, but the first attack on the generic version came in 2008 when a study was published from Shankara Nethrali. I'm not mentioning the brands or anything now because of the sensitivity of the issue. But the Xalatan was considered to a very commonly and very widely popularly used latanoprost brand in India, generic version. And the effect was not as good as Xalatan. That was the first study in 2008. But again, this study was funded partially by the manufacturers of Salatan, but the authors are beyond reproach as far as integrity is concerned. So I will keep that as a very valuable lesson. Then subsequently, from my own alma mater, in RP Center, there were a couple of studies published. This was not on the basis of IOP lowering and other things. What they did was, they took, for example, Travoprost. They had, say, Travatan as the original brand, and then they took up various other brands that were manufactured and went for a chemical analysis. Because these are drugs at very unusually low concentrations, 0.003%, and this is the usual concentration of these drugs, right? And they looked at the concentration of these drugs in the generic forms and along with the concentration of the adjoining vehicle, your preservative, whatever it is. And they found that with the exception of one or maybe two brands, all the other brands had concentration which was widely variable from the original brand. So if you ask me, it is not exactly comparable. If you want to be politically correct, you can say that you can use it, but I still believe in brand values and things like that. And I think everybody at some point of time, whether it is due to some bad adverse reactions which happens due to certain specific drugs, which has happened recently with a tear substitute, and with so many of the retina people would give their intravitreal injections, and some brands have repeatedly developed problems, and to think that all brands are the same is really foolish thinking. Citicolin was the one drug that went the maximum in RCTs, in randomized control trial. There was a large trial conducted in the US. They were very positive about the effects of Citicolin, but after 2 years they discontinued the study because it was not found to be effective. None of the other drugs have to be found to be neuroprotective in any manner. The only postulation was with brimonidine. Again, this is a theoretical postulation because you have two drugs, both of which produces the same IOP lowering, but one drug had a better visual field preservation. So you are thinking that brimonidine has the neuroprotective effect, but at the same time, if 1/3 of your patients are going to drop out because of allergies, and the worst thing is these allergies sometimes develop as a delayed hypersensitivity reaction 1 year after you have started this drug, and therefore it's certainly not a drug that you would start with. Thank you.
Now I request Dr. Sabita to hand over the token of appreciation to Dr. Kiran Gopalakrishnan.
We'll move to the next topic. Visual field strategies in glaucoma, in diagnosis and management of glaucoma, by Dr. Meena. Dr. Meena Nair is a senior consultant of glaucoma services, Chaitanya Eye Institute and Research Center, Trivandrum. After graduating from Medical College, Trivandrum, she finished a PG from Manipal Academy of Higher Education, and she did a fellowship from Bangalore Westline Hospital. She has keen interest in academic activities and fellowship training. She is a member of GSI and has been a faculty at several national and state conferences. Over to you, Dr. Meena.
Thank you for the kind words of introduction. First of all, at the onset, I wish to thank the PATHANAMTHITTA Ophthalmic Society, Amita Eye Institute, and Dr. Rani Nair, as well as Dr. Priyanka for the invite. And my topic for today is visual field strategies in the diagnosis and follow-up of glaucoma. Automated static perimetry has actually given the platform and actually is a standard accepted care for visual field evaluation of any glaucoma patient today. And it is, I would like to say that, Humphrey is so popular that one forgets that actually the octopus was introduced far earlier. And then Humphrey for the last 40 years became very popular. And now octopus is again regaining popularity for over a decade with the versions 300, 600, and 900. And you can see the Humphrey from 720, 740, 750 series to 2i series, and then to the HFA3. So I don't need to say about anything extra about the visual field. All of you know that the brow as well as the bridge of the nose actually limits the extent of visual field superiorly and nasally, and requires definition of hill of vision, cannot be forgotten, which says that the island of vision in the midst of the sea of darkness is the hill of vision, and the peak represents the fovea, which has the highest retinal sensitivity. So you can see that in the static static perimetry, you have stimuli which give you a contour of field of vision. The stimuli are from above. And one cannot forget that, decibels are varying from different machines. You cannot say 1 dB is the same as the extent of the dB in the other machine. So you can't compare perimeters and the extent of dBs. And what a dB represents, the decibel represents, is a retinal sensitivity. So if the fovea has a high retinal sensitivity, that means it has an inverse relationship with the stimulus. And the minimum stimulus can evoke a response in an area which has high retinal sensitivity. As postgraduates, I think this concept should be really drilled down. And the definition of threshold is very important to understand strategies. As you can see in the graphs below, threshold is the decibel at which 50% of the time that the stimuli are projected, that at that locus one perceives. And anything above that is suprathreshold, anything below that is infrathreshold. And with that, we come to the test strategies on the Humphrey, the suprathreshold strategies and the threshold strategies. On the octopus, you have the normal, the tendency-oriented perimetry, and the dynamic. In suprathreshold, it's mainly for screening. You use 4 to 6 decibels above the threshold values, and you tend to check whether you're perceiving the stimulus or not at a particular locus. And how do you apply it? You have the 2-zone and the 3-zone strategy. In the 2-zone strategy, all you get is either black squares or open circles. And the black squares mean nothing, but it indicates a point of abnormal sensitivity. Locations which are seen are coming as open circles. Now this is a totally depressed field. Coming to the 3-zone, points which are not perceived by suprathreshold are tested again with the maximal stimulus, that is 0 dB. And if they are seen then, it becomes a relative defect. But if they are not seen even with the maximum stimulus, it becomes a solid square. Now, this is what is represented by the circled red. You can see the defect coming as black square and the cross as a relative defect. How do you apply it? In the Humphrey, you have the 81 point test and the 120 point screening test, wherein from the graph you can see that most of the fields on one hemifield are appearing as black, and the not seen points are 41 out of the 81 points. So how do you apply it clinically? You can see the central 30-2 field is showing you a left homonymous hemianopia. So these screening tests actually will tell you the extent and even can pick up neurological defects right away if you screen it. So your choice of the test is important depending upon what you have analyzed from the history. Now coming to the -2 and the -1 strategy, we are all used to 30-2, 24-2, but I'm sure the residents are not even given a thought to what -2 means. So -2 means that the stimuli are projected on either side of the vertical or horizontal meridian. But you don't have any directly on the vertical and the horizontal meridian. Why so? If so, what happens is that the vertical or the horizontal field cuts will not miss these points. So you have between the vertical meridian and the test point 3 degrees separation, and between test points you have about 6 degrees of separation. So these are the -2 strategies which are very important in glaucoma ordering a test. The -1 strategies, you can see the points on the vertical and the horizontal meridian, and like I said earlier, missing out sometimes the vertical field cuts may miss the vertical meridians and they may not be seen. Coming to the threshold strategy, we have the full threshold strategy. How do you identify that? You look at the raw data and you see brackets, and these brackets indicate that at all the cardinal points, each test locus, the machine has tested again. And with that, it is important to know not just those cardinal points, even points at loci where they are 5 decibels above or below the expected range, they are tested twice. So it takes a long time because it is going to do bracketing at several times at each locus. And just to give you an animated view as to what the Humphrey always does, the 2-1 bracketing strategy. So if you are seeing 32, then further you try +4 decibels, 36 dB, and now you do not see 40, so you go up now to know the exact threshold by another 2 dB. So that is the 2 dB till you see, and the threshold is 38 dB. This is the concept you should understand. On the left-hand side, you have the 4-2 double bracketing strategy. What double bracketing means is that from a non-seeing area to a seeing area, you are crossing the threshold twice. That is called double bracketing. On the other hand, in the fast-pack strategy, it is going up by 3 dB. You test with 3 dB jumps, and then you cross the threshold only once. So obviously, fast-pack is much faster. And that's why the same thing, the full threshold, which you are able to arrive at an important thing in a full threshold is the short-term fluctuation. If you look at the global indices, in the usual CETA standard that we are used to, we do not get the short-term fluctuation and the CPST, which you will get in the global indices on the ash encircled in the red. So from the variability of the test can be understood by testing each loci again and again. So there's a lot of variability coming up in the FAST-PAC, and now the full threshold and the FAST-PAC is replaced by the newer adaptive thresholds, which are these CETA algorithm, wherein you have the CETA standard, CETA fast, and the CETA faster, and the central 10-2, 24-2, 30-2, 60-4, and macula are all the test patterns, mind you. So there's a lot of, the residents find it difficult to perceive what are strategies, what are patterns. I've seen our own students make such mistakes. I just wanted to impress upon you that CETA standard is fast. As you can see, the same advanced glaucoma patient in 9.35 minutes has done the CETA standard. The same patient has taken 11.56 minutes for the FAST-PAC. And for a 10-2 also, you see it is much lesser fast without loss of anything. Because you can see on the overview that almost the same reproducibility of the field effect is obtained by both 10-2 FAST-PAC and standard at a lesser time. So how does CETA standard manage? It's very intelligent because the machine is actually is understanding what is the patient's response, what is the interval between the stimuli to be put is also dependent upon the patient's reaction time. So these are taken into account, and the patient's initial starting point is started very close to the expected age-corrected normal value. And that's how CETA standard saves time, but there is no short-term fluctuation. Now, this is an advanced glaucoma patient showing you the double arcuate scotoma on the left side and a hemifield defect or superior arcuate dens on the right side. What I want to know is, whatever be the defect, whatever strategy you use, you have to apply the Anderson's criteria to define it as glaucomatous, visual field defect. And even in the 10-2, to know whether there's a fixation threat or a split fixation, you have to do an 10-2 program whenever you find there is a defect close to fixation. And you can see on the right-hand side, the macular threshold program with the size 5 stimulus, wherein we have, you should understand that there you don't have the CETA standard, it is only on the full threshold strategy. So there you have the bracketings and you don't have the, you have the global indices in this. Coming to the octopus test strategies, the normal 4-2-1 strategy is the normal, and then the dynamic and the top of these. Top is the fastest, and one would say that top acquires most of the defects. Only thing, the nature of the defect may be a little round compared to dynamic, but most of the defects are perceived with saving time. So in today's world, you have to do things fast, give less stress to the patient, and get maximum output. You should be able to understand the visual field defect. So at our hospital institute, we have set our machine at the top strategy. Most of it, we have found excellent results. This is the 4-2-1 bracketing I was talking of. Like again, when you go from the not seen to the seen areas, the dark black circles tell you not seen to seen, and you have to increase by 4 dB till you see. And once the threshold is crossed, then you step up by 2 dB, and then again it becomes non-seen. You bring it down by 1 dB. So this is the 4-2-1 strategy, which is not used because it takes almost 12 to 18 minutes, which is long. One cannot afford. So the frequency of seeing curve one should know, because through this you understand the dynamic strategy, where depending upon the visual field defect depth expected, the machine is going to throw in steps of 2 to 10 dB. That means if you are expecting areas close to normal, you go by 2 dB close to that threshold value. And if you are having a lot of dense defect, you go as fast as in the lower diagram, the space interval can be increased to as high as 10 dB. So you will get it fast, the results. While top is a very systematic strategy where it is not testing the individual loci 5 times. It is only testing once and interpolating all its information from the surrounding areas. So it is much faster. Now these are the results of a patient on whom I have done dynamic and top strategy, and you can see that the SLV, the loss variance, is almost the same. So you have got almost similar knowledge from the top strategy. So also for the 10-2, the SLV is 7.1 and 7, which again means the same, that you get almost good reproducible data with a faster strategy, that is the top strategy. Now this is a patient who is a doctor who came as a suspect, and you can see the OCT also showing so. And here, we have seen that the CETA faster has yielded results in 1.51 minutes compared to 5 minutes for CETA standard. So if you are expecting a normal fields, you can go for CETA faster strategy in the young, it yields good results at very minimal time. And if you compare in such cases where you have a DIS suspect and you are not getting any field defect, now you can go for the 24-2C CETA faster strategy, where there are extra 10 points in the central area and you can get more amount of information. And if you get some positive yield in that, you can avoid doing a 10-2 in that patient to know whether this normal patient, because of the supratemporal notch there, does he have and a field and a wedge defect there, does he or she have any point affected in the 10-2. So in the glaucoma population, CETA faster is 33% faster than CETA fast, and compared to CETA standard, the CETA faster gives 58% faster results. So compared to this pattern, in the G2 pattern of the octopus, you have this kind of a G2 program where the central points can be assessed. StatPack is the software and the normative and statistical analysis for both Humphrey and the forum. So coming to progression analysis, what I want to say, we are all used to event analysis, trend analysis in progression. And for progression analysis, again, white on white perimetry is enough. And whether you do the 30-2 or the 24-2, the glided progression analysis software comes to results. The fields on the top are representing the baseline fields, and the field below is comparing with the baseline, and that is the event. And the graph in the middle, which represents the visual field index trend analysis, will tell you the rate of progression of the glaucoma patient. And this is in the global indices progression analysis for the mean defect, diffuse defect, SLV and LD in the octopus, where you can see that the red line shows that there is progression. The rate of progression is significant for mean defect and LD, and in this patient for SLV and LD. SLV and LD gives a better idea about progression with respect to a glaucoma patient. Now, this patient is having bipolar notch with bipolar wedge defects, bipolar early notch, so is a DIS suspect. And you find that the patient's fields have been very normal all the way through with a very stable trend analysis of the visual field index. But what you see here, you find that here in 2019, there were some scotomas, which in the overview analysis, which I showed up there, have disappeared. So you have, when you interpret fields on follow-up, you have to keep in mind the confounding factors like coexisting cataract, etc. This patient underwent cataract surgery in 20, and that's how those scotomas have been gone in the fields done recently. These are how the overview analysis programs appear. What I wanted to show here is that you have a separate overview program for the 10-2 and a separate for the 30-2. Whether you do 24-2s in between, it is immaterial. It comes up in the overview analysis. Only thing, overview doesn't have a statistical package. And now the CETA faster and the 24-2C grid can also come up in the overview. So don't get confused that if you do different strategies, you will not be able to get your analysis on the overview programs. Now this is the patient with a possible progression, and this is the patient with a likely progression. In the likely progression from 2010 to 2017, you can see how he has progressed, and the progression analysis is showing multiple triangles, solid fill triangles, which shows you there is a likely progression which is worse than the possible progression. So GPA alerts will keep you on guard, but you have to view them skeptically. Now, even though from 2010, when you compare to 2022, from the previous, you can see it has further worsened to a double arcuate, and that is probably because you have not reset your baseline after a trabeculectomy. So 2010 and the 2011 baseline should have been redefined, and your baselines have to be changed according to the interventions done. That is what I want to tell you here. Now, when you have dual pathologies, like this patient was a myope who was sent to me on medication from the Gulf, and actually was found to have a compressive optic neuropathy. And even in such cases, you have to decide what strategy, what program, and take the baseline as well as the follow-up after the neurosurgery to follow up the patient in future. What about these patients who have disc hemorrhages which are suggestive of progression? Your OCT also suggests that there is progression. But even now today, we don't have fields and strategies to tell us which is the specific one which will pick up the progression. As you can see, despite the hemorrhages, despite the wedge defects, the fields are normal here. So I did a trial of top-end dynamic. That too has not yielded any specific cause. So there are still areas which need a rethought. And keep in mind the learning effect, repeating fields on the same day, as you can see the top and one on the left, it has not given, but repeating on another day as a 16th, we have a different outcome. So learning effects as well as coexisting pathologies which can mimic glaucoma can be kept in mind. Like this patient with a macular hole, you see which strategy to use. The top strategy has yielded only an isolated central scotoma there, which is because of the field, because of the macular hole and not glaucoma progression. So also this post-traumatic and post-trauma IOFB removal patient with having a typical field defect because of the location of the chorioretinal atrophy supratemporally. So keep the mimickers in mind. Now this patient was done fields, OCTs and fields elsewhere. These are the fields done in 2022. Patient is on glaucoma treatment, blind in the other eye, but left eye. The right eye, this was the field I saw when I saw the patient now in 2024. But clinically the patient was having only temporal pallor. And which test do you order in this scenario? Changing machines and doing on other machines which are giving faster results may help results. And this patient had normal fields. Now coming to this patient who actually was a patient with, is an NTG patient. And if you look at the baseline, 2 fields and the one below, you'd think there is no GPA alert, so you take for granted that he's normal. But don't go by GPA alert. You have to scrutinize the patient because the patient was intelligent. He was telling that he's having some reading difficulty now, and the patient was found to have obstructive sleep apnea. And scrutinize the baseline fields, the fields, individual fields, like the 10-2, when you scrutinize, you find that the PSD also is slowly progressing from 22 to 23. And the patient is symptomatic. Now in today's world, you get a lot of newer strategies. This patient came from elsewhere doing Zeta strategy, which I was not exposed to. But I want to tell you that all these adaptive strategies and newer machines cannot be, you should have a little information of how to interpret them, because this patient had a nasal step defect, had a defect in 22 with the inferior thinning, and even in 24 has not progressed because he's on treatment. So apart from the strategies on perimeters, what are the strategies for success? You have to determine whether the field defect is consistent with the pattern seen in glaucoma. If the field defect is consistent with the pattern, you have to correlate with the optic nerve head finding, and also you have to correlate with visual function. Sometimes we have to do ancillary testing like the pupil assessment when you have asymmetric to rule out other pathologies coexisting, and always assess progression on whatever strategies you are. Keep in mind the confounding factors that I showed you as examples. Don't go by only the GPA alert or rate of progression if it is more than 1. And re-establish baseline after surgical interventions or in additions of medications. And the more number of field tests, the better trend analysis you get. So always do periodical field evaluation for progression analysis. Thank you.
Thank you, Dr. Meena, for that excellent presentation. Now we'll move on to the third topic, decoding unilateral glaucoma. Dr. Lima Rose Thomas is the Assistant Professor at Government Medical College, Kottayam. She did a graduation from Government Medical College, Trivandrum, and her PG from RIO, Trivandrum. She did her fellowship in glaucoma from Aravind Eye Hospital, Coimbatore. Over to you, Dr. Lima.
So let me begin by thanking the PATHANAMTHITTA Ophthalmic Society and the Amita Eye Care team for giving me an opportunity to present this. So this thing is decoding unilateral glaucoma. I was thinking what to present, what to do and all that. So I decided to tweak the title a bit and made it decoding apparent unilateral glaucoma. So that's basically the topic that I'm going to talk about. So as I'm working in a government hospital, I'm pretty sorry that our clinical photos and those kind of things will be limited, but I'll just stick on to anecdotal references of certain cases which might help us to discuss this. So a 65-year-old presented with mature cataract in the right eye and an IMAC left eye. She had pseudoexfoliation in both eyes. The IUP was 32 in the right eye and 16 in the left eye. She underwent cataract surgery, right eye after IOP control, and fundus after cataract surgery. We examined the fundus. It showed a 0.8 CDR in the right eye and 0.3 CDR in the left eye. Now this was the post-op picture, and I hope that the left eye was the learning curve of the patient. So basically we got an advanced field defect in one eye. It's pretty obvious the diagnosis is pseudoexfoliation syndrome in both eyes and pseudoexfoliation glaucoma in the right eye. So basically every time it is not as simple as that. You'll have to really think why the patient is having only a unilateral glaucoma. So primary glaucomas also can be occurring to unilaterally because of asymmetric anatomical or genetical predispositions. The management of unilateral glaucoma always requires a careful monitoring of the unaffected eye, as well as because bilateral disease can often develop. So basically there are certain studies which shows that the genetic predisposition of a unilateral glaucoma or a POAG or an NTG that is presenting unilaterally is different from when it happens as a bilateral. So the asymmetry is predisposed by some kind of a genetic the information. And also research on anterior segment anatomy by multiple UBMs also shown that there is a difference in the two eyes. Wherever the primary glaucoma is appearing earlier and more, the anatomical peculiarities shown in the UBM is different between when it is a bilateral disease, almost symmetrical bilateral disease. And same thing, the patterns of visual field defects is also different when you consider unilaterally more in the primary glaucomas, and that is it. You see that it is more often affecting the superior hemifield for some unknown reason. So one thing that you look is you're looking for predispositions in the eye, why it is asymmetric, so why it is more. And also you have to also look at the other eye, whether this is following suit. For that, what all we can do? One is we look for, you just compare the two eyes, and they compared a lot of cases of unilateral and bilateral POEG and NTGs, which is presented as very much asymmetry. So most of the factors were similar, but what is in NTG, they show that the RNFL is more thinner in the NTG eye, which progressed. So that's what they could see. Then ganglion cell complex study is something that is very important. You need to study that. And the FLV and GLV, that is a global loss volume and focal loss volume, where the focal loss volume was the most sensitive index of in the macular program, OCT macular program, which should predict a progression in the fellow eye, where you have a unilateral glaucoma. Now, optic nerve perfusion studies in early glaucoma is also important. In late glaucomas, neither the macular or the perfusion studies are not that important. You can do it by doing the OCTA, laser Doppler flowmetry, color Doppler imaging, as well as fundus fluorescent angiography. So OCTA studies, it is all these things shows early microvascular changes of the things before the significant optic nerve damage occurs. Same thing with laser Doppler. There are different studies shown that the laser Doppler showed that once you introduce a treatment, the laser Doppler shows increased perfusion of the. That means that perfusion is an important factor in determining the progression in glaucoma. Same thing with color Doppler and fundus fluorescent angiography studies. So here the NTG patients have significantly delayed choroidal filling, so which is seen in FFA, so indicating impaired choroidal perfusion. So that is also there in the study. Whether it's significant clinically is something that we have to look for. Now, coming to the case 2. It was a 23-year-old presenting with a defective vision in the right eye. The vision initially was pointing finger 2 meters, and right eye was 6.6 in the right eye and 6.6 in the left eye. IOP was 26 millimeters of mercury in the right eye and 16 in the left eye. Fundus showed a 0.8 cupping in the right eye and 0.4 cupping in the left eye. We had to really ask the patient. We were not getting any history. On repeated asking, he talked about we did the gonio and saw a lot of hyperpigmentation in the eye with glaucoma. So we asked him again and again, and ultimately he remembered a trivial trauma that occurred in the right eye. So we got it as a traumatic glaucoma. So it required a lot of questioning. And he underwent trabeculectomy in the right eye, and actually his IOPs came down. It was controlled. And interestingly, we did a field review. The vision was also, BCVA was something like 624 after cataract surgery with the glasses. And we made a field effect. The field effect was not much. And surprisingly, the cup had reduced. I don't know how it reduced in a 23-year-old, but basically after the trabeculectomy, we saw that the cup was only 0.6. And for sure, I saw it, and there was a difference. Anyway, so we come to secondary glaucoma. Traumatic glaucoma, obviously, if it is an acute trauma and there is an IOP, we're not going to miss it. But if sometimes it is a trivial trauma that happened long way back and the patient presents years later with a glaucoma, they might not remember to give you the history. So we'll have to ask it and find out. Pseudoexfoliative glaucoma, neovascular glaucoma, IC syndromes, lens-induced glaucoma, obvious diagnosis, we don't have to search further. Inflammatory glaucoma also can be obvious, but there are very white eye uveitis like postnasclosing syndrome, Fuchs heterochromic iridocyclitis present with glaucoma. So you think that the patient is presenting with glaucoma, but actually it is a uveitis, and we need to find it out by careful examination. Now coming to the congenital and developmental glaucoma, all these things are bilateral syndromes, but all these things can present with very much asymmetry. So it might look like a unilateral glaucoma. But in that, Stouge-Weber syndrome and neurofibromatosis 1 Both of those are unilateral glaucomas. And in neurofibromatous, just like we described the Stooge-Weber syndrome as glaucoma occurring in the side of the nevus flammeus, in neurofibromatosis, it is in the side of the plexiform neurofibroma. So you can see there is a predisposition of the eye on the side of the plexiform neurofibroma to have glaucoma. Now another case is a 32-year-old female who presented, she was diagnosed to have glaucoma, was on topical drugs. IOP was 14 millimeters of mercury in both eyes. Fundus showed 0.6 cupping with IT notch and corresponding field effect in the left eye and a normal disc in the field in the right eye. So I asked her the history. She had a history of preeclampsia. She was on antihypertensive drugs post-natally also. And on checkup, she went a little later for checkup and found that there was hypotension. And then the drugs were stopped. I also stopped the drugs and it was not progressing. I followed up the patient. The IOP did not rise and the fields did not progress. So there are some cases like that where you have an event that happened, maybe a high IOP or a hypotension that happened as an event. And these are non-progressive glaucomas in the sense that there was a uveitis, there was an IOP, there was steroid use, there was an IOP hike, and then it doesn't progress. So you needn't treat them. You just have to follow these patients up. And one of these interesting cups can be associated. You also need to look at the retina because it could be a PRP done or something. Patient might not tell. On peripheral examination, you might see a PRP and a patient usually develops a cup later, which is not glaucoma basically. It is just a PRP done and the cup develops. Now case 4 is a 35-year-old male patient presenting with non-specific complaint. He was going to Gulf in 2 days and wanted a routine checkup. His BCVA was 6.6, pupils brick, IOP and CCT were normal. And fundus examination revealed a 0.9. This is a bilateral glaucoma, but it can happen unilaterally also. So that's why I showed. This was a cup of the patient, but on OCT, it turned out to be an optic disc pit. So there can be physiological cupping or anomalies, which can also look like an unilateral glaucoma. It depends on the cup size, whether it's normal or not, will depend upon the disc size. So in a large cup, a large disc, a large cup may be normal. In a small one, it may be difficult to pick up early pathology. So this is the disc size can be measured by slit lamp biomicroscopy. Also you can do the OCT and also direct ophthalmoscopy. You can project the grid that you look for the fixation onto it. If it is much larger than that, it's a larger disc. If it is equal to it, it is a normal one. It's smaller, it is a small disc. So you can even measure the disc size using a direct ophthalmoscopy grid. You can see here on first appearance, the disc appears a little, the cup appears more in the right eye, but mostly it is normal because there is a disc size asymmetry. Now, congenital anomalies and hereditary optic disc anomalies that can present as the unilateral glaucoma. Look like one is a tilted disc, then optic nerve head pits, optic nerve head collobomas, morning glory syndrome, again it's a unilateral presentation, papillorenal syndrome, and superior segmental optic nerve hypoplasia. So these are cases that presents like unilateral glaucoma, but they are non-glaucomatous optic nerve head cupping. Now case 5, it was a 50-year-old female presenting with defective vision. The BCVA was 6.6 both eyes. IOP was normal. Disc right showed a CD ratio of 0.6 with pallor ahead of cupping. The left eye was normal. The field showed scotomas in the paracentral areas in the right eye. Of course, a neurosurgery consultation was done at that time, and it turned out to be NAD. The diagnosis was NTG right eye, and the treatment was started. But on follow-up, the field shows progression in right eye as well as left eye showed a hemifield defect temporarily. So it was like that. And the MRI brain showed a pituitary macroadenoma. Patient underwent treatment with carbapenem for this thing, and later a neurosurgery was done. And after the surgery and on follow-up, it was complete pallor of the right eye, and left eye, the fields got better, they're completely normal. The right eye went to atrophy. So what are the red flags for possible non-glaucomatous cupping? So pallor will be ahead of cupping, mismatch between the degree of optic disc cupping and the degree of visual field loss, the presence of an afferent pupillary defect, rapid progression of the visual loss, glaucomatous appearing field loss in a patient with an anomalous or a hypoplastic optic nerve in which cupping cannot be easily judged, early loss of color vision, and age less than 50. So these are the conditions in which you get. One is anterior ischemic optic neuropathy. So you can see a cupping in that. The reason is there is cupping occurs due to loss of prelamina as well as lamina damages. Prelamina occurs because of damage to the retinal ganglion cells. So any condition that produces a damage to the retinal ganglion cells will produce a lamina sign. So the cup which you see will be a shallow cup. So lamina cribrosa when damaged and the scleral ring is damaged, that occurs in inflammatory conditions like optic neuritis also, and in glaucoma, then you get a larger cup or a deeper cup. So the cup will be shallower. You will have a cup, but it will be shallower in conditions like anterior ischemic optic neuropathy and also compressive optic neuropathy. So this is a previous ischemic optic neuropathy, and compressive or infiltrative lesions usually in the cellar region. The supracellar region is the ones that produces. Aneurysm can give you a very variable thing because it depends on where it presses the optic nerve. Other things usually give the usual pictures that we expect. And here again the thing is there will be a shallow optic disc cupping. Pallor will be more than cupping, and the low visual acuity and red the color vision abnormality will give you an idea, because glaucoma, the visual acuity remains normal for a long time. So these are the conditions. Also, you have something called a dominant optic atrophy. Here you can see temporal wedge defects in the cup. So that's what you see. Neurosyphilis also can produce optic nerve head cupping, inflammatory, and making the lamina cribrosa more susceptible to normal IOP. And traumatic optic neuropathy also rarely can present with cupping. So you should look up everything: patient's age, associated neurological and endocrine symptoms, prior blood loss, major surgery, family history of glaucoma, past medical history, and everything should be examined very properly. And not the speed of progression. Don't rely on a single piece of information. Remember that a patient may have more than one disease. Glaucoma can coexist with the neurological one. Automated perimetry should be done and carefully interpreted. So basically, when you see a retention of central acuity, absence of dyschromatosia, vertical cupping that corresponds to a nerve fiber or visual field defect, is generally glaucomatous. And the most specific signs of known glaucomatous cupping are age of 50 years, optic disc pallor in excess of cupping, and field defects that border over the vertical meridian. So these are the ancillary tests. So therefore, when you have a unilateral glaucoma which you can't explain, and imaging is something that you should do, MRI should be done for the patient, you might find out something that could save the patient. Carotid Doppler electrophysiological test can be used as ancillary testing. In OCTs, in non-glaucomatous cupping, have a lower mean RNFL thickness in the nasal quadrant, lower average macular thickness, and lower macular volume compared to the glaucomatous eyes. So to conclude, the bottom line is, it is important to keep in mind that not everything that looks like glaucoma is glaucoma. Your patient is depending on you to know the difference. Thank you.
Thank you, Dr. Lima. No further questions.
Ma'am, do you use FDT in your hospital? No, preferential double deck.
No, we don't.
No, we do not. Yeah. What is your protocol for newly diagnosed glaucoma in first year? How many visual field you will do after detecting a newly glaucoma patient in the POAC, primary opening? How many visual field you will do?
So the idea is that even though AAO guidelines
yeah,
and all will tell you,
they
will tell 5 fields, etc. in a year.
Yeah.
But in our setup, I would say that by hook or crook, you have to have a good baseline.
Good.
So what we do normally is, the moment I suspect it as a glaucoma suspect, or if the patient is definite glaucoma, a suspect, I can increase the gap between fields, but a definitive glaucoma patient, I call them at weekly intervals, or in our hospital, we have a cutoff of 2 weeks. We don't charge them if they come again to us within 2 weeks. And that is one of an incentive to make the patient come actually. So a baseline field, if it is having, if there are artifacts in that field, we give them a chance to do once again within 2 weeks. And then if still we don't have a good baseline, call them a month later, and maybe within 3 months, we have to have a good baseline field.
Yeah.
And if it is a suspect, I give a maximum of 3 months time. If it is a definitive, I'll call them earlier because I want to have a good baseline visual field. So I would say that
3 to 4 months.
3 to 4 in 3 months time to have a good baseline. Yeah. Subsequently, you keep doing only when you expect there is a progression. Sticking on to 6 fields in a year and all is not practically possible in our setup.
Our Indian scenario. Yes. Do you follow same strategy if you do 24 dash?
No, see, actually,
the same thing you will follow 30-2.
When I was a fellow in the institute there, they used to do a baseline always 30-2 and follow up with 24-2.
24-2. Yeah.
So that is a good concept because you can pick up the neurological fields in a 30-2. You have lesser number of test points in a 24-2. You may miss neurological. And the artifacts also you can pick up better probably because you have more test points in 30-2. Temporal wedge defects also you can pick up better in a 30-2. So putting all that together, the dictum what I was taught is good enough to do a baseline 30-2 and follow up serially with 24-2.
24, that's a
Because
good,
the
yeah.
overview programs as well as GPA accept whether you do 30-2 or 24-2 to set as baseline.
Which GPA you follow?
Guided-
Trend analysis or?
So we are doing, we have both.
Ah.
So
Which is the better
it-
about? Yeah. Which is the better results?
The better results means it is easier to do on the octopus.
Okay.
But I quite love Humphrey because
No, we only use
have
Humphrey.
evolved
We
through
don't have
Humphrey.
Octo-
So I feel that it is very good to go on with either.
Ah.
But one thing is certain, people who don't do consistently good fields on Humphrey, I shift them over to octopus to get a good baseline on the octopus. People, it does faster, the top strategy is much faster. And so I do feel that people who can't do the Humphrey despite repeated attempts are better candidates for the octopus. That is one method one tip that I follow.
Thank you,
But
Dr.
the
Meena,
progression
for that.
analysis is good enough on both. And I think I prefer the Humphrey a little more because it gives a little more in-depth about the GPA alerts and etc. things.
Thank you, Dr. Meena. Just one quick question. From the day anyone joins post-graduation, it's emphasized, do a field analysis. But unfortunately, many of our elderly patients who were doing their fields well and now they can't cooperate anymore for non-ophthalmologic reasons. So how does the progression analysis on the OCT compare to the progression analysis that we have with these machines on perimetry?
Actually, that depends upon the severity of glaucoma the patient has. In severe glaucomas, I don't think there is any point in keeping them doing the OCT because once the floor effect is touched, then you have to probably go by the macular programs, the GCIPL or the macular maps, which is available on the Cirrus OCT or the Spectralis. So I don't think you can compare a structural progression with a functional progression. For the early glaucomas, yes, because of some torticollis or spondylosis issues, if the patient is not able to do fields, we can do serial structural progression analysis. But for the elderly patients who can't sit before the machine, for the fields, if they have early glaucoma, yes, we can follow up with the OCT. But if they have severe glaucomas, I think we have to, it doesn't make much of a, it doesn't help us to plan our management strategy based on the serial OCT progression.
Thank you. One quick question for Dr. Lima. You talked about the unilateral glaucomas. Now, just say you know from history that the patient did use steroids and was a steroid responder, and now they've stopped steroids, pressures are normal, huge cup disc asymmetry. The patient has come to you for the first time. And the patient has already been started elsewhere on medication in that eye. Can you stop the medication the first time you see it if you are really sure, or do you have to follow up the patient and prove no progression on fields before you take the patient off medication?
I do that. I mean, I would follow them up. I don't take it on the first time. Sometimes if they're using something that reduces the IUP for like a prostaglandin and all that, maybe we can reduce to something that reduces. Sometimes I have this betaxolol as a comfy drug where I think I don't have to, kind of give a glaucoma. I'm 100% sure by instinct that the patient does not need AGMs, but still you're afraid to just completely stop the drugs. So sometimes I maintain them on betaxolol, look for the progression, and then, look how much it is increasing after I stop, and then decide. You can always stop the drug, ask the patient to come back and look how much it increases. And that might convince the patient, make the patient understand that it's very important that you come back because your IOP might, I'm just trying a trial. And if you think that the patient has comprehended, then you can stop the drug and ask them to come back. But if you think that the patient might not understand entirely what you're saying, then maybe you have to just reduce on the drug, how much the IUP reduction is, slowly reduce it. Use drugs that don't reduce up to prostaglandin, make it something that is in between, and then slowly stop it.
Dr. Lima, very good presentation. I have one or two questions for you. One, case 3. You told 23 the preeclampsia patient. Is she on any systemic beta blockers?
No. She continued the antihypertensive drug for a long time after pregnancy.
After no beta blocker because of the anti-glaucoma medication. Beta blockers, they won't act.
They continued using the antihypertensive quite sometimes. I was assuming that maybe the NTG happened during that time. when she was having that nocturnal
Maybe the
hypotension.
nocturnal hypertension.
So
because
I
of
was
the
thinking,
no
so I
blood loss during any nothing.
No,
other-
not like that.
no
It was
other.
just a preeclampsia. She was very serious, and she continued the medications for 4 or 5 months after. When she went back, it was hypotension, and they stopped the antihypertensive. So I was just assuming. I just again followed up the patient.
As said by you, disc evaluation by direct ophthalmoscopy. Actually, we use plus 90 diopter lens with magnification power. Do you use or?
No, that we use only that. I don't use a disc one, but I'm saying that in case only what is available for you is a disc, only the direct ophthalmoscope, you can use that also to find out whether the disc size. The ideal thing is to use a 90D and a slit lamp and measure the this thing properly with the magnification factors.
One more patient you saw, the trauma patient with the glaucoma, any angle recession component?
No,
in
no,
that?
it was not
Because
there, but it
because
was
trabeculectomy, he went under, but he told visual field is improved. Because disc
Visual
also.
field we couldn't test initially when he came with that high IOP. His vision was low. Because of that, we didn't test the. We immediately actually we diagnosed him on. It was a staff's son actually. So what made us do is we on Monday we saw on Thursday itself the trabeculectomy was done. So we didn't have much time in between to evaluate, and the vision was low. But after this thing with the myopic astigmatism, like after the trabeculectomy, we were able to give him a vision of around 636. So we did the fields. Field was not very much.
Like congenital glaucoma, the disc also has a change. No.
Yeah.
because
I didn't expect the change to happen in 21 or
because
22
usually
year
we
old.
see in the congenital glaucoma, because
so
of clear
that was something that's
rigidity.
really, and two independent doctors felt that the cup has improved. I
Thank
wish
you.
I had taken the photograph so that I could demonstrate it more objectively. But we, both of us, two independently, two people felt definitely that the cups have improved.
Thank you so much. Thank you.
Thank you, sir. Now, I would like to request the speaker and moderate photo session.
Sir, one more question regarding the IOP management. Can we do this NCT measurement, or every time do we have to follow this applanation?
NCT is basically a screening, and when I know that the patient has advanced glaucoma, I stick to applanation. If it is just that we need to just reduce the IOP below 20, it's an early glaucoma, we can manage, then NCT will do. But when it comes to a patient whom I'm really closely following up, it's an advanced glaucoma, I don't want any mistake, then I do. Only for those patients, I do applanation.
NCT, I think, should be restricted only as a screening tool to refer to the glaucoma clinic once an IOP has a cutoff that you put for your set of patients. I don't think NCT is a good tool for follow-up of patients with established glaucoma on whom you have started medication. It's going to be GAT and GAT alone.
Now, I would like to request Dr. Sabida to hand over token of appreciation. Dr. Meena Nair. Dr. Lima Rose Thomas. Dr. Rani Nair. Dr. Kashina Shenai. And Dr. Jacob Koshi.
Next, we'll move on to the much-awaited NETHRAM Film Festival. I request Dr. Aditya, Senior Cataract Surgeon at Amida Eye Care, to take over the session.
Good afternoon, everybody. So we'll move on to the film festival session. Rather than wasting any more time, we'll ask the contestants to please come forward. The contestants can please come forward and occupy the front seats. We have 4 contestants competing for this session. And we have a panel of judges. We'll start our clip first. contestants what we have for this session today. Dr. Chaitanya R. Warrior from Chaitanya Hospital. Dr. Samvedya V. from Giridhara Hospital. Dr. Archana Kumar from Amrita Hospital, Kochi. And Dr. Shihail Jinna from Sri Nethra Eye Care. And we have panel of judges also. May I ask the judges to occupy the seats? Dr. Satish Thomas, sir. Dr. Shaji, sir. Dr. Bastin, sir. And Dr. Shishir Burgess. The criteria to judge the video will be the novelty of the topic, content of the video quality and editing, and keeping the time of the 4 minutes. And the judges' decision will be final. We will be having only single winner because already we have only 4 contestants. So if the judges are ready, can we go ahead with the video? Chaitanya Warrior, can you please come up and...
Many a time at OPD, patients will come with complaints of eye strain, blurring of vision for reading, diplopia while reading, missing letters during constant reading, or even missing lines during reading, eye strain or eye fatigue during constant work. Orthoptic examination begins with a proper full refraction for both distance and near. A quick cover-uncover test to assess phoria for near and distance is very important. Same way, ocular movement should also be assessed. Sensory status of the eye is examined by Wordford dot test for distance, and near we will use Titmus fly to assess the stereopsis. Accommodation can be assessed by 3 steps. First step, we need to see the amplitude of accommodation. We use RF ruler to assess the near point of accommodation. Using RF ruler, we will be using N12 size letters and the reading will be first sustained blur. We will calculate accommodative amplitude by 100 divided by near point of accommodation. Next, we need to check the relaxing ability of accommodation, that is negative relative accommodation or NRA value. NRA is assessed by putting plus 0.25 diopter lenses in increasing value, and the first sustained blur is the endpoint. If it is more than plus 2 diopter sphere, the value will be abnormal. Next, we will assess the stimulation ability of accommodation by positive relative accommodation PRA value. The sustained blur is the endpoint of PRA value. Next, we are assessing the flexibility of accommodation using accommodative flippers and dynamic retinoscopy MEM, monocular estimation method. Next is to assess the convergence. Here we are using the same RF ruler to assess the near point of convergence. Here the sustained diplopia, the first diplopia seeing double is the value. Then we need to assess the negative fusional vergence and positive fusional vergence. For that we are using prism bar. Negative fusional vergence, the prism will be kept base in. For positive fusional vergence, we are assessing the convergence ability of the patient. Here we are keeping base out prism. Negative fusional vergence will assess the divergence capacity and positive fusional vergence will assess the convergence capacity of eye. Vergence facility we will be using prism flippers. These all values will give us the convergence status of the eye. This will help us to find out whether there is any convergence insufficiency or any divergence excess and so on. And we can sort out and manage these patients using proper refractive correction along with prism glasses if there is any phoria less than 20 prism diopters, and any accommodative or convergence issues we can treat with orthoptic exercise, Brock string exercise, cat card exercise, lifesaver cards. This will help us to sort our patient's issue and to clear the patient unhappiness to a happy, smiling patient.
Excellent video, Dr. Chaitanya. Can we have discussion with judges? Any questions, sir?
Good presentation.
Thank you, sir.
So, what is your protocol? When do you subject patients to all these kind of
If
gamut
the
of?
refractive error is if the refractive error is not accounting for the eye strain of the patient, or the patient is 6/6 uncorrected visual acuity is 6/6 N6, but most of the time they are complaining of eye strain or asthenopic symptoms, or during constant reading they are missing the letters or fatigability during reading. That time we will subject to orthoptic exercise, orthoptic clinic, and will do the full orthoptic evaluation to rule out any vergence abnormality or any accommodative issues. We will first categorize the patients, then we will send for this.
Do you have any age criteria for this?
Most of the time it will be less than 40 years before presbyopic, or even sometimes 35, 37 onwards, sometimes pre-presbyopic correction will start. Less than that, 35, less than 35 age.
Anybody from audience has any questions? Shall we move on to the next presentation, sir? Thank you, Dr. Chaitanya. Our next presenter, Vidya. Can you please come onto the stage?
This video demonstrates minimally invasive levator advancement, a one-suture technique. Blepharoptosis is a common eyelid disorder in which aponeurotic ptosis is the most common form of acquired ptosis. It also known as the senile or involutional ptosis because it occurs most often in elderly. Aponeurotic ptosis can occur due to dehiscence, disinsertion, or degeneration of levator. It can be corrected surgically through anterior as well as posterior approaches. Anteriorly in the form of external levator advancement, posterior approaches are in the form of Mueller's muscle conjunctival resection, and posterior approach white line advancement. Here we can see the pre-op and post-operative pictures through both the approaches. There are various pros and cons related to both the approaches. The field of ophthalmology is increasingly moving towards minimally invasive surgeries, so here we demonstrate a small incision levator advancement under local anesthesia, done for an involutional ptosis in a 70-year-old female at our center. This procedure was originally devised by Hector MacDonald in 1993. Lid crease marking done. Traction sutures taken. An 8mm lid, crease incision done with the help of radiofrequency cautery. Orbicularis dissection is done, suborbicularis dissection carried out in preseptal and pretarsal plane. Minimal pretarsal orbicularis is excised. Orbital septum is opened and retracted. LPS aponeurosis identified and sutured to the tarsus with non-absorbable single-box suture with 6-0 proline after adjusting the lid height. Lid crease forming sutures taken from skin, pretarsal orbicularis to LPS to preseptal orbicularis and skin with 5 to Nero Vicryl. 2 sutures taken. These are the preoperative and postoperative pictures of patients who underwent this procedure. Advantages of this procedure are: there is lesser anatomical disruption, reduced operative time, rapid healing, and minimal scarring. So to conclude, this procedure can give excellent outcomes in selected patients with aponeurotic ptosis.
Fantastic video, Dr. Samvedya. Judges, for the questions.
A good presentation.
Thank you.
Like, how many cases you have done this?
We have done around 10 cases.
Okay. What do you feel the main advantages other than the cosmetic and the rapid recovery?
Actually, it is better for a patient who's like sick, like who have difficulty to lie down for a longer time. So this procedure takes only around like 10 minutes. The regular classical procedure would take around 30 to 45 minutes. So
do you feel any difficulty to identify the structures because it is small incision?
not really, sir, because
Yeah, then why don't you do this for all cases?
Actually, this procedure, like since it's a minimal invasive, the lid contour can be affected. So the patients who requires a better aesthetics, like for them, yeah, this could be
Disadvantages?
no, not. Like for usual ptosis, like we call the patients for like 1 week to then 3 weeks and 3 months follow up. So patients, not really, because we are doing this for only mild to moderate doses. So some patients do get under correction, but not many. Longest follow-up was like 1 year, ma'am.
Maximum follow-up you have?
Maximum follow for the patient
Yes.
was 1 year. Yeah.
1 year.
Yeah.
Okay, thank you.
Thank you.
Thank you, Dr. Samvedya. We'll call upon our next speaker, next contestant, Dr. Archana Kumar.
Corneal patch graft for a non-healing fungal infection of a phaco wound. Infectious complications post-cataract surgery pose a serious threat to vision. Although literature contains several reports on post-op endophthalmitis, there are few published data on corneoscleral wound-related infections, especially of a sutureless self-sealing phaco incision with fungal infection. In this video, we will see such a case. A 56-year-old man, known case of type 2 diabetes, gave a history of an uneventful phaco surgery in the left eye, with post-op 6/9 vision, now with pain, watering and photophobia, on moxifloxacin and natamycin eye drops Q2 hourly. Slit lamp examination revealed infiltrate along the side of the incision and stroma of the internal wound with AC reaction. Staining with cobalt blue showed minimal epithelial uptake due to a more deep-seated infection. ASOCT showed hyperreflectivity of the posterior stroma with endothelial exudation. The patient was taken up for intracameral wash followed by intracameral intrastromal injection of amphotericin B. Yet the infection didn't subside and thus was taken up for a corneal patch graft. Stromal punctures are done to mark the area of dissection with a 26-gauge needle stained with dye. Calipers are then used to measure the dimensions of the patch graft required and marked with a sterile marker. The donor cornea is then marked at the limbus peripheral corneal junction and the exact shape of patch required is dissected. A stencil is then made out by tracing the edges of the donor tissue on surgical filter paper. The advantage of fashioning a stencil is that we are not limited by the round margins of a corneal trephine and can exactly dissect out the diseased tissue. The stencil is then used to trace out the boundaries of dissection of the recipient cornea. Manual dissection of the recipient cornea is done keeping in mind to go beyond the level of infiltrates in the stoma with a 1 mm clear zone. The graft is then placed and 10-0 nylon sutures flush with the recipient cornea. Post-op day 1, he had a well-opposed graft-host junction with intact sutures, and 1 month post-op, the patch graft was in place with a healthy junction and no anterior chamber reaction. Fungal infections of a tunnel incision present a therapeutic challenge because most available antifungals are fungistatic and have poor penetration to the deeper stroma, and use of corticosteroids may cause the organism to spread diffusely and gain early access to the AC and vitreous. Thus, early surgical intervention with the patch graft can provide favorable outcomes. Thank you.
Thank you, Dr. Archana.
How do you decide the shape of the graft? Usually we are using banana graft. And you have taken a pentagon shape. Why?
This was to better delineate the diseased tissue margins. So that was what was different in this case. That was done differently.
How many cases are you have done?
It's actually done by my consultant, sir. He's done
Okay.
1 case of this.
Every time you are taking this pentagon shape?
No, sir. We measure accordingly, and the pentagon shape best managed to cover the boundaries of the dissection that was needed.
Yeah. Is it deep lamellar or?
No, full thickness.
Full thickness.
Full
Oh, okay. Thank you.
Pseudo-faking or faking? Pseudo-faking.
Yes.
Post-phaco.
Post-cataract surgery, sir, from an outside.
So did you excise the entire wound area of?
Yes, sir. Yes, sir.
Entire wound area.
Yes, sir. Yes, sir. Yes, sir. We had given systemic antifungals and intracameral, but it did not respond. That's why we went ahead with the patch graft. Systemic. Yes. Yes, sir. For around 2 weeks, and then. No, sir. We have followed up. He was seen recently 2 months back, and his vision is 6.9. No, 6.6 parts. Yes, sir. But there was no record. No record.
Thank you, Dr. Archana. Next is Dr. Shihail Jina.
Proper visualization with centration, illumination and artifacts out the way is crucial for a surgery. It begins with a triplanar incision for self-sealing anterior chamber. Continuous rhexis is done with needle 1 to 3 mm away from margin, with optimal pressure and pull-on flap, keeping the anterior chamber steady. Hydrodissection is required for good separation of layers. Dialing the nucleus may be done to verify adequate hydrodissection. Deep trenching is done till red reflex is slightly visible when the first division is made. Holding the epinucleus or superficial part of the nucleus doesn't help while chopping. There has to be good gain into the substance for a deep split. On the other hand, a posterior plate prevents the piece from freely rotating and being eaten up. While emulsifying the last bit of nucleus, the chopper is held away from the capsule and a low-energy phaco is used. Cortical wash begins by pulling the cortex to the center and then aspirating it. The irrigating cannula may be used to push in fluid to separate cortex from the capsule. After IOL insertion, it is also important to remove all viscoelastic from under the IOL. In cases of small pupil, iris hooks may be used to expand the pupil. The hooks are placed through additional side ports, made at a lower plane created more vertically downwards. The hooks are tightened later to perform the remaining steps normally. It prevents any iris trauma or zonular strain. During last piece emulsification, due to direct phaco energy to the posterior capsule, a rent like this may happen, creating central large craters, and as a consequence taking the tip to the extreme periphery for holding lens matter is inevitably disastrous. A rent may become obvious as an area with the clearest view of the background, and the lens matter may escape into the vitreous through this area. In small posterior rents and in absence of vitreous in anterior chamber, placing the lens in the bag may be attempted. Complications in a surgery should be identified at the earliest and should be managed adequately.
Okay, Dr. Shiai, can we have a question, sir?
Yeah. Okay. What is the take-home message with your presentation?
Sir, it was my initial days of FECO, the steps which the mistakes I created initially. So how we can prevent those mistakes and do a better FECO in the initial days. That was some most main message from my
FECO that
Sir, I do FECO chip, FECO chopping. Stop and chop and FECO chop. Here I have used stop and chop. So initially, usually it starts with the stop. I was initially taught the stop and chop method only. So.
Have you ever tried for divide and conquer?
No, sir, I haven't tried it yet.
No. Okay.
Okay. Any questions from the audience? Yeah.
Yes, sir.
What do you want to come with? These are the common problems that everybody faces. Is that what you want to convey?
Yes, sir. Mostly, most of the beginners start with these mistakes, like making the big craters, so the adequate hole is not there, adequate split is not being created, and even when we do the FECO, mostly we see only the right hand, the FECO machine only, but we forget the chopper which we have in the left hand. So mostly it becomes a rent or some other complications happen with that. So
is it advisable to use sharp
chopper in initial days during the phaco? We have seen the very sharp chopper.
Sir, initially it is better to learn with the dialer than going with the chopper.
Because your chopper is very, you see, with the holding the other hand is, you are not moving very fast.
Yes, sir.
So, Varghese.
Yeah, thank you, doctor. Thank you.
Yes, sir. So we have finished all the presentations. Oh, sorry. We'll give some time for the judges to calculate the marks. Is it ready, sir? The quote is by one of the great surgeons, I mean the father of surgery, Maharshi Sushruta. When I was trying to search like what all good qualities ideally a surgeon or a clinician should have, when I was searching, I found this shloka by Maharshi Sushruta, which says, Shauramya Shukriya Shastra Taikshanya Suvedave Patu Asammohasya Vaidyasya Shastra Karmani Shasyate. Means what a surgeon should have as a good quality is shaurya. Means it's not the shaurya of the war. It's the surgeon should be confident enough to go ahead with the given surgical procedure. He should be acting fast. I mean, any complication, any emergencies he comes across, the decision making should be as fast as possible. Shastra Taikshanya, I mean, all the instruments, obviously, nowadays we have it ready-made, but probably by the time when he was operating, he made all the instruments on his own. Then Svedavepatu, what he meant was the surgeon should never get frightened because of any complications which occur. I mean, he should be ready with the plan B probably so that he doesn't have shaky hands and all. So it should be very stable hand. And asammohasya, I mean, he should never lose a hope when he's operating. So whatever complications he comes, he should always be ready to face them and try to the best of his abilities. He should not leave it halfway down. So this was given by Acharya Sushruta so many years back, and I think still it holds true. That's why I thought I will share this quote with everybody. By the time we'll just confirm whether the...
So any guesses from the audience? So after a decision from all the judges, our winner is Dr. Samvedya V with her small incision levator aponeurosis surgery. Congratulations.
Can I request the judges to hand over to the winner? Dr. Samvedyak, please come on the dais. Congratulations. The prize money is sponsored by Sun Pharma. Thank you. Thank you, sir. Thank you.
Actually, all the presentations were good, but one common thing for future presentation is at the end of the presentation, you should be able to convey some message to the audience. So your presentation should be having some aim and what you want to convey to the audience and what is the novelty and what are the take-home messages is more important when you present. Thank you.
I request Bastin sir to give over the certificate of appreciation to all the contestants. Dr. Chaitanya, our warrior. Dr. Shihail Jina. Dr. Archana Kumar. Dr. Samayda, you can collect your certificate too. So we'll conclude the session and move on to PG case presentation. Over to Dr. Ann.
So our next program will be competitive session for the postgraduates. So we have a lineup of presentations by our talented postgraduates awaiting. So before we begin, let's invite our judges, Dr. Jisha, Professor, Kottayam Medical College, Dr. Shane Matthew, Senior VR Consultant at Chaitanya Eye Hospital, Thiruvalla, Dr. Kashanatha Shenoy, Professor and HOD, Pushpagiri Medical College, Dr. Manjit P.S., Associate Professor, Kottayam Medical College. So here is how competition will proceed. Maximum time allotted for each candidate is 5 minutes, followed by a question and answer session where judges can ask the questions. Points will be awarded based on the presentation skills such as stage presentation, voice modulation. Marks will be given for the slides, and we'll see how innovative they are and the workup and management of the case. So without further ado, let's begin with our first presenter, Dr. Anaka from Giridhara Institute.
So good afternoon. Today I am presenting the case of a 9-year-old boy who presented to us with complaints of nodular swelling and defective vision in the right eye since birth. So his parents noticed a nodular growth in the right eye few days after birth, which was non-progressive and painless. They also noticed the complaints of defective vision since childhood. There was no history of any redness, pain, foreign body sensation. There was no complaints of diplopia, no history of trauma, foreign body fall infection or any surgeries. Ophthalmic consultation was done previously for the same complaint at 9 months of age and 3 years back and was told nil visual prognosis and no need of any surgical intervention. They were advised only patching of left eye, which was done only for 3 months. No further follow-up was done. No similar complaints in the other eye. His birth history was uneventful. His general examination, white test and systemic examination were all within normal limits. Coming to his ocular examination, his head posture was normal. There was no facial asymmetry. He was orthophoric. There was no ptosis, proptosis or nystagmus. Ocular movements were full and free in all directions. His best corrected visual acuity in the right eye was CF 2 meter N36 and in left eye was 6.6 N6. Coming to the examination of his right eye, lower eyelid was retracted. The lower punctum was displaced laterally and the contour of the medial canthus was altered. 11 into 9 mm nodular yellowish white mass, which was non-tender and immobile, was noted at the temporal limbus, extending vertically from 10 o'clock position into the inferior of fornix. The inferior extent of the mass could not be delineated. Horizontally extending from lateral fornix, encroaching 4 mm into the cornea, and with the presence of hair follicles on the surface. In the cornea, we can see that the mass is extending from 10 o'clock to 6 o'clock position with involvement of the infratemporal 1/3 of the pupil, and rest of the cornea was within normal limits. A similar small mass can be seen in the medial limbus at around 4 o'clock position. This is his external photograph showing the same findings. Rest of the anterior segment examination was within normal limits. His IOP could not be measured. His retinal examination was within normal limits. His left eye examination was essentially within normal limits. So to summarize, a 9-year-old boy presented with complaints of nodular swelling and blurring of vision in the right eye since birth with a visual acuity of CF 2 meter N36. His examination, right eye showed yellowish white nodular lesion of size approximately 11 into 9 mm, extending from the vertically from 10 o'clock to inferior fornix and horizontally from lateral fornix 4 mm encroaching into the cornea with infratemporal 1/3 involvement of the pupil and hair follicles on the surface. With this, we came to the diagnosis of right eye grade 2 limbal dermoid and meridional amblyopia. So we did a ASOCT to rule out the extent of the lesion and MRI orbit to rule out the involvement of recti muscles. So this is his ASOCT, which shows a hyperreflective homogeneous echo with backshadowing. And the MRI orbit confirmed the presence of the mass and it ruled out the involvement of recti muscles. So we decided to go ahead with the procedure of dermoid excision with tectonic lamellar keratoplasty or penetrating keratoplasty with amniotic membrane graft under general anesthesia under guarded visual prognosis. So this is a surgical video. Here we can see that we have made a conjunctival incision. Then the dissection of the plane was done. Tissue was hooked and tied. Then the conjunctival half of the mass was excised. After that, the limbal dermoid was excised. While clearing up the limbal dermoid in the infratemporal quadrant, a small outpouching was noticed. And then we proceeded with superficial keratectomy. But at the region of this outpouching, cornea was perforated and the procedure was converted into penetrating keratoplasty. After that, the graft tissue was sutured. Then the phoneal dissection of the mass was done. Inferior rectus muscle was hooked and kept intact. The whole of the conjunctival dermoid mass was excised in toto. Conjunctiva was opposed with the sutures and glue. And a medial tarsorrhaphy was also done. This is his picture in post-op 2 months, which shows a clear cornea with a clear graft-host junction. So this is his final picture, which shows his visual acuity has improved from CF 2 meter N36 to 660 N36 with -2 diopter cylinder at 160 degrees. So according to this article by Amir Purisoyan, this patient's dermoid comes under grade 2, and accordingly we have done the surgical correction. And our take-home message is to never say never. And thank you.
Questions by the judges?
Okay, Naga, you presented it well. What do you think was the reason for defective vision for this patient?
Ma'am, the preoperatively, when we have examined him, he had in the retinoscopy, he had a +2 diopter cylinder, but he was not accepting the same. So we are thinking it's the meridional amblyopia which is caused for the defective vision.
Wasn't the lesion extending to the central area?
No, ma'am, but infratemporal pupil was only involved.
Involved. Was he given any refractive correction before?
Before they have done only patching. No refractive correction was done.
Okay. Suppose a patient had come to you, whether you would have given a refractive correction for the patient?
We would have attempted optical correction along with patching. But if it's not improving and this comes under the management, they have advised the surgical correction.
-2 cylinder and the vision is not improving. Does that mean the vision, you should not give a refractive correction for the patient when the patient is coming for the first time? A patient is coming to you with -2 diopter cylinder. You have tried and the vision is not improving. Okay, what does that mean?
It's not accepted. It's amblyopic.
Is amblyopic. So will you give a refractive correction for the patient, or will you give a patching alone?
We will do both.
Both. You should give both. Right. Even if the vision is not improving, you have to give astigmatic correction along with patching. Then only the vision will improve. Okay. Do you have any differential diagnosis for this patient?
Because of the presence of this hair follicles and all on the surface, the diagnosis is confirmatory that it's a dermoid. But we have the other differential diagnosis that we usually think are any granulomas, any foreign body granulomas, any presence of any keloid, like that. But no such history was there.
Okay. So surgery is done. Do you think the cornea will remain clear? Do you expect any trouble for the patient to occur later?
Conjunctivalization of the cornea can happen, and he has that in the last visit.
It does. Yeah, like right now the patch is relatively clear. Can you expect any mechanism by which the cornea at that area may become hazy later on?
Any graft rejection or graft failure?
Okay. Anything else? That is right. Graft rejection can occur. Anything else? It's a large area. What else is lacking at that area?
Limbal stem cells.
Yes. What can it lead on to?
Conjunctivalization.
Conjunctivalization. Okay.
Good presentation, Annika. And did you see that the conjunctiva's color was different at the base of the hair follicles? Did you notice that? No. Yes. What is happening with that? That's a food for thought for you to go back home and read about. There was a change in the color of the conjunctiva right under the follicles, at the base of the follicles. No, at the base of the hair follicles.
He had lower retraction pre-op also, so maybe due to exposure, due to inflammation.
The hair follicles were seen not in the lower part, it was seen in the temporal part, just adjacent to the limbus.
Did you come across any ocular motility in this patient post-operatively?
His extraocular movements were full.
Full. Did you check for any pre-auricular attacks? Any other things? Spine? Did you check?
Yes, sir.
No other systemic abnormal. Absolutely normal. Spina bifida, no pre-auricular attack, nothing.
No tags, no fistula.
Have you seen?
Yes, sir.
Yeah, okay, then good. Very good presentation. Very nice.
Thank you, Dr.
By the way,
Anika.
there was keratinization of the conjunctiva at the base of the hair follicles.
Sorry for the interruption in between. Shaji sir missed a token of appreciation. May I request Dr. Varghese Joseph to hand over the token of appreciation to Dr. Shaji Angan. Thank you, dear sir, for spending your valuable time with us. Our next presenter is Dr. Binuja, postgraduate from Government TD Medical College, Alapura.
Good evening. Today I am going to present a case of 23-year-old male, an immigrant working in a resort, came with sudden onset of pain, redness and defective vision in left eye 2 weeks back. For the above symptom, he was consulted in the nearby hospital and it was treated with 2 topical medication. But the defective vision was gradually progressive in nature and he complains of floaters. Hence, he got referred to here. There was no history of flashes of light and no history of contact with pets. Other negative history were not there. Past history, no history of contact with TB or TB in the past. And coming to the personal history, he took mixed diet and he regularly takes food from the hotel. He was a chronic smoker and occasional alcoholic, belongs to lower middle class family. General examination and systemic examination were within normal limit. Coming to the ocular examination, right eye vision was 6/6 with anterior segment and posterior segment within normal limit. Coming to the examination of the left eye, vision was counting finger half meter without any improvement. With pinhole, color vision could not be assessed. Lid and conjunctiva was normal. Cornea shows fine fresh capes over entire endothelium, more in the inferior half. Medium to large size fresh capes arranged as clumps in the inferior half seen. Anterior chamber shows +3 cells and 3+ flare. Iris shows multiple nodules distributed throughout the iris, suggestive of Busaka nodules. Pupil were mid-dilated pharmacologically with absent reaction. Lens were normal. Anterior vitreous phase show 4+ vitreous cells and 4+ haze. Coming to the fundus examination, media was very hazy due to severe vitritis and anterior chamber reaction, hence details could not be assessed. With indirect ophthalmoscope, inferiorly we could see dense clumps of exudate on the vitreous. Intraocular pressure with applanation tonometry, right eye were 14 mm HE and left eye were 10 mm HE. From the above clinical picture, we came to a provisional diagnosis of acute granulomatous panuveitis left eye, with the most probable etiology to be as toxoplasma, bacterial endophthalmitis, and tuberculous panuveitis. All the necessary investigations were done and it turned out to be negative, with B scan shows severe vitritis, no RDs and CD underlying it. So we started to treat the patient with prednisolone acetate 1% eye drop, homide, and empirically we started tab azithromycin and put on in systemic steroid injection DEXA for 5 days. But even after 5 days, there were no improvement at all. We repeated all the tests and there was a rise in WBC count to 17,000. So we suspected again bacterial etiology and put on to antibiotic injection meropenem. Vitreous strap was dry and aqueous strap was taken for culture but turned out to be negative. Intravitreal and vancomycin and ceftazidime were given. But even after 2 days, there were no significant improvement at all. But later, when we examined the patient, we saw a yellowish whitish lesion with well-defined margin as seen in this video, lying on the surface of retina and position was shifting with change in head posture. We suspected migrating granuloma or encapsulated parasite and we made that it could be a parasitic endophthalmitis. So we started with tab albendazole 400 mg BD and restarted systemic steroid after 2 days. And dramatically the patient showed improvement and it was this day 5 and day 10 picture after starting the albendazole. In day 10 his vision improved to 6/9 with significant decrease in vitritis. Hence our final clinical diagnosis was parasitic endophthalmitis with most common etiology to be as toxocariasis. But unfortunately this doesn't last long. 3 weeks later he came with complaints of flashes of light in the same eye and on examination there was rhegmatogenous retinal detachment with a break at supratemporal quadrant. Patient was reported for RD surgery. Hence toxocara is a rare infection which is caused by Toxocara canis and canti. It exists in 3 forms. And this is a journal which suggests treatment of albendazole and steroid can improve. Thank you.
What was the fundus finding when you were able to see the fundus?
So initial days we couldn't see the fundus, but after giving one dose of intravitreal vancomycin, there was we could see that very slightly the vitritis decreased, and we could see a encapsulated granuloma-like thing, and it was shifting. Actually encapsulated parasitic something or granuloma. We couldn't identify it because it was very hazy and there was severe vitritis.
In the vitreous. It was
Yeah,
seen
in the vitreous. It was not in the retina. It was in the vitreous, and it was moving. Even with change in head posture, it was moving. We considered toxoplasma because the age of the patient was 23 and it was a unilateral pan-uveitis for this patient, and toxoplasma is one of the most commonest cause for unilateral posterior uveitis. No, pan-uveitis, yes. Posterior uveitis is one of the most common.
What else? Bacterial and ophthalmic.
Bacterial is because we suspected because he was a immigrant worker and he was a chronic smoker as well as and we constantly ask about whether he is using any IV drugs, but he didn't said that. So we suspected some endogenous endophthalmitis by IV drug initially.
Was there any evidence of IV
No,
drug abuse?
there was no evidence. We examined.
A healthy young man, no
Yeah.
indwelling catheter, has never been hospitalized, no septicemia.
No, there was not there.
At that point, severe panuveitis, granulomatous panuveitis, any other differential diagnosis you should consider?
In this patient,
Unilateral, can become
Behçet's
bilateral.
disease, posterior uveitis.
Any history of chickenpox?
Viral.
If there is a history of chickenpox with severe vitritis, severe anteruveitis,
Viral.
what should you think of?
Any vasculitis lesions or something like that.
So you said toxocara, and you saw a moving ball in the vitreous. Is that the presentation of toxocara?
No, actually toxocara most commonly it can present with posterior granulomas and granuloma.
Exactly.
It is
so it is on the retina,
Retina.
and it's a non-mobile stuff.
Yeah.
So you saw a mobile.
mobile thing, but with chronic he present with endophthalmitis.
So you are right in a way. What other cysts can present something like that? A mobile cyst in the vitreous moving around.
Hydatidus.
Cysticercosis. So you combine the findings of cysticercosis with toxocara together. That's exactly what happened.
Any exposure to the pet animal?
No, sir, no exposure to pet. No. B scan, you can do B scan, and we could see some calcification or scolex inside.
Did you do that in this case?
B scan we did, sir.
What is the finding?
It was only severe vitritis. We couldn't see any cyst-like thing.
And for once the things cleared, you didn't see any granuloma.
No.
So how can you say that it is toxoplasma? I mean, toxocara granuloma or even
It
hydatitis?
was just a clinical because when we given the albendazole BD, immediately after 2 days itself, the patient starts to show improvement along with steroid.
So let me put it. Sorry.
What will happen in case of cysticercosis if you give albendazole alone without giving the?
It will increases the inflammation because it can release. If the parasite will die, it will increase inflammation and toxicity. So we always have to combine with systemic steroid rather than giving albendazole alone. Albendazole alone, if we are giving, it will increase the inflammation.
Any other site for cysticercosis other than posterior segment? In the anterior segment, where will you see?
Anterior segment
Where will you see?
can be seen.
Anterior segment, some cyst I will see somewhere.
Ankles and eye.
Thickened muscle.
Muscles. Thank you.
Thank you, Dr. Binaja, for that wonderful case. May I request Dr. Sumaya Muhammad Ali from Chaitanya Eye Hospital, Thiruvalla to present the case. Next presenter is Dr. Shilpa.
Good afternoon, everyone.
A case of elusive deviation. Here I am presenting a case of a 20-year-old female patient who came to her OPD with the complaints of inward deviation of the right eye and double vision for the last 3 days. She mentioned similar episode 1 month back which resolved itself after 2 weeks. There is no history of trauma, systemic illness, no history of any numbness, weakness, paresthesia, no history of any headache, loss of consciousness and vomiting. But she reported more use of screen time due to online classes. Her past ocular history, medical, surgical history, personal history, general examination, systemic examination, including the cranial examination, was absolutely normal. Her vision noted to be 6/6 and 6 in both eyes, and intraocular pressure noted to be within normal limits in both eyes. Coming to ocular examination, on orthoptic evaluation, Hirschberg corneal reflex indicated 15-degree esotropia in right eye. Her ocular movements were full, normal saccades, no nystagmus noted. Cover test, uncover test, alternate cover test, and alternate showed alternate esotropia with right esotropia. Prism bar cover test showed 35 prism diopter with base out prism, esotropia, both near and distant, and also with either eye fixing. There is no AV patterns noted. This shows her ocular movements are full in all directions. Her anterior examination and fundus evaluation was within normal limit. So, given her condition, we came to a probable diagnosis of it may be a case of acute comitant esotropia. We sent investigations like thyroid function test and ocular myasthenia gravis workup, and advised MRI brain with contrast and neurology consultation. Surprisingly, after 1 week, she came back with reports. All her reports within normal limit, and on evaluation, there is a minimal residual esotropia of about 8 to 10 degree. So, the differential diagnosis of this case include acute comitant esotropia, cyclical esotropia, or it may be decompensated esophoria. Up to March 2022, same findings are, she again had diplopia and squinting, for which she consulted another hospital, but she came to in May 2022 with right esotropia of large angle deviation of about 50 to 60%. So we re-evaluated her with a repeat MRI and neurology opinion, were absolutely normal. Despite routine follow-up and left eye patching, and there is no remission and her stereopsis was decreasing, we went ahead with surgery. So right eye medial rectus resection of about 6 mm and lateral rectus resection of about 8 mm performed. She was under regular follow-up for the last 1 year. She is 6/6 and 6 orthophoric until now. So we came to the final diagnosis of it's a case of acute comitant esotropia. How we reach the diagnosis? Acute comitant esotropia is not cyclical, although it may be initially intermittent. It has been categorized by Buren and Miller into 3 categories. Type 1 is swan type. It is due to interrupted fusion or artificial disruption of fusion by monocular occlusion. And type 2, which is idiopathic, which is Buren-Franchitti type, which may be precipitated by any physical or physiological stress and is demonstrated by large deviation, small refractive errors. And Birchowski type, which is associated with moderate myopia or might result from excessive near-work activities. Rather than the 3 types of comitant deviation, decompensation of pre-existing phoria or monofixation syndrome has been reported, but our patient has no such features. And there is an entity called cyclic esotropia. It is a rare entity. It usually takes 48 hours cycle, 24 hours of squint and 24 hours of orthophoria, but our patient has not such features. Excessive smartphone usage is also reported as a cause of acute comitant esotropia in adolescents. So we came across the salient characteristics of acute comitant esotropia. It's an acute onset, concomitant, non-accommodative esotropia with accompanying diplopia, and onset is more than 5 years of age with no tendency for spontaneous resolution, and the surgical outcomes were highly favorable surgical outcome for those with deviations of greater than 20% diopter. How we worked the case? At first, a case with a large angle deviation, we had to thoroughly rule out the neurological causes, and the management plan include surgery and the follow-up. Surgery was required to re-establish the ocular alignment in all patients described to date. The follow-up was needed because there is delayed appearance of brain tumors were noted in patients who underwent surgery. That is 18 months even after surgery, the patient may present with brain tumors. So re-evaluation with neurological re-evaluation is necessary in all cases of acute strabismus, even following successful surgery. Thank you.
Okay, Dr. Sumaya. Nice presentation. So when a patient is coming with acute onset of esotropia, what all conditions will you suspect?
First of all, we had to rule out any neurological causes.
So what finding will you look for in such a patient?
First, any lateral abducens palsy is one of the most common. If a young woman appear, a 20-year-old woman,
Okay, let us take it as lateral rectus palsy. So how do you examine? What finding will you elicit?
there is abduction limitation.
Abduction.
But here in this case, abduction is full.
Okay. So will abductions or versions which are more likely to pick up LR palsy if it is very minimal? Will you look for ductions or versions? What are ductions? What are versions?
Ductions are uniocular movements and versions are binocular movements.
Okay. If it is a very minimal or -1 restriction or limitation of movement, ductions or versions which will pick up?
Ductions will.
Sure. Okay. So what is the, why do you want to do, what is primary deviation and secondary deviation?
Primary deviation when the non-deviating eye has the same angle of deviation and the.
In which condition you get primary deviation and secondary deviation same?
In concomitant deviation.
Okay. So in paralytic or restrictive?
Primary deviation is not equal to secondary deviation.
So which is more?
Concomitant.
Okay. So a patient with minimum LR palsy, what will be the complaint of the patient? For near or distance? When will they have more of diplopia?
Distance.
Distance. Okay. So suppose a patient is, you said that you evaluated the patient for myasthenia. What all tests did you do? Clinically bedside, what all evaluations will you do when you are suspecting myasthenia?
Eye score test
and any other test?
Tensilon test will not perform.
Tensilon is not done bedside. So simple, what is a simple OP procedure that you will be testing for?
Drooping.
So in such a patient, what fundus, when you are doing a fundus examination, what finding is expected usually? What are you looking for?
Actually, we look for any papilledema in case of idiopathic intracranial hypertension. We can notice in papilledema.
Only in idiopathic intracranial hypertension you will get papilledema? What is papilledema?
Papilledema, bilateral optic disc edema.
Suppose it is bilateral optic neuritis, will you call it as papilledema? In papillitis also sometimes you get bilateral disc edema. Will you call it as papilledema?
Due to increased intracranial hypertension.
Why do you get LR palsy in a case of elevated intracranial pressure? What is the reason?
Abducen nerve.
Why does it happen? It's called a false localizing sign. Why do you get it? What was the surgery? Can you just show the previous slides? What was the surgery done?
Medial rectus recession and lateral.
Slides. Which refractive error produces esotropia?
Normally in Belchowski, Francis.
Which refractive error is associated with esotropia?
It's accommodative.
Refractive error.
Refractive hypermetropia.
Okay. Just take the previous. What was the surgery done?
Medial rectus recession of 6 millimeters and lateral rectus.
And lateral rectus?
Resection.
Ah, yeah, it's a resection. Okay.
Thank you, Dr. Somaya. May I now request Dr. Shilpa from Pushpari Medical College, Thiruvalla, to present her case.
Good afternoon to all. Myself, Dr. Shilpa, PG resident PIMS. My case is preceptor cellulitis, the great masquerader. So, an 8-month-old female child was born with complaints of swelling left upper eyelid since 1 week. So, history of presenting illness. The child was brought to emergency medicine by parents with complaints of swelling of left upper eyelid noticed since 1 week. Swelling was acute in onset, progressive in nature, and associated with pain. There was a history of fever 5 days back, high grade in nature, which subsided on oral medication. Child was started on oral antibiotics when she initially presented to OPD 3 days back. As there was no improvement in symptoms, she was again presented to emergency medicine. There was no history of any trauma, no history of any insect bite, no history of frequent nasal blocks or upper respiratory tract infection, no history of discharge, redness or watering from eyes. Past history, no history of similar illness in the past. History of recurrent ear infections requiring hospital admission and IV antibiotics 3 months back. General examination was within normal. Systemic examination was unremarkable. Coming to examination of orbit, on inspection, erythema and edema of left upper lid, supralateral to lateral canthus was there. Mild dystopia of left eye. There was no proptosis, no ptosis, no evidence of any engorged veins, no visible pulsation. Skin over the swelling was normal. Palpation, there was a tense, tender 3 × 2 cm swelling, supralateral to lateral canthus. There was a mild inframedial dystopia measuring 2 mm vertically and 1 mm horizontally. The swelling had a well-defined margins and firm consistency with a localized rise of temperature. Orbital margins was intact. Intonation with fingers was possible in all 4 margins. There was no resistance to retropulsion. There was no thrill or pulsation. No regional lymph nodes was palpated. Auscultation, there was no bruit. Ocular examination was within normal limits. Anterior segment and dilated fundus examination was all within normal limits. So, considering the clinical presentation, the first TD we were thought was in favor of an infective pathology like a preceptor cellulitis, which is the most common cause in case of a child like this. We also put in mind other possible differential diagnosis like an inflammatory one, a vascular one, or lastly a neoplastic one also. We did a hematological evaluation which revealed a mild anemia and an elevated total count and elevated ESR and CRP. We did a peripheral smear which showed mild microcytic hypochromic anemia with no abnormal or immature cells. So, as a clinical presentation and the workup was favoring an infective pathology, we went ahead with the diagnosis of a preceptor cellulitis and admitted the patient and started on with IV antibiotics. Due to tense nature of the swelling and the child was not responding to the IV antibiotics as suspected, we did a USG orbit which showed a 3 × 2 × 1 cm size collection supralateral to the globe, and we did a USG gated aspiration which yielded blood which was sterile. It was a dilemma and we decided to do an imaging to rule out other possible etiology. We did a CT brain and orbit which showed an ill-defined heterogeneous lesion involving the lateral wall of the orbit. There was a bony erosion and indentation of lateral rectus and abutation of the globe was there, and there was loss of fat plane. There was another lesion involving the anterior ethmoid sinus walls and nasal process of the frontal bone. So in view of these CT findings, we had to rethink our differential diagnosis more in favor of a neoplastic etiology. So we did a contrast enhanced CT which confirmed the findings of plain CT and also showed contrast enhancement favoring a neoplastic etiology. So considering the age and the characteristic lytic lesion pattern, we streamlined our differential diagnosis to the possibility of a Langerhans cell histiocytosis or a neuroblastoma METS. We did a skeletal survey which showed vertebra plana, that is at the level of T10 to T11 we can see the flattening of vertebra which is vertebra plana. In fact, the most common cause of vertebra plana in infancy is Langerhans cell histiocytosis. We did an USG abdomen which was normal, chest x-ray, all systemic examination was within normal. So, we referred the patient to RCC for histopath and further treatment. Histopath and electron microscopy revealed features of isolated Langerhans cell histiocytosis with bone involvement and no other systemic involvement. Patient is currently on cycles of wind blasting along with oral prednisolone and is on follow-up with no recurrence. So the take-home message I want to convey is that all orbital inflammations are not as simple as it seems. Keeping an open mind and a team approach is crucial if it is a pediatric age group, and imaging as and when needed should be there. And a timely diagnosis and intervention can save an eye and also save a life. Thank you.
What other serious conditions can masquerade as an orbital inflammation?
Ruptured dermoid cyst, and then
Apart from what you have mentioned. Serious.
Serious rhabdomyosarcoma, Ewing's sarcoma, Wilms tumor. This can also masquerade as a preceptor cellulitis.
In children, anything else in children?
Sir? An idiopathic orbital inflammatory disease, pseudotumor.
What are the other tumors that you see in pediatric age group in the orbit?
And neuroblastoma mets, then rhabdomyosarcoma.
Okay.
Then
any other malignancy can have an orbital involvement?
Yes, ma'am. In case of like Ewing's sarcoma,
yeah,
Wilms tumor.
Okay. Other than that, any hematological?
Leukemia.
Leukemia. In what all ways leukemia can affect the eye in a child? What are the different presentations of leukemia as far as an ophthalmologist is concerned?
Or clinical
orbital as well as fundus, anterior segment, you can have many presentations as far as leukemia is concerned. So tell me about the orbital presentations.
You can have proptosis.
Yeah.
Ptosis.
What is scleroma?
That is the tissue, normal tissue in a other position.
Scleroma. Okay. What is can leukemia have any muscle involvement, extraocular muscle involvement?
Yes, infiltrating into the muscle, it can have a EOM restriction and loss.
Not restriction alone, it can have something like a hypertrophic muscles. Okay, it can present as proptosis. Fundus, in adult patient also we can have
Mets
fundus.
can be there.
Okay. Okay. So usually erythema of the lid, what is the diagnosis? What are the vascular lesions of the orbit in a child?
Carotid cavernous fistula.
Child. Newborn, like children, what are the vascular anomalies?
Capillary hemangioma.
Capillary as well as capillary and cavernous also later. Then
phangioma. Varices.
Okay, what are the other tumors? Suppose a child is having neurofibromatosis.
S-shaped deformity of the lid.
It is due to the neurofibroma itself. What are the other manifestations of neurofibroma related to the eye?
Nodules.
Okay.
And ectropion is
anything related to the optic nerve? Anything related to the bony part of the orbit?
What was the total count?
12,004.
Thank you, Dr. Shilpa. Next, Dr. Jayalakshmi R from Believers Church Medical College will be presenting.
Good afternoon. Presenting the case of a 43-year-old male patient who was admitted in the Department of Endocrinology for uncontrolled diabetes mellitus. He was diagnosed to have cerebellar hemangioblastoma and surgical intervention was planned, and he was referred for an eye checkup. History of present illness. Patient wanted a routine eye checkup of right eye. No complaints of right eye vision. Left eye artificial eye implant was present. No history of flashes, floaters, glare, pain. No history of distortion of images, transient blurring of vision. No history suggestive of visual field defect. No history of trauma to right eye. No history of use of spectacles. Past history. In 2009, left eye enucleation was done. Patient had progressive blurring of vision left eye since childhood, and blurring worsened and consulted Aravind Eye Hospital at the age of 27. Was diagnosed to have left eye staphyloma and underwent enucleation at Little Flower Hospital. Patient was diagnosed to have diabetes mellitus in 2015. It is uncontrolled. Right eye cerebellar hemangioblastoma status post surgery. Revision surgery was done thrice in the past, and now patient has got recurrence for 4th time and is planned for surgery in Trivandrum. History of cauda equina lesion with diffuse meningeal enhancement and multiple cystic lesions in spine, kidney, pancreas. Active lesion. It is von Hippel-Lindau syndrome. Family history. I took a detailed family history, and paternal grandfather had history of early death, but details were not known. And the patient had 2 elder brothers, out of which the eldest brother was diagnosed to have von Hippel-Lindau disease and expired during a brain surgery. And patient's father's sister had 4 children diagnosed with von Hippel-Lindau disease. Then general examination was within normal limits. Systemic examination, central nervous system, power of upper and lower limbs, grade 5. Swaying was present to both sides and cerebellar signs were positive. And ocular examination, right eye, vision, extraocular movements fully painless in all directions. Vision unaided was 6/6, N6. Color vision was normal, and anterior segment examination was normal. Then right eye fundus examination, media was clear, disc size and shape normal, with cup disc ratio 0.5, with healthy neuroretinal rim and well-defined margins. Vessels rising from center of disc, branching dichotomously with AV ratio 2:3, and dilated and tortuous artery and veins noted infratemporally. Macula was FR+. 2 orange red color round sessile mass of size 1.5 disc diameter and 1 disc diameter was seen in the infratemporal quadrant. Surface of the mass appeared irregular. Dilated tortuous feeder vessel seen entering and draining vessel emerging from the mass. No fibrovascular proliferation was seen. No dot blot hemorrhages or vitreous hemorrhage. No cotton wool spots. No hard exudates around the mass. No retinal detachment noted. This is a fundus photo of right eye. Diagnosis: right eye retinal hemangioblastoma, left eye status post enucleation, implant in situ, von Hippel-Lindau disease. Patient was advised photocoagulation, but he was under follow-up for cranial hemangioblastoma in another hospital, so he wanted to continue further management there. And then we explained to the elder brother. Eldest brother expired. The elder brother was not diagnosed with any syndrome, so we explained to the brother about the genetic predisposition, and a detailed eye examination was done, and the elder brother best corrected visual acuity was 6/6 both eyes, and a retinal capillary hemangioma was present in the left eye infratemporally. And then a photocoagulation was done for the lesion. MRI showed cystic lesion in the left lobe of cerebellum with minimal edema, and renal ultrasound was within normal limits. Then von Hippel-Lindau disease, it is a rare autosomal dominant neoplastic disorder in which multiple benign or malignant tumor and cysts with specific histopathological features develop in tissues of central nervous system, in brain, spinal cord, inner ear, retina, visceral organs like kidney, adrenal glands, pancreas, and epididymis. Retinal hemangioblastomas can be the presenting manifestation of the systemic illness. The role of ophthalmologist can be potentially life-saving in educating the patient, and a screening of family members is also important in this illness.
So what's a differential diagnosis?
Sir, retinal artery macroaneurysm, then racemose hemangioma, cavernous hemangioma, Weber-Mason syndrome.
How do you differentiate? How did you come to a diagnosis that it's just because they wrote it as hemangioblastoma, so you made a diagnosis of hemangioblastoma of the retina also, or is it retinal hemangioma? What you've written as diagnosed as
Hemangioblastoma.
yes. Is it retinal hemangioma or retinal hemangioblastoma? And how did you differentiate it from others? You said differential diagnosis, but how did you differentiate?
So in retinal artery macroaneurysm, usually there will be dilatation of the artery, usually seen in the first three branches, seen in the posterior pole, but here the lesion was in the periphery and there was a round orange red colored mass seen. In retinal artery macroaneurysm, such a round mass is not seen. And then in cavernous hemangioma, usually the lesion is grape-like cluster, seen more near the optic disc. Then in racemose hemangioma, there will be arteriovenous malformation, connection between the artery and vein. There will not be a dilatation or a round mass won't be seen.
Phacomatosis.
Phacomatosis develop. There will be systemic group of diseases, systemic illness associated.
Okay. What is Linda's disease? What is von Hippel? Linda's, what is von Hippel? You told no one diagnosis here. Von Hippel.
Von Hippel, Linda's disease.
What is Linda's? What is von Hippel? Like weak age. What,
both of them are scientists.
What is von Hippel? Von Hippel is only involvement of the eye. If you see in the brain, hemangioblastoma, it is Linda's. Okay, you got like one weak age syndrome. Hardas means exudaretinal, multiple exudaretinal detachment. Here, involvement von Hippel means same feeding vessels and arteries. That's why you will diagnose it, not like, yeah. How will you manage?
Depending on the size of the lesion, it is.
You can do
photocoagulation, sir. If it is, if the size is more
What's the
than.
BP of the patient? Blood pressure.
Sir?
What was the blood pressure of the patient?
110/80.
It's not retinal macroaneurysm. Chance it's more common in which age group? Retinal macroaneurysm. Male or females?
Females.
Unilateral or bilateral?
Bilateral.
Where else can affect other than brain?
Spinal cord, then adrenal, renal pheochromocytoma, then epididymis.
Any urine test for?
Catecholamine. The first manifestation for VHL can be a retinal hemangioblastoma. So, this yes.
Thank you, Dr. Jayalakshmi. Now I request Dr. Khalid from Amrita Medical College, Cochin to present the case.
Good evening, everyone. This is Dr. Khalid, junior resident from Amrita Institute of Medical Sciences. So, a 53-year-old lady presented with redness and pain in the left eye since 3 weeks, diminution of vision in left eye since 3 weeks, watering since 3 weeks, whitish opacity over cornea since 2 weeks. So, 53 years old female hailing from Kollam, homemaker, presented to OPD with alleged history of injury with chemical while cleaning the floor. She reports of rubbing her eyes and washing with tap water after the incident. Next day, she noticed redness and watering from the eyes. She also gives history of foreign body sensation and mild pain. So, 2 days later, she went to some local hospital and was given some oral analgesics for pain and was referred to a higher center. So, she also noticed her vision was dropping day by day and a whitish opacity started to develop over the cornea. She also gives history of increased sensitivity to light. She was then referred to Amardeep Eye Hospital and was diagnosed as a corneal pathology and was started on topical and oral medications. 2 weeks later, she was referred to Amrita for further management. So, past ocular history, first she was started on topical antibiotics like moxifloxacin, and then 2 days later she was started with natamycin, and that medication was continued for 2 weeks. So, for 2 weeks she was using natamycin hourly, moxifloxacin eye ointment VD, atropine, lubricants and oral analgesics. So 1 week, after 2 weeks, they had started voriconazole eye drops 1 hourly and added a systemic antifungal, itraconazole 100 mg BD. And history of past medical and surgical illnesses, she only has history of diabetes mellitus since 4 years. And general examination, everything was within normal limits, moderately built, nourished, conscious, oriented, and the systemic examination was normal. Vital 78 beats per minute and BP was normal, 138. Systemic examination, severe CNS, respiratory, everything was on normal limits. Local examination, right eye vision was 6.9 unaided, improving to 6.6 parts, intraocular pressure 14 mm Hg. Extraocular movements were full and painless in all cases. Eyelids, eyelashes, conjunctiva, cornea, everything was under normal limits. AC, there was no activity, quiet. Iris was normal in color and pattern. Pupils were brisk, and lens showed some early lens changes in right eye. In the left eye, vision was PL plus PR accurate, not IOP was not getting. EOM was full and painless in all cases. Eyelids, there was normal. There was a mild matting of eyelashes in the left eye, and diffuse conjunctival congestion was there, and discharge was there. And in the cornea, a large ring-shaped 5 into 6 mm corneal ulcer with edematous edges in the central cornea. And there was a small grayish white opacity 2 into 2 mm, and there was a mild stromal edema. Apart from that, then there was a thick whitish hypopyon in the anterior chamber, which was immobile, and it had a little convex border. And so iris details were a little hazy, and lens was not seen, and pupil was mid dilated due to atropine. And posterior segment in the right eye was within normal limits. This was normal. Vessels in periphery was normal. Left eye we were not able to see. So investigations, we had routine investigations, blood workup and all was within normal limits. WBC was slightly elevated. CRP was slightly elevated, but not very significant. So ASOCT, there was epithelial loss and then stromal infiltrate, and some endothelial exudates were there, and with some backshadowing. In KOH and KOH smear, the fungal filaments were there, showing septate fungus. And fungal culture, there was some growth of fungal filaments on SD agar after 5 days. So we clinically it was looking like a fungal keratitis. So we went ahead, it was referred from it was already treated previously, and then it was not resolving. So it had they referred it to Amrita Hospital. So looking at it was a pretty deep infiltrate. So we went ahead and did a penetrating keratoplasty and sent the excised cornea for histopathological examination. So it is a pretty simple case, but what we found out was that in the excised corneal specimen, the histopathological examination also showed Pseudomonas aeruginosa. So it is a pretty simple case, but what I want to tell you is, if the corneal ulcer is treated and referred, it is little difficult to clearly differentiate from fungal and bacterial. And in many of cases, sometimes it can be a co-infection also. And it is better if the ulcer is severe, it's more than 5 mm, and it's a little deep, better to go ahead with a surgical management early. So penetrating keratoplasty was done, and this was 1 day post-op. Some exudative matter was there, and 2 weeks post-op it cleared up a little bit, and centrally that exudate was there, and lens was little cataractous.
Can you show that picture, ulcer picture? Go back.
I'm sorry, sir, it's not very clear, but yeah.
What is that black mark? It is the iris?
No, that is a camera.
Perforated or
No, that's the camera thing, sir. It's not on the cornea.
Yeah. Very thick hypopyon.
Thick hypopyon and ulcer, convex hypopyon.
In all cases, we will do therapeutic penetrating keratoplasty.
Not all cases, sir.
Then why? What is the indication for this?
It was the ulcer was larger than 5 mm, and it was very deep ulcer, and it had endothelial exudates also.
What are the other options now? Because of my center, I don't have cornea. I am not a corneal surgeon. I cannot do penetrating keratoplasty. I know. You should know the pros and cons. What is the indication? What are the other options other than therapeutic keratoplasty?
First, we can start on topicals, sir. If it is not responding, we can go to intracameral, intrastromal.
When patient is landed to your hospital, he is on topical voriconazole, natamycin, topical antifungal, everything they pumped out. Yes or no? Yes. He's sterile. He came. SDA, you got after 5 days, report. I don't know. 5 days we may not get. How many days minimum we need for report fungal culture? 5 days can you get?
Yeah, we actually it can show up in 3 days or 7 days. Like culture will take a little bit of more time.
Yes or no? The fungal elements may be the true because already he is on moxifloxacin. He is the sterile now. Yes or no? If you want to scrape, you have to stop the medication for?
And for 1 or 2 days and then scrape.
24 hours. 2 days means we will perforate tomorrow morning. Yes or no? Then what are the other options other than this? One of the already they explain.
Intracameral injections we can.
Intracameral
and intrastromal.
Wash we can give. Otherwise, intrastomal injection you can give. Other if you want the patient is not responding, you can do corneal biopsy.
Yes, sir.
Yes or no?
Yes, sir.
Then what is the indication here for your therapeutic keratoplasty?
There was a poor response in spite of systemic and topical antibiotics, and the ulcer was severe. It was more than 5 mm, and it was a pretty deep ulcer. So, like it was pretty deep infiltrate. And there was from the patient side also, she was not a very compliant patient, and she was not following the medications also properly. So we like it was better to do a penetrating keratoplasty. No, sir, not immunocompromised. Diabetic, yeah, but from 4 years, but on oral medication only. Thank you.
Which investigation will pick up the fungus in such a case? Non-invasive.
KOH mount we can get, and if not,
any newer equipment?
Confocal microscopy.
Okay. Which other organism will be picked up with confocal?
We can see cysts and trophozoites.
Okay.
Thank you, Dr. Khalid. Now I request Dr. Adira Manoharan from Sri Nethra Eye Care Trivandrum to present her case.
Good evening, everyone. I am presenting case of a 14-year-old girl who has came for annual change of glasses to her OPD. She had no significant history of night vision difficulties or visual field deficiency or difficulty in identifying colors. And her past medical history and past ocular history were normal and were non-significant. She just had a history of spectacle usage for 1 year but not using since 5 years. Her parents had a non-consanguineous marriage and they had no history of defective vision or night blindness. And her personal history was normal and her general physical examination showed normal findings. Vitals were stable and systemic examination of all the systems showed normal findings. On her ocular examination, her head posture was normal and erect and face was symmetrical and she was orthophoric. She had a visual acuity of 6/24 in the right eye, which was improved to 6/6 with a cylindrical correction of -3.75 diopter at 10 degree. And she had a visual acuity of 6/12 in the left eye and with a cylindrical correction of -1.50 diopter at 180 degree, it has improved to 6/6. And her near vision acuity was N6 and her color vision and field of vision by confirmation was normal. And her ocular retinal cell examination under torchlight and street lamp examination showed normal findings. And her anterior segment examination also were non-contributory to the diagnosis. And her pupil was reacting to light on direct concentration and near reflex. And her IOP was also normal. This is a fundus picture of the patient which shows normal disc and vessels with a cup disc ratio of 0.4 and healthy neuroretinal rim. And as you can see, the fovea is looking normal and bilateral symmetrical yellow-white flux could be seen which extends from the posterior pole to the periphery, more concentrated at the mid-periphery and sparing the macula. And this is how the flux looks like, which have well-defined border and flat surfaces and which is seen at a level deep to the level of blood vessels, and there are no pigmentary changes also. And this is the fundus autofluorescence of the patient which shows hyper-autofluorescent lesions at the level of mid-periphery, more concentrated, and fovea was paired. And background shows normal autofluorescence. And this corresponds with the fundus picture. This is the OCT of the patient. The first two OCTs, the line scan is passing through the macula and the foveal contour is maintained. And the line scan passing through macula shows normal OCT. And the second two, below two OCTs, the line scan passes through the lesion. And as you can see, when compared with the normal OCT, there is thickening and hyperreflectivity at the level of retinal pigment epithelium, and ELM tending and as well as ISOS junction elevation is there, which gives a sawtooth appearance, but there is no disruption of the ISOS junction. This is a ERG of the patient, which shows normal scotopic, photopic, and combined responses. And coming to the differential diagnosis, our patient doesn't have history of night blindness, and she had normal ERG findings, which rules out fundus albipunctatus, which this is how it looks like. And her macula was looking normal, and ERG was normal, which rules out fundus flavimaculatus. And she doesn't have history of night blindness and any visual field problems, and doesn't have any pigmentary dispersion changes, and she had normal retinal vessels, which rules out retinitis punctata albicans. And her macula was looking normal, and lesions were more arranged in the mid-periphery, not nasally arranged lesions like in familial drusen. And the lesions in my patient were mostly small sized compared to the large white lesions seen in fleck retina of Kanduri. And the diagnosis is both eyes benign familial fleck retinus and simple myopic astigmatism. And the features that distinguish this benign familial fleck retina from other fleck retina syndromes are no visual disturbances or nyctalopia, fundus examination which shows yellow-white flecks from the posterior pole to it can extend to the extreme periphery also, and corresponding findings in the fundus autofluorescence, and her OCT revealing the discrete deposition at the level of RP without disrupting the ISOS junction, and a normal ERG finding. And no active intervention was needed for the patient. Her refractive error was corrected. Both her parents and only sibling were examined and did not reveal any abnormality. And parents were reassured, and he was advised to follow for every 6 months. And coming to benign familial fleck retina, it is a rare autosomal recessive condition due to mutation in the group 5 phospholipase A2 gene on the chromosome 1p36. The parents would be normal but can transmit a mutant gene, and the risk of inheritance is 25% for each child. And the diagnosis of benign familial fleck retina is by fundus pattern recognition, which shows yellow-white flecks sparing the macula, and corresponding findings in the autofluorescence, OCT which shows RP thickening and elevation of the external limiting membrane and ISOS junction without any disruption of the ISOS junction. And ERG would be normal. Hard exudate lesion can be seen in macula also, and it is not retinitis fundus albipunctatus, because the lesions look in fundus albipunctatus there will be it has the same picture as for benign familial fleck retina, but she doesn't have any, but there won't be any history of night blindness in benign familial fleck retina as seen in fundus albipunctatus. And ERG also would be normal in benign familial fleck retina, whereas there will be no abnormal scotopic findings in ERG of fundus albipunctatus. And retinitis punctata albicans also shows night blindness, and ERG findings also would be, there will be scotopic abnormalities, whereas in benign familial fleck retina there won't be any night blindness, and normal ERG findings would be. Retinitis punctata albicans is a fundus albipunctatus is a stationary form of retinitis punctata albicans. ERG findings, the pigmentary changes are seen in retinitis punctata albicans. No pigmentary changes. Hard exudates are hard exudates would be seen at a higher level, below the just below the This was seen at the level of RPE.
Any renal condition?
In Alport syndrome, reflect retina happens.
Anything else?
Drusen.
Thank you, Dr. Adra. We have two more presentations. I request Dr. Aishwarya Xavier from Believers Church Medical College to present the case.
So presenting the case of a 31-year-old female who presented with complaints of blurring of vision in both eyes for past 2 days. It's a 32-week plus 4 days primary with DCDA twin conceived via IVF who presented to the OPD with complaining of blurring of vision of both eyes of 2 days duration. The blurring was mild, non-progressive and persistent throughout the day, and it was more in the left eye when compared to the right eye. There was no pain in both eye movements, no history of any use of spectacles, no history of any recurrent red eye, no associated discharge, itching, redness or photophobia, no history of distortion of images, no history of flashes or floaters, no history of transient obscuration of vision, no history of seeing one object as two, no history of trauma or surgery to the eye, no history of headache, nausea or vomiting, and no history of fever or in history of joint pain, dry mouth or cough with expectoration or pets in the family. In the past history, the patient is diabetic on OHA for the past 3 years and she has subclinical hypothyroidism and is on tab Thyronome, and she has undergone Shirodkar circlage for the present pregnancy. There is no relevant family history, no history of any diabetes or hypertension or any other disease in his family. Then personal history, she has mixed diet, she is anxious about the present pregnancy and she is unable to sleep for the past few days and due to anxiety. There is no addiction, she is a staff nurse and she has been married for the past 8 years and conceived via IVF. General examination, she is conscious oriented in place, time and person and moderately built and nourished with no pallor, icterus, clubbing or cyanosis. There is presence of generalized edema and vitals were all within normal limits with BP or 90/60 millimeters of mercury in the right arm in the sitting position. Systemic examination was within normal limits. On an ocular examination, the head posture was erect, forehead normal wrinkling was present, facial symmetry was symmetrical, gaze were orthophoric, extraocular movements were full, free and plainless in both the eyes. The right eye, unaided, visual acuity was 6/12, best corrected visual acuity was 6/6 and 6. With refraction, we got -1 sphere and color vision was normal. IOP was 23 millimeters of mercury, measured with applanation tonometry at 1 p.m. was not on anti-glaucoma medication. The lids, conjunctiva, sclera, cornea were all within normal limits. The pupils were, the light reflexes were normal. It was brisk with no RIPD. On fundus, the media was clear. The disc color was normal. Cup disc ratio was 0.4 with healthy neuroretinal rim. The disc margins on the right eye, there was mild blurring nasally and inferiorly. There was peripapillary edema of 1 disc diameter present superiorly, inferiorly and nasally. The vessels were normal, arising dichotomously with AB ratio 2:3. At the center of the macula, multiple white, slender, linear lines were seen radiating from the fovea, extending over an area of 3 disc diameters. And inferotemporally, in the mid-periphery, you can see multiple dark spots with surrounding yellow halo, suggestive of Elchnick spots. And there was multiple yellowish, well-demarcated lesions of 1 to 1.5 disc diameters in the mid-periphery with multiple hyperpigmented lesions within it, suggestive of Siegel streaks. And in the left eye, the visual acuity was 6/24 and the refraction, we had -1.5 sphere with best corrected visual acuity 6/6 and 6, and this segment was within normal limit, and the fundus examination was similar to that of the right eye, and except that the disc margins were well defined. This is the fundus photo. This is a close view of the disc as well as the macula. You can see the peripapillary edema superiorly, inferiorly and nasally, and ILM folds at the macula. And here the black arrow points towards Elchnick spots and the yellow arrow or white arrow points towards C-grid streaks. And this is OCT RNFL showing disc edema in the nasal and inferior margins. This is OCT macula showing normal OCT macula. In the right eye, inferiorly and yes. OCT macula was within normal limits. There was no macular edema or any subretinal fluid. So the diagnosis, it is 34 weeks, 4 weeks primary with hypertensive choroidopathy in both the eyes. So on follow-up, the patient was asked to follow up in gynec OPD, but since the BP was normal, she did not go immediately to the gynec OPD. She went after 2 weeks, and over there when she went, the BP recording became 200/120 millimeters of mercury, and she had generalized edema, and they tested for urine albumin and became they got trace urine albumin, and patient had emergency LSES, and the postpartum hemorrhage was also there, for which bilateral uterinatal ligation and blood transfusion was done. And the mother continues to have high BP recordings, and she is currently on 3 hypertensive medications. The generalized edema had resolved, and urine albumin continues to be traced in by testing. And on follow-up, after 5 days postpartum, we did a FUDES examination, and on the right eye there was pigmentary epithelial defect with, and in the left eye there was subretinal fluid. After 5 days, this is after 5 days. In the initial, before delivery, after delivery. Madam, BP in the initial examination BP was 90/60, and on during the delivery and following that the BP rose to 200/120. The patient has got high BP recording, so fluid collection.
We had only choroidopathy, any hypertensive retinopathy? Vascular
Retinopathy
changes?
findings was not there, only
Choroidopathy. No arterial narrowing.
No.
Was there any AV crossing?
No, AV crossings was changings was not there. Normal.
Do you expect?
I expected, but it was not there.
You expect heavy crossing change? What reflects the duration of hypertension and what reflects severity of hypertension in retina? What finding?
Broadening of the light reflex. When hypertension is affecting, then there can be broadening of the light reflex and copper wiring, silver wiring. It's clear.
On the opposite happens when there is
Ischemia.
Continue.
So normally when we say preeclampsia, we expect proteinuria and rise in BP and edema. Sometimes atypical presentation can also happen when the BP is normal And there can be edema and other signs of urine albumin. So the message of this case is that when a pregnant lady presents with end organ damage like hypertensive choroidopathy and if with generalized edema, even if the BP is normal, we have to refer the patient to the gynecology in order to save the life of the mother and the child. We recorded the BP only at certain point in the daytime. Sometimes the BP might have risen at night or something, but yeah, she was a staff nurse and she said that she had recorded the BP at home and it was all normal. Bilaterally, infratemporally, it was there.
Thank you, Dr. Aishwarya. A last presentation, Dr. Lakshmi Parvati from Kerala Medical College.
So good evening. Coming to the history of 22-year-old pregnant lady presented with sudden onset defective vision in the right eye since 2 weeks. It was not associated with pain, redness or watering from the eye. No history of flashes or floaters. No history of headache or vomiting. No history of fever, skin rash, cough or small joint pain. No history of trauma. No history of oral or genital ulcers. There was a history of contact with pets. And she consulted a local hospital and she was referred to our institution since she had treatment from our institution for similar illness 2 years back. Past history. She gives a past history of one episode of defective vision with metamorphosis 2 years back, which was treated and improved with topical and oral medications. No history of diabetes, hypertension, tuberculosis, and no other comorbidities. The family history was not relevant. Personal history, she takes mixed diet, sleep and appetite normal, bowel and bladder habits normal. General and system examination within normal limits. Coming to ocular examination. Visual acuity in the right eye was 636 with pinhole improving to 624. In the left eye was 66. Head posture was normal. Ocular posture was orthophoric. Ocular movements are full in all directions of gaze, both unicular and binocular. Then anterior segment was normal in both eyes, both right eye and left eye. Pupil was brisk in both eyes. Lens was clear in both eyes. Anterior vitreous showed 1+ cells in the right eye, where it was clear in the left eye. Fundus examination. Coming to fundus examination of the right eye, the medium was slightly hazy due to vitreous cells. It was average size disc with defined margins. Cup disc ratio was 0.3. Neuroretinal rim was pink. And retina showed a whitish yellow raised lesion of about 1.5 disc diameter just above the fovea with ill-defined margins, and the lower margin of the lesion showed a blackish pigment. Surrounding retina was normal and vessels was normal, no evidence of sheathing. Macula foveal reflex was dull. So this is the fundus picture which I have already previously described. And fundus examination of the left eye was normal. IOP was 12 millimeters mercury in the right eye and 40 millimeters mercury in the left eye. Color vision was normal, both eyes. So from the above history and the clinical fundus examination, we came to provisional diagnosis of probably reactivation of toxoplasma retinochoroiditis. So we proceeded with her investigations, and all other investigations were normal except for the toxoplasma IgG, which was increased 42.2. So we came to diagnosis of reactivation of toxoplasma retinochoroiditis. So coming to summary, a 22-year-old pregnant lady with sudden onset defective vision in the right eye since 2 weeks, with a past history of similar complaint with metamorphosis 2 years back. General system examination were within normal limits, and ocular examination, the right eye showed visual acuity was 636, anterior vitreous showed 1+ cells, retina showed a whitish yellow raised lesion of about 1.5 disc diameter above the fovea with ill distinct margins, and blood investigation revealed elevated toxoplasma IgG. And considering present state of pregnancy and non-availability of the drug spiramycin, we gave 3 doses of intravitreal injections of clindamycin 1 mg in 0.1 ml and dexamethasone 0.4 mg in 0.1 ml at 1 week apart. 3 doses of intravitreal injections. This is a fundus picture for both pre-treatment and post-treatment. We can see that the lesion has resolved. Patient became symptomatically better, and now she is under our follow-up. Thank you. fundus showed yellow, whitish yellow lesion of about 1.5 disc diameter just above the fovea with ill-defined margins. There was no overlying vessels or there was no vascular sheathing. Then disc and vessels were normal. Macula foveal reflex was done. Media was it was slightly hazy due to anti-vitreous cells. The lesion is approximately 1.5 disc diameter. Episode 2 years back.
Okay, so what is the difference? When you see a yellowish white lesion right there, what's the differential diagnosis? And how did you say that this is Dr. Clark? Clinically, before sending the investigation, how did you come to a differential diagnosis? So I would say this is tuberculosis.
Tuberculosis usually produces choroiditis. Usually it is a choroiditis.
Yeah, you can have similar pictures. Tubercular granuloma involved in the choroid can have a similar picture. Or a metastasis. Sarcoid granuloma. It can respond to intravitreal dexamethasone. Because you gave clindamycin along with dexamethasone. It can temporarily come. But these are the differential diagnoses you should be thinking about. Even I cannot say this is which at this point. But these are the points by which you differentiate different agents. That's why you have investigation.
Thank you, Dr. Lakshmi. Judges, please take a moment to decide our winners. So, first prize goes to Dr. Khalid from Amrita Medical College. Second prize goes to Anaka from Giridhar Institute. She's not here. Must have gone. We'll send her the prize. And third prize, we have a tie. That is Dr. Lakshmi Parvati from Kottayam Medical College and Dr. Jayalakshmi from Believers Church Medical College. Thank you, dear judges, for spending your valuable time with us. We have come to the remaining pages. Please come to receive the participation certificate. I request Jisha madam to hand over the token of appreciations. I request Dr. Binucha.
Just for a clarification, Attention please, just for a clarification, we would like to tell you that we didn't put marks for those students from our own institutes. So we didn't put, myself and Manjit did not put marks for Lakshmi Priya, and other judges also did the same. So this is totally an unbiased result.
Dr. Binocha, Dr. Sumaya, Dr. Shilpa, Dr. Atira Manoharan, Dr. Aishwarya Savior. Dr. Jayalakshmi, Dr. Aishwarya Savior, Dr. Atira Manoharan, the winners first, second and third prize, please come and receive your certificates. We have come to the closing of NETHRAM 2024, indeed a very memorable day for each one of us. We express our sincere gratitude to all of you who have come from far in spite of your busy schedule. We look forward to see you all next year, God willing, NETHRAM 2025.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे